الرحيم الحمد لله رب العالمين والصلاة والسلام على أشرف الأنبياء والمرسلين. Again, we welcome you in the second day of the second Diabetic Food Conference. We are going to start with the first session today. This session talk about ABC of diabetic food. And the modulator for this session, Dr. Maram and Thamr al-Nasr, please welcome them.
السلام عليكم صباح الخير بسم الله والصلاة والسلام على أشرف الأنبياء والمرسلين سيدنا محمد وعلى آله وصحبه أجمعين. First, good morning everyone and welcome on the second day, and we hope inshallah to be enjoy with us with our speaker, our lecture, and we hope inshallah to be very good day today.
Okay, good morning all. Assalamu alaikum wa rahmatullahi wa barakatuh. I'm going to present Dr. Yusuf Al-Tuwajri. He is a pediatric surgery consultant, head of pediatric surgery division at King Abdulaziz Medical City in Riyadh. Diabetic foot ulcer, he's going to talk now regarding diabetic foot ulcers, history, exam, and labs. تفضل Dr. Yusuf.
Assalamu alaikum. Good morning, everyone. I hope you had your morning coffee to boost up your energy as we're about to start our second and last day of this conference. Now, my talk is about the diabetic foot ulcer history examination and labs. But before I start with my talk, I just want to mention some facts and figures regarding the effect of diabetes on patients with diabetic foot ulcer. Oh yeah, so we're on. So 20% of diabetic infection may end up with amputation. Amputation in patient with diabetes is 10 to 20 more common than patient without diabetes. 15% of diabetes will develop an ulcer during the course of the disease. Every 20 seconds, there is an amputation happens worldwide as a consequence of diabetes. 50% of incidence of contralateral amputation in 2 to 5 years after a lower extremity amputation. But the good news is that 85% of amputation can be avoided and prevented by proper pediatric care. So I guess we're taking a break now. Another coffee break, I guess. Okay, we're testing. So if you see the diagram on the left side, the death caused by diabetic foot ulcer is equal or exceeds the death caused by prostate cancer, breast cancer, and non-Hodgkin's lymphoma combined. And if you see in the other diagram, you will see that the mortality rate caused by amputation exceeds that of many cancer. So this implies a great challenge for all of us to develop a prevention program to act against amputation. The pathogenesis of diabetic foot ulcer, usually patients start with neuropathy, a small tiny ulcer that grows bigger and deeper and then jump to the next step, which is peripheral vascular disease, and then the infection kicks in and then patient end up with amputation. Nevertheless, peripheral vascular disease and neuropathy can be an isolated factor leading to limb loss and amputation. So when you evaluate your patient, you evaluate as one unit. Most of our patients with diabetic foot ulcer comes with a package of many comorbidities, usually uncontrolled diabetes, A1C to the roof, uncontrolled hypertension, end-stage renal disease. And then we jump to the local factor caused by the systemic problems. The patient comes with the neuropathy, the most common cause of diabetic foot ulcer, surgical deformity, history of peri-ulceration. All these factors can lead to diabetic foot ulcer. So this draw shows the journey of most of our patient with diabetic foot ulcer, the triad of amputation. The patient with neuropathy comes with motor dysfunction, sensory loss, and autonomic dysfunction. These all can lead to Charcot foot deformity, and patient become more prone for ulceration and may end up with amputation. Also vascular disease, whether it's macrovascular or microvascular disease, which it decreases the amount of oxygen supply and nutrition to the ulcer, and may lead to infection and end up with amputation. These are the 4 systems that we evaluate the diabetic foot patient: the dermatological assessment, vascular assessment, neurological assessment, and musculoskeletal assessment. We'll discuss this in details in a moment. So dermatological assessment is very important in patients with diabetes. As with long-standing uncontrolled diabetes, usually patient's skin loses its flexibility, become easily to break through and become open door for infection. If you see in the upper left picture, you will see hyperkeratosis at the weight-bearing area. Now these calluses, if you don't debride it, sometimes there is an ulceration formed underneath the callus, might go deeper and may have severe infection, may end up with amputation. And if you see in the upper left picture, you will see the most common fungal infection that we have in our clinic. Now tinea pedis is easily treated when detected earlier, but unfortunately most of our patients ignore these kind of problems and may end up with severe infection, cellulitis, pus discharge, and unfortunately they may end up with amputation. And I had some patients that had amputation caused by tinea pedis. Vascular examination is important for a patient, not just for detecting the vascularity of the foot and ankle, but also to planning perioperatively where the patient can go for surgery or postpone the surgery for further investigation. We palpate the 2 major arteries that supply the foot and ankle: the tibialis, or the posterior tibial artery, which located 2 fingers behind the medial malleolus, and the anterior tibial artery, which located between the extensor hallucis longus and the anterior tibial tendon. And the microcirculation is detected by applying gentle pressure at the distal forefoot. If the capillary filling time is less than 3 seconds, consider as normal circulation. The characteristic of the arterial ulcer is usually a punched out ulcer located at the distal forefoot. The wound bed is usually covered with black eschar and necrotic tissue, and some or minimal or no granulation tissue. Now, this is a typical picture of a arterial ulcer. As you see, the location of the wound is the distal forefoot with cyanosis at the hallux, and the wound bed is covered with black eschar and minimal granulation tissue. Now, this is a dry gangrene of the forefoot. Now, before you jump into surgical intervention, whether you're planning for transmetatarsal amputation or shore part amputation, you have to address the vascularity of the patient. Otherwise, you will cause more damage to the patient than benefit. The most common non-invasive tool that we use in our clinic for evaluation of the vascularity is the ankle brachial index. Now, due to non-compressible arteries, sometimes we get false positive results, and usually we combine the ABI with the toe systolic pressure to get more accurate results. The other tool that we use in our clinic is the handheld Doppler ultrasound, which has 3 phases. The monophasic waves consider as bad circulation. The biphasic and triphasic waves consider as good circulation and usually proceed with surgical debridement. The transcutaneous oxygen pressure, TCPO2, detect the amount of oxygen delivered to the ulcer, and it's becoming more popular nowadays in clinic. Angiography remains the gold standard for evaluation of the vascular system and considered as invasive tool. So this is the ABI interpretation guidelines. And usually a patient with ABI of less than 0.8 millimeter per mercury is considered as bad circulation. We usually postpone any surgical intervention, even compression considered as contraindication in these cases, and we usually refer these patients to vascular intervention radiologist. The TCPO2, as we mentioned, it detects the amount of oxygen delivered to the ulcer, and if we have a TCPO2 less than 20 millimeter per mercury is considered as bad circulation. Even superficial debridement considered as contraindication. So if you run your diagnostic test in your clinic, your ABI, your TBI, and TCPO2, and you have these values you see in the left column, these are the indicator of poor wound healing prognosis. So you have to stop any surgical planning, and you have to send the patient for vascular intervention radiologist. The American Diabetic Association stated that the 10-gram monofilament is the gold standard for evaluation of reduced sensation. 10 points, dorsal and plantar forefoot. If a patient misses more than 3 points, it's considered as reduced sensation. The musculoskeletal evaluation is very important in patient, not just to detect the pressure area in the plantar foot, but also to detect or planning surgical preoperatively to serve the patient biomechanic post-surgery, just to avoid any recurrent ulceration, and the patient might become a chronic patient in your clinic, and you may take the patient for another surgery. So we have two classification systems for wounds, the Wagner classification, which assesses the depth of the wound, and the University of Texas grading system, which assesses the depth of the wound and also the vascularity of the wound, and it become more commonly used and more comprehensive evaluation. Now, this is the Wagner classification. Grade 0 is considered non-plinchable erythemia. Grade 1 considered as partial thickness ulcer. Grade 2 and grade 3 is considered as full thickness ulcer with bone involvement in grade 3. Grade 4 and grade 5 is forefoot gangrene and whole foot gangrene. Now, as we mentioned, the University of Texas grading system, it describes the depth of the wound, as you see in the horizontal column, and the vascularity of the wound, as you see in the vertical column. Footwear examination is very important with patient with diabetes. So as you do your clinical examination, as we mentioned before, you have to evaluate the type of shoes the patient is wearing and the orthotic he's using, also the depth of the shoe box. These are the inflammatory biomarker that we use for the diabetic foot infection. Now, the Infectious Disease Society of America stated that there is high correlation between the white blood cells and the severity of the diabetic foot infection. Also, high value of ESR when there's an infection present, but usually ESR has affected by many comorbidities like anemia, and also has low response in acute infection. C-reactive proteins having high accuracy in diagnosis of the severity of the diabetic foot infection, especially in grade 2 infection. For PCT, in recent studies shows that high value, there's a correlation between high value of PCT and also the osteomyelitic infection. In 2023, the International Working Group of Diabetic Foot stated that due to low sensitivity and specificity of the inflammatory biomarker, it's all being used when there is a doubt in your clinical examination. The goals of your ulcer management is to have the right wound, the right patient, the right type of dressing at the right time. So timing is very essential in patient with diabetes. Any delay in intervention can cause amputation and limb loss. So the cornerstone of our foot ulceration prevention is to identify, inspect, and educate the patient of at-risk foot, and education about the proper footwear, and also treatment of the underlying causes of the ulceration. The take-home message is that not all diabetic foot complication can be prevented, but can be avoided and reduced through a multidisciplinary team. The American Podiatric Medical Association stated or recommended that any diabetic patient should have a visit to a podiatry clinic at least once every year. Thank you very much.
Thank you, Dr. Yusuf. Now, please welcome with me Dr. Noor Janahi. Dr. Noor is a chief podiatrist in Awali Hospital in Kingdom of Bahrain. She finished her degree in Edinburgh in 2005, then continued her master's degree and doctorate from Edinburgh in 2014. She's the first Bahraini to practice the profession of podiatry in the country. So please welcome her. and the talk gonna be regarding with the title of Understanding of Diabetic Foot Biomechanics. تفضلي دكتور.
Good morning, everyone. First of all, I would like to thank the organizing committee and especially Dr. Hani for inviting me to be a part of this interesting conference and successful conference as well. So I'm very happy to be here with you all today. So my topic is the biomechanics of the diabetic foot. Is it working? Okay. So the biomechanics of the diabetic foot is a complex topic, but obviously I'll try to brief it in 15 minutes so that you can go home with an understanding of the basic biomechanics of the diabetic foot. So before we start this, what do we mean by the biomechanics of the diabetic foot? The things that I want you to focus with me today are what do we mean by biomechanics of the diabetic foot? What are we looking for when we're thinking about the biomechanics? And what is the why is it so important for us to understand this? So before we go into details about the topic, I wanted to show you this picture. So when you look at this picture, normally, when you ask someone to describe it, they'll be like, yes, we see probably a neuropathic ulcer that looks like it's healing well, has good granulation tissue, and so on, right? But what I want you to look at when you, what I want you to describe when you actually look at this picture is this image here. Because that ulcer has developed for a reason. So if you don't understand the factors that actually led to the development of that ulcer, you will never be able to heal that wound. So what do we see when we look at this image? We see a rigid deformity, we see a cavus foot type, we see plantar flexed metatarsal in relation to, plantar flexed forefoot in relation to rear foot, we see an equinus deformity, we see toe deformities, we see claw toes, hammer toes. All these contributing factors will actually develop or lead to the development of ulceration. So we all know that 34% of DM patients will develop foot ulcers. We all know that more than 50% of these ulcerations will get infected. We know that 20% of the diabetic foot ulcer will lead to amputation. But the interesting fact here is that approximately 40% of patients who have actually an ulcer that has healed will develop recurrence within 1 year of that ulcer being healed, 65% within 5 years, according to the study by Armstrong et al. So what are the factors contributing to the development of ulceration? The most common pathway to the development of foot ulceration that has been described by Ribber et al. In 1999 suggested that if you have neuropathy present, and with the presence of deformity, any trauma can actually lead to the development of ulceration. So the contributing factors to the development of ulceration, this has been talked about yesterday and this morning. So I'm not going to go through the vascular or vasculopathy and the neuropathy of the diabetic foot ulceration. I'll be concentrating more on the deformity and the trauma aspect of it. So what do we mean when we talk about deformities of the diabetic foot? Now, deformities can either be primary deformities, such as these are basically the deformities that patient has regardless of having diabetes. For example, pes cavus, which is a high arch foot, pes planus, which is flat foot, toe deformities such as hammer toes, and hallux valgus, and any other forefoot and toe deformities. Now, we can also get secondary deformities. Now, these are deformities that develop because of diabetes or because of any other medical condition. For example, the intrinsic minus foot, which is the image you see on the top there. And we'll talk more about this in the coming slide. You can get an equinus deformity, and you can obviously get Charcot deformity as a complication of diabetes. Laterogenic deformities are basically deformities that are caused because of removing a part or a segment of the bone structure in that foot, which usually happens post-amputation. When we talk about trauma, I want you to understand that there are two types of traumas that we deal with when it comes to diabetic foot ulcers. There are acute traumas, and these are things like that happen suddenly, such as burns, cuts, abrasions, or any basically something that happens suddenly within the foot. Chronic trauma are basically trauma that develops over time because of repetitive injury to that soft tissue underneath that bone, and I'll talk about this more in the coming slides. So any structural deformity will obviously lead to increased plantar pressure. It will lead to ulceration and can actually lead to a subsequent amputation. So these are some images of plantar foot ulcers, and it shows the basically increased plantar pressure, and you see in the image next to it. So the purple or the bright pink color, this basically indicates an area of increased pressure, and you can see that it demonstrates well when you look at the picture that is, and where the ulcer exactly is. So how does the biomechanics of the foot get affected in diabetes? So for us to understand the biomechanics of the foot, let me start by explaining to you how the foot functions in a normal individual with a normal foot structure and a foot function. So understanding the foot function, we all know that there is something called gait, and there are two phases of gait. So we have the stance phase of gait, and then we have the swing phase of gait. So in the stance phase of gait is basically when the whole body weight is basically distributed on one foot, or the load is on one foot, and this is the part where basically supports your body to allow for further movement from one part of the ground to the other. The swing phase is basically the phase where you lift your foot from one part of the ground to the other. Now, I want you to think about this, because during the stand phase, about 100% of your body's weight is actually on that one foot. When you're standing, 50% of the body weight is on each foot, but when you're walking, 100% of the body's weight is on that foot during stance phase. So in a normal gait, usually when the heel strikes the ground, the foot is actually in a flexible position. It goes into that pronation to allow basically adaptation to the ground the foot is walking on. And then it moves from being flexible into that rigid type of foot to give you stability to move forward. Now, why am I discussing all this with you here? Because I want you to remember this when we talk about the foot deformities that happens with diabetes. So now we all know that we have a big, this has been mentioned yesterday, that motor neuropathy does lead to a weakness of the intrinsic and extrinsic muscles, which leads to imbalances in these muscles' functions, and leads to deformities formation, which usually involves plantar flexed metatarsal with prominent metatarsal head and deformities of the toes, such as claw toes. So this leaves the foot with a metatarsal that is really plantar flexed and prominent, and the fat pad over time actually migrates distally as well, leaving that area under the metatarsal head exposed to even more pressure. We all know that with diabetes and increased glycation, we get stiffness in the plantar tissue. We also get limited joint mobility, and all this with loss of protective sensation will lead to this foot. So you get a foot that is really rigid, really difficult to move, and you have areas of increased plantar pressure. Now, I want you to think about that gait concept that I mentioned before. So imagine if you have a foot that looks like this and feels like this. How does it feel when actually it's going through the gait cycle? So they will not have that flexibility to adapt to the ground. They will not have that structure to basically support the foot to allow it to move forward. So think about how painful that foot should actually feel, but unfortunately, due to the lack of protective sensation, the patient is unaware of how painful that foot is. Other types of foot biomechanics are obviously Charcot foot. I'm not going to go into details in this because I know that Dr. Hani will cover this for me later. But just to have a quick understanding, Charcot neuropathy is rare, but it's a devastating and complicated complication of diabetes. If not treated and not detected early, can lead to increased destruction of the bone structure of the foot. There are different parts of the joints that can be affected, and Charcot foot, the less frank joint can be affected in up to 60% of cases, which basically leads to collapse of the forefoot and metatarsal area. You have the metatarsal joint that can be affected in about 30% of cases, and you have the ankle joint that can be affected in 10% of cases, which can lead to increased deformity of varus or valgus, depending on the procedure. So both ways, whether you get a foot that is affected by a motor neuropathy and leads to that intrinsic minus foot, or you get a Charcot foot, you will always end up with areas of increased plantar pressure, as you can see in the image here. So why do we need to know all this? We all know that high plantar pressure is considered a risk factor for foot ulceration. It has been detected in patients with neuropathy and has been correlated with limited joint mobility, plantar pressure thickness, and plantar fascia thickness. There are so many measuring tools out there in the literature in terms of plantar pressure measurements, but recently plantar tissue stretch, which is usually a combination of detecting or measuring plantar pressure, measuring shear stress, and measuring daily weight-bearing activities into one, has been introduced in literature, and they have found that increased PTS will obviously lead to increase the risk of ulceration. Other plantar pressure measurement tools are things like cumulative plantar tissue stress, which also combines measuring plantar pressure with weight-bearing activities. But however, there's no universal system for measuring plantar pressure up until now. So this has been briefly mentioned by Professor Bolton yesterday. So we discussed plantar pressure. Now, how do we bring plantar pressure measurement into patients' life? Now, there are new devices that have been developed. We did mention about the lack of awareness in patients with diabetes in regards to adherence to offloading and footwear and even understanding of plantar pressure. So these artificial intelligence systems or smart devices have actually been developed that has been helping patients to understand the importance of their plantar pressure and when they are basically at risk of developing ulceration. So for example, this is like a smart watch that basically shows the patient and the practitioner whether the patient is actually adhered or actually wearing his offloading devices and footwear, diabetic footwear. Other advanced systems are things like the pressure mat or the temperature mat, where basically it's like a bath mat, and the patient stands on it every morning, and then it can give them an indication of whether he has areas of increased pressure that might lead to the risk of ulceration. So if you think about it this way, if you have a patient that has no sensation, so he will never know if that area is painful for him. If he has things like this, that obviously will always keep reminding him of how that area in his foot is going to ulcerate any second, then maybe that will actually increase awareness and might help that patient understand his foot better. So the literatures have basically compared different AI modalities to normal modalities that are being done nowadays in our practices and how they can basically overcome these risk factors. So for example, lesions that are occurring prior to ulcerations, nowadays basically we use things like thermometer devices to detect whether that area is at risk of ulceration. The AI alternative is basically continuous at-home plantar pressure measurement by the patient. Other risk factors such as elevated plantar pressure, right now we obviously try to control it by offloading. IA alternative would be continuous at-home plantar pressure monitoring that goes to the patient's phone and to the practitioner's phone as well. Irregular adherence to offloading, nowadays we try to control it by forcing the patient into total contact cast. Other alternative would be monitoring adherence to temperature, such as the mat that I described earlier. So these are just some smart devices that are available right now, such as the smart mat, silent care, and Podotem. So what are the implications of understanding the biomechanics of foot in diabetes? Prevention, obviously. We're here to do to basically reduce the pressure on that ulcer to allow healing. Understanding the mechanism behind that ulcer development will obviously lead to better healing of that ulcer, and obviously offloading, whether conservatively and surgically. So we all know about footwear, and I think you have a workshop that basically describes what type of footwear is good for diabetic patients. Now, the important message here is there's no single footwear that works for all patients, because every foot is different. So you really have to examine that foot, understand the function and the biomechanics of that foot to be able to prescribe better footwear for that patient. Injectables have been mentioned by Dr. Khalid Idris yesterday. So there are things like collagen injections, silicone injection, filler injections, and studies have actually shown that it has reduced plantar pressure in that area that has been injected. However, it's a temporary solution, and they obviously need to re-inject within 9 months to 1 year to maintain that good plantar or reduced plantar pressure under the metatarsal heads. Surgical offloading will be discussed in other sessions, but things like, for example, Achilles tendon lengthening has been proven to be important in reducing the forefoot load, to reduce the pressure on the forefoot, to reduce the risk of ulceration. Joint arthroplasty, single or pan-metatarsal resections, and osteotomies as well has all been introduced as a concept of offload, surgical
Doc, 1
offloading.
minute more.
So this is an important message that I want you to take with you home today. So why are we doing this talk about biomechanics, and why are we adding it in this conference? Now, I'm sure that most of you have realized that the previous years, everyone has been talking about vascular assessment and neuropathy assessment in terms of sensory loss, but no one is really looking at how we basically evaluate the foot in terms of the biomechanical aspect. And it is a very big deal. It's a big contributing factor to the development of foot ulceration. So we need to introduce it to our primary health physicians. We need to make sure that our primary health nurses and physicians are aware of the importance of understanding the biomechanics of the foot and assessing the biomechanics of the foot in terms of reducing prevention and reducing the risk of ulceration and amputation.
Dr. Noor?
So in summary, biomechanical alterations are a composite function of neuropathy, structural deformity, limited joint mobility, and is associated with gait disturbance. Early recognition and prevention is important in terms of plantar pressure measurements and the biomechanical aspect of the foot to reduce the risk of ulceration and amputation. Thank you so much.
شكرا دكتورة. And now please welcome with us the foot and ankle practitioner and specialist, Mr. Saad Al-Faiz. He got a bachelor degree of pediatric medicine, graduated from University of South Australia, working at military hospital in Taif region. He is a head of pediatric department. He is a certified trainer for TOT program from Saudi Commission of Health Specialties. The topic gonna be now regarding medical offloading of diabetic foot wounds. تفضل أستاذ سعد.
بسم الله الرحمن الرحيم. Today I'm going to talk about medical offloading of diabetic foot ulcer. The content of this lecture, I'm going to talk a little bit about history of diabetic foot, definition of offloading, force applied on the foot, principle of offloading, and method of offloading, and some take-home message. Over the last 15 years, the rate of diabetic foot amputation has been increased, especially in our region. More than 60% of non-traumatic amputation are performed in patients with diabetic. The amputation rate is 10 times higher in people with diabetes than those without diabetes, and every 30-second loss a limb as a consequence of diabetes. WHO estimated that 85% of diabetic amputation are preventable. So the offloading is a medical term for relieving pressure on a part of the body. As a podiatry, the offloading refers to reducing pressure to area of the foot to reduce pain and trauma and improve healing of the ulcer to those areas. The offloading plays a critical role in wound healing, especially in diabetic neuropathic and pressure ulcer of the foot. There are four main types of force that apply to the soft tissue of the foot. The first one, we call it shear force when moving into or more direction at the same time due to single or multiple loads, as you can see in the left side, A. And the second force, compressive force, squeezed between two or more opposing load, and frictional force, a force move over the surface of materials while in contact with it, creating a drag across the material's surface. Tensile force or strain force when a material is stretched by two or more opposing force. As you can see here in this slide, an ulcer underneath of the head of metatarsal, and there is a combined force applied to an ulcer over a material metatarsal head. So we have a compression force, tensile force, and rotational force, which need to be do an offloading this area to allow healing of an ulcer. The concept of offloading is use of devices, medical devices, or surgical intervention that to remove a pressure from a special area in the foot. This is to improve healing of the ulcer. And diabetic foot often occur in the sole of the foot at a site of repetitive injury that are recognized by patient because of the loss of protective sensation. The ulcers are usually at a pressure point on the bottom of the foot where a callus has formed if a neuropathic patient continue to walk in that area. So it's very difficult to heal that ulcer. The offloading is one of the most important intervention to facilitate healing in the foot ulcer by reducing pressure and shear force at the site of ulceration, by reduce motion of the joint of the foot, and also by decrease the number of steps or loading cycle per day. This allows healing tissue to bring the wound without continual damage. In this slide, in the normal patient, we have in the left side in the top the normal fat pad underneath of the head of metatarsal, but with those patients who have a neuropathy and deformity in the feet, the fat pad migrate to the anterior of the head of metatarsal, causing a very thin area underneath of the head of metatarsal, with wearing incorrect footwear, which lead to causing a pressure area and causing ulcer underneath of the head of metatarsal. So we can see in this slide the callus diagram located under the second, third, and fourth metatarsal head as a result of fat pad atrophy and pressure area as a result of deformed foot. In the left side, we can see the abnormal lateral loading pressure area for patient with diabetes, which leading to cause a callus and causing an ulcer. We have different materials and different medical offloading in the market. We could use it to offload. We have a total contact cast also, which is a gold standard also, and we have the removable boot and crow boot, and also we have an ortho wedges and post-operation shoes. And also this one, we call it sheepskin. We use it for those patients who are bedridden and need to have an offloading. The total contact cast, it is the accepted gold standard for the offloading of the mid and forefoot lesion. Offloading for neuropathic non-infected plantar ulcer reportedly healing between 72 and 100% of ulcer within 5 to 8 weeks. Despite this, the technique is not widely used in our clinic because of lack of education, training, and resources. The removable cast walker, useful in cases of infection, allow for dressing change, difficult to apply for patient because it has like 3 or 4 strap, and heavy elevated sole control lateral limb remove same amount of plantar pressure as total contact cast, but we have a compliance issue with the patient. The sheepskin boot useful in areas of ulceration not involving weight-bearing surface for toe ulcer, not advised in highly oxidated wound because of hygiene issue. And post-operative boots, not great for weight-bearing ulcer, shearing force are often increased, will accommodate a large dressing, and it's good for transmetatarsal amputation that have no plantar involvement, need addition of porin. The ortho diabetic walker, it's for foot ulcer. Poor stability, patient tend to weight bear distally and wear this boot inappropriately. Increase the shearing force, need the addition of a porin to minimize the friction, and we have an stability issue with this type of foot wear. The Charcot restaurant orthotic walker, it's an offloading a similar amount of plantar pressure of total contact cast. Structurally more complex than show. It's customized for each patient, useful in offloading plantar ulcer that require the long-term management. Used in Charcot foot once a coalition is achieved. Also useful in offloading a polyfunctional foot following parter amputation. And also we have different types of medical offloading, such as customized shoes and orthotics, and also we could use felt pad to minimize the pressure in a specific area in the foot. The surgical method, we could also use it as an offloading. The first one, Achilles tendon lengthening, which lead to minimize plantar diabetic neuropathy ulcer on the forefoot in patient with limited range of motion. And study shows a mean 28% reduction in peak pressure on the plantar aspect of the forefoot. As a subsequent study demonstrated that Achilles tendon lengthening procedure in conjunction with total contact cast, leading to minimize the recurrence of ulceration from 59% to 15% compared with the total contact cast alone. And surgical correction of skeletal abnormality, like a surgical debridement of the abnormal bone, or corrective of hallux abductory valgus and hammer toes correction. And the recommendation by International Working Group of Diabetic Foot for the offloading guideline, they divide this one to 3 categories for patients with non-plantar ulcer and plantar forefoot or midfoot ulcer, plantar heel ulcer. So for the non-plantar ulcer, they advise to use custom footwear or insole, and for plantar forefoot or midfoot ulcer, if it's with infection or ischemia, they advise to use a high walker airboat cast. And also, if not achievable, they can use a felt as well. And for non-infected or ischemic or non-ischemic patient, they can use a walker or consider using a felt foam with appropriate fitting footwear. With the plantar heel ulcer, consider to use any high offloading device. And if there is no, if the ulcer it's failed to heal, they can go to the surgical intervention. The take-home message: reducing high plantar tissue stress is critical of healing diabetic foot ulcer. Best choice for offloading is a total contact cast or walker non-removable for the healing of neuropathic plantar forefoot and midfoot ulcer. A high-quality randomized controlled trace of non-surgical and surgical offloading intervention that include measure for change in the plantar pressure, ambulatory activity, and treatment adherence, as well as reporting of adverse event and patient satisfaction and cost are needed to better information for clinician and patient about effective offloading treatment in this area. We want to take hand together to prevent the most disastrous and costly complication of diabetes, which is amputation rate. And thank you.
Dr. Abdelaziz Al-Tassan, please, the floor is yours. He's going to take us in a talk about selection of proper imaging in diabetic foot. A short introduction about Dr. Abdelaziz. He's a musculoskeletal radiology consultant. He's the section head of musculoskeletal radiology, director of residency training program, working at King Fahd Specialist Hospital, Breda. تفضل دكتور.
السلام عليكم ورحمة الله وبركاته. Good morning, everyone. I am Dr. Abdelaziz Al-Tassan. I am consultant musculoskeletal radiologist. Today we'll cover a bit of selection of proper imaging in diabetic foot. The topic is huge, but I'm trying to do some outline of the talk. Okay, so this one. Okay, sorry. So my outline of talk will start by a brief introduction, then gonna go for overview of radiological modality to imaging diabetic foot. Then we're gonna discuss the example of diabetic foot pathology imaging feature, and we're gonna take some home messages. So a brief introduction, which will be, I think, discussed many times, but just to be good entrance for the topic, which is diabetes mellitus is a multisystemic disease that is associated with significant complication affecting multiple organs. Specifically, diabetic foot infection are frequent and associated with substantial morbidity. Studies have been shown that up to 50% of patients with diabetes will develop lower limb neuropathy, and between 19 to 34% of the diabetic patients will develop neuropathic and or ischemic ulcer in their lifetime, and imaging play a crucial role in their diagnostic process. So early and accurate diagnosis of diabetic foot pathology, such as we're gonna discuss some soft tissue infections such as cellulitis or necrotizing fasciitis, or bone or centered joint pathology such as osteomyelitis or Charcot arthropathy. It's a key for successful treatment in patients with diabetic feet. So what the imaging modality we can do to investigate diabetic foot? There are many. The choices are including basic conventional radiograph, which will be preferably to be done as weight bearing. Move on for ultrasound, do it in both. The regular diagnostic and also Doppler ultrasound. Also we can do for venous and for arterial ultrasound examination. CT scan, also looking for, we can utilize the facility of CT angiography, MRI as well, and MRI. Nuclear medicine scan we can use for lipid leukocytosis, bone scan, and etc., and also PET scan. Some example of the common, usually daily practice of every one of you as a pediatric cellulitis, which is acute infection of dermis and subcutaneous tissue without debial, facial, or muscular involvement. The patient will present to clinic with red swollen foot. So to start with, you're gonna go for basic radiograph. So this will be considered the initial examination. The finding not always specific. So usually we're gonna show for soft tissue swelling. You're gonna check for effacement of fatty plane, and you also look for skin discontinuity setting for deep ulceration. The aim of plain radiograph to direct you to exclude other differential diagnosis, such as in case of trauma, you're gonna have those findings, soft tissue swelling as a fracture. In case of foreign body, such as any radiopaque foreign body. So this is, for example, a frontal radiograph. I know we are usually in radiology, we live in dark, so I think some image will not be that clear, but I will try to myself to explain it. So this patient having a soft tissue swelling around the ankle, and the lower limb X-ray giving effacement of that fatty plane. Is this specific cellulitis? No, but it's the baseline that we exclude. There is no underlying fracture, no radiopaque foreign body underlying. So move on for ultrasound. For cellulitis, the sonographic hallmark of cellulitis, which include increased echogenicity, increased thickness of the dermis, and indistinct haziness, and increased echogenicity of subcutaneous tissue. It's always helpful to compare with a normal contralateral side, if any. Then you're gonna look specifically for the, what we call it, couple stone appearance, which is a progressive accumulation of edema in subcutaneous tissue, appearing as branching and anechoextraction, such as this images. So the patient having anechoextraction surrounding the subcutaneous fat, giving same appearance to couple stone appearance. So move on for the cellulitis imaging. You can do CT scan. CT scan is for cellulitis is not gonna add more, except for looking if they're deep cellulitis, looking for excluding of abscess formation. Move on for MRI. It is best imaging technique for any soft tissue abnormality. So it is more sensitive, more specific. We don't do MRI for cellulitis. We do MRI to exclude others. So to start with is this cascade of images that you will go through it and let you find your diagnosis. So you're gonna see edema, which will be low T1, high T2 of soft tissue. Cellulitis, localized skin and subcutaneous tissue with a reticular button and fat associated with enhancement. This patient having a red dot swelling, if you're gonna see that selected images of axial T2 scan, that you noted that the patient is post-contrast administration, having thickened, enhanced skin, as well as reticular enhancement of the subcutaneous tissue with no abscess formation. So this is cellulitis. Move on for another soft tissue infection, which is necrotizing fasciitis. It is aggressive soft tissue infection within subcutaneous and deep fascia, toxin-producing organism that spread rapidly and causing necrosis and liquefaction of muscle and fat. The diabetic patient, in particular, they are risk to both because they are immunocompromised and they're having vascular insufficiency. So, imaging recommendation. Best imaging tool, it is clinical diagnosis. There is usually it's clinical. If you suspect, you just monitor and you need to go for surgical debridement. So, what is the imaging modality? What we can use? You can use to exclude necrotizing fasciitis, especially if the normal fascia is normal. Then we can use just simple X-ray to look for air, or eventually CT scan to see how the extent of the air. MRI, you're gonna see it with contrast, looking for facial fluid and necrosis. But MRI should not be undertaken if the patient is unstable. So those two examples, lateral X-ray of the foot, demonstrating that there is extensive subcutaneous air that dissecting up to the lower leg. So corresponding imaging, axial CT scan, that's showing also abnormal air within subcutaneous tissue as well as within the fascia. This is consistent with necrotizing fasciitis, necessitates surgical debridement. Move on for bone-centered pathology, osteomyelitis. Typically begin with radiograph. As we say, any suspicion, you have to go by X-ray to exclude others, and also looking for sign of acute osteomyelitis, such as any cortical bone destruction, any permeative radiolucency, any focal osteopenia, soft tissue swelling as well. So this patient, frontal, if we have dim light in the front, the images will be more accurate. So I don't know if it's available if we can have dim light. So the patient having a tip of the distal phalanx of the big toe, the patient having soft tissue swelling, ill definition of the cortex. This is suspicious for acute osteomyelitis. Move on for lateral ankle X-ray, the patient having abnormal skin ulceration to the calcaneus area, but there is no extension, obvious extension to the underlying bone. So the image is non-specific, but it's an interest. So you can move on to can do CT scan, looking for any bone destruction, periostitis, and eventually you can evaluate for vessel doing CT angiography. Also, nuclear medicine, radiolabeled WC scintigraphy, which representing the nuclear medicine standard for diagnosis of infection. So two selected images of lateral X-ray, CT scan, sagittal images demonstrate there is a large soft ulceration at the plantar area in the left images, but there is no obvious destruction underlying bone. Another patient, which is sagittal images, you see there is a large soft ulceration at the plantar area. Also, there is abnormal destruction of the cortex. This is concerning for osteomyelitis, which is already patient have developed. So next you have gonna move for this is also an example for labeled WC scan. You're going to see a focus of high uptake in the big toe, and this is corresponding to acute osteomyelitis. If the beauty of the WC that you're going to combine it with SPECT images. So SPECT CT images that will give you a good anatomical localization of the abnormal uptake. So exactly you will decide this is the abnormality of uptake. It's happening within the distal toe. So MRI is sensitivity and specificity of acute osteomyelitis is very high. It is reaching up to 82 and 100%, and the specificity is also high. So what you're gonna see in the images, MRI, we have a confluent low T1 signal intensity. I always suggest for anyone to ask for 2 plane of T1 signal intensity. Of course, most of the patients with diabetes have a chronic kidney injury, so the GFR was below sometimes will be difficult to give the patient contrast, and also we can utilize the diffusion weighted images as well. So this is 2 selected images of coronal T1 and coronal T2 fat sat that's showing there's a confluent loss of T1 signal intensity of the calcaneus bone, which corresponding edema in T2 sequences. Both contrast images shows that there is intense enhancement within the calcaneus. This is corresponding to acute stomatitis. Another example, patient of fifth metatarsal, you see there's a confluent loss of low T1 signal intensity. Notice that the bone marrow signal intensity in T1 will be bright, so it's high as a fat. So all the bone marrow is normal except for the fifth one, which is eventually confluently lose the T1 signal intensity, and in the T2, you're gonna have abnormal bright signal intensity. So this is a case of acute stomatitis. So move in, do we use the BIT scan for infection of stomatitis? Yes, but it can be used for major purpose oncology patient. You follow them for activity, but also not usually widely used in clinical practice. MRI will be more than enough for diagnosing those images, but can be used in spinal stomatitis, and it shows increased activity in the affected osseous. And if you combine the increased FTG uptake with the CT images, you show that there is a high uptake in the fourth toe, which corresponding bone destruction within the SPECT CT scan. So move on to the last example. The fourth one is in neuropathic charcotropathy. Always go for X-ray, blare radiograph, looking for 5Ds. We know there is a different phase of charcot-arthropathy, but is the most common one to best imaging clue that to have any joint dislocation, any deformity, any disorganization, any bone debris, any distension, if there is increased density as sclerosis or increased joint distension. So patient having midfoot abnormality, usually patient will not having an soft tissue ulceration, so centered within the midfoot, patient having a lateral dislocation, there is a destruction of the joint, so this is corresponding to acute stomatitis. If you apply the 5Ds, you will end by diagnosing the charcot-arthropathy. So radiography is important in diagnosis and long-term surveillance. MRI utility for detection of the disease and problem solving in setting of superimposed infection. So MRI will have it, you can have a charcot with superimposed stomatitis, but you're gonna have eventually clinically evaluate that patient. He's reaching to that stage, then you're gonna order for MRI. So I think there is a massive, because maybe the different in font, but there's a code that's calling if you need something you never do, you have to do something you never done. And this is, I believe Dr. Hani and the group, they do it. They believe in their purpose and they came up with excellent conference. Take home message, blare radiograph will preferably do weight bearing. It is initial exam, exclude other differential, looking for any fracture, any tumor, any foreign body. You always pay attention for what you call it, buzzword to use to diagnose some modalities such as 5Ds, looking for soft tissue ulceration to check for any underlying bone destruction in terms of osteomyelitis. Ultrasound is the best modality to use to look for cellulitis, looking for cobblestone appearance, and make sure that you put a pulse wave so you're gonna see increased pulse Doppler, exclude collection, any abscesses, look for other differential, and you evaluate the vascularity, either venous or arterial. CT will help you for deep collection, any destruction of the bone, and MRI is best imaging technique in soft tissue abnormality and in evaluation of diabetic foot. So the complication will be well managed by MRI. Radio-labeled WC scintigraphy is the new medicine gold standard for diagnosis of infection. BIT scan not widely used in clinical practice, but is mostly useful in spinal osteomyelitis. And thank you very much.
Thank you so much, Dr. Tassan. And now please allow me to introduce Ms. Hayat Al-Saleh. She's a nurse, specialist, and team leader of wound and stomach care in National Guard Hospital. She has a long experience of around 15 years in wound management and stomach care. A leader in her field, participated in many national and international conferences beside the training courses. Today, she's gonna take us in a nice journey with the subject titled Optimal Dressing for Diabetic Foot Wounds. تفضلي Ms. Hayat.
Good morning, everybody. Thank you so much for the organizing committee and for Dr. Hani Badahdah for inviting me. I wish that I'm adding value for this conference. Yesterday, we learned about how important that we can normalize the blood sugar level to prevent the complications. And today, we learn how the flooding is very important also for prevention of the diabetic foot ulcers. In my presentation, I'm highlighting for this the problem solution for unlucky patients that develop negative, what? I'm so nervous. Develop diabetic foot ulcers. So, in my, which one? This one? Okay, so this one. The outlines, I'm going to highlight the wound assessment, optimal wound dressing selection, and advanced technology. So I used to hear one question when I started my career as a wound care nurse specialist. Once I introduced myself as a wound care specialist, they asked me, what's the best dressing available in the market? Actually, there is no straightforward answer for this question. So I advise everybody, don't jump to the conclusion before you assess the patients and assess the wound itself. So careful assessment for the wound, starting from the location, size, measurement, and the location is very important for the diabetic foot ulcer because if it's in a pressure, overpressure area, beside the what we are doing or putting as a dressing, is the offloading is very important throughout the journey. Blood circulation, if there is no optimum blood circulation reaching to the wound bed, no matter what you are applying to the wound, it will not have positive outcomes. We have to assess the tissue available within the wound bed, exudate level, edges, margins, and surrounding signs and symptoms of infection and the presence of sensation or pain. You have to use all your senses when you are looking at the wound, either whether pressure injury or diabetic foot ulcers or any types of the wounds. You have to look, touch, smell, but don't taste, please, okay? So if your system in the hospital allowing for photo documentation, I'm encouraging you to use the baseline photo documentation. It's very important to have the subsequent comparison as well. After the wound assessment completed, you have to set up your goal. What do you want, or what do you want to achieve by selecting the dressing to use for this for the ulcers? Then you have to know what the material that you have available in the hospital, and then you can go with the proper dressing solution. So market is busy. You can see all the companies outside is busy for the creating and supporting us with the best available technology or advanced wound care product. And we have to be very careful, understand all the ingredients and what they are doing for the wound situation. So books and the companies advising us what the ideal wound dressing that's producing fast healing. This is the features for the best and available wound dressing that's treating the infection, managing the exudate, contain the odor, pain reduce, and etc. But in a clinical wise, the most important deriving you for the selecting best dressing is the presence of the infection, level of the exudate, available product within your hospital or hospital budget, what they can offer to you, and availability of the expert that who will select the best options available for you. So keep it simple all the time. If your assessment recognizes the infection, you have to select something with antimicrobial properties. If the wound is heavily exudating, you have to use something absorbing. If the wound is dry, you have to use something that donates water or moisturizing the wound bed. If there is a hole within the wound, don't leave it without any packing, because Leaving any empty or dead space without packing, it will allow the serous fluid to accumulate, and serous will lead to seroma. Seroma will lead to the infection. Necrotic tissue, we have to select something that will help us to clean up the wound bed, because the skin will never going to be closed over the non-viable tissue. And if the wound is clean, we have to maintain it and protect and prevent the further damage. We have to remember the moist theory or moist healing environment. The George Winter, the scientist who studied the healing process for the wound, in his lab, he came up with the conclusion in 1962 that confirmed that optimum wound healing process will take faster through the moist environment, not a dry environment. If the wound too wet, we have to dry it. If the wound too dry, we have to moisturize it. Why this theory, or why we need optimum or well-balanced the moist environment? Because all the cellular that can help in healing process or formation of the new tissue needs a moist environment to migrate or to do to create epithelialization and granulation. If the wound bed is dry, these cells will be rigid, will not be able to do their function. And if the wound too moist, that will be chaotic environment. So they will be unstable or inappropriate environment to do their function. Yeah, sometimes we have one wound that's having moist, that's having necrotic or non-viable tissue, slough tissue, or sometimes granulating tissue at the same times. So from these pictures, you will see there is no one dressing can fit all the wound conditions. So the wound that, or the dressing that I'm going to apply for this one, different than the dressing that I'm going to apply for this one. And the same foot from the palantar side, you can see a pressure point, so we have to offload it. There are more than 14 categories, and the time remaining is 7 minutes only. I'm not sure that I'm going to cover everything and share with you successful result with in my clinic. But I'm encouraging you to understand all the indications and contraindications of the available dressing that you have. So starting with the hydrogel dressing, it's solidified water, 95% solidified water. I have to use it in a dry, non-exuding wound, or if there is available of non-viable tissue, it will help us moistening and provide otolytic debridement. Its daily dressing change required secondary dressing and fixation. Contraindication if there is a heavily exudating wound, and this is not careful not to be applied overlapping intact skin, because it's going to cause maceration and then a skin breakdown. And also, don't use it with infected wound unless it's having antimicrobial properties. Non-adherent layer, it's providing moist environment. The first version of the non-adherent layer was impregnated gauze with paraffin ointment. Then the cellulose material that's really non-adherent, whether it's impregnated with the iodine, bovidine iodine, or a plain one. So providing smooth, painless removal, atraumatizing removal of the dressing, and providing comfort for the patient. Hydrofibers, it's very interesting product. It can be used with minimal to moderate wounds exudating. And once it gets saturated, this is the maximum, so we have to change it. And it's good things about this one. Once it gets saturated or it's absorbing, it will be transformed to gel, and it's providing otolytic debridement, painless removal of the that dressing and cleaning up the wound bed. Once those contain of silver, those dressing contain of silver, it will be used with the infected wounds. Hydrocolloid dressing, it can be used with a minimal exuding wound, providing otolytic debridement and protecting the wound from further damage. It's waterproof dressing and it promotes healing as well. Careful when you remove this hydrocolloid dressing because it's very adhesive, a strong adhesive, and it can cause skin stripping. So you have to use adhesive removal wipes or adhesive removal spray for prevention of the skin stripping. Alginate dressing, the main ingredient for this dressing is seaweed. It can control minor bleeding. It can absorb moderate to heavily exudating wound. It's transferring the exudate to the secondary dressing. Once it's impregnated with honey or silver, it can be used with the infected wounds. Antimicrobial dressing, we do have a lot of options. We do have silver-silvadiazine, we do have silver dressing, ionic metallic or nanocrystalline. We do have iodine impregnated dressing or metronidazole gel. Also, we use it with the fungating wounds. Also, nowadays, we have physical binding dressing that attract the bacteria and remove it. It will not kill the bacteria within the wound bed. It will just absorb the bacteria and remove it, take it away from the wound bed. So all these options, we need to be very careful when we use them with the patients with the thyroid or kidney issues. We have to be very careful with the silver toxicity. Long term of use of the silver dressing will cause silver resistance. Once you have or notice that the wound is stagnating, we have to switch for any antimicrobial agent. Then you can come back with the silver after 2 weeks or 1 week. Honey, it facilitates otolytic debridement, inhibit bacterial growth. It has anti-inflammatory properties, control the odors, and clean up the wound bed. Foam dressing, it's the first use or indicated when they put in the market. It's to control the heavily exudating wounds, but over the studies and over the times, there is we discovered that they are useful in pressure injury prevention, especially for the patient who's hemodynamically unstable or those patients who's going to OR for long surgery, more than 3 hours. So without a chance for changing patient position, we can use the foam dressing. There is some companies combine or composite, merging more than one categories of the wound care dressing to increase the time wear or decrease the frequency of a dressing change. For sure, those dressing will be more expensive than the dressing that we can use it individually. Odor control with contain of activated charcoal. It comes with silver. You can use it as a primary dressing, and if it's only activated charcoal, you can use it as a secondary dressing to control the odor. Collagen dressing or proteases modulating matrix dressing. It's very useful when the wound is clean, low exuding, superficial. It will help epithelializing the wound and allow skin closure in short time. Super absorbent dressing is very phenomenal, especially for the heavily exudating wound. It will allow and protect the surrounding skin for the wound. It will not have a skin maceration, especially for the venous leg ulcers or heavily exudating wound with the diabetic foot ulcers and the palantir. Enzymatic gels, we do have available from multiple companies. They are very useful with the cleaning up the wound and providing enzymatic debridement. Film or transparent dressing, it's very important, very useful when the wound is superficial and when we want to utilize the body enzymes to do the otolytic debridement. And low adherent dressing, you have to be very careful because the adhesive edges are very strong, and you have to use again the adhesive removal barrier when you are removing it. There is some of a dressing with this special technology that promoting fibroblast proliferation and synthesis of the extracellular matrix, and promote faster healing and significant wound care process. Adjuvant therapy, now we might reach to a stage that all this advanced care dressing, we consider them advanced at this stage, will be very traditional. So we have to look and consider the advanced technology or artificial intelligence within the wound bed. Yes, they are so expensive, but there is a chance for great opportunity for fast healing in the future. Some of those negative pressure wound therapy, there is a lot of RCTs and studies confirming the usefulness of negative pressure wound therapy. We have a workshop this afternoon, so you are welcome to join us for further and more information. Amniotic membranes is very proven to have to treat the wound bed, but we have to consider the hospital budget as well. Bioengineering skin substitute, this is phenomenal when we consider the skin coverage for the wound. It can be replacing for the skin graft for some cases. Growth factors or platelet-rich plasma still understudied to confirm their useful and evidence-based to support the dressing, the wound healing. Hyperbaric oxygen therapy, a lot of the studies supporting the topical oxygen therapy. Laser therapy or electrical stimulating is still under studies as well. So here's some cases that I can share with you. This lady refusing totally amputation. There is angioplasty done for her 3 times, but every time her blood vessels collapse and occlude. Then and very minimal blood supplies reaching to her heel. And we use the negative pressure wound therapy for more than 5 months, maybe, for this patient. And you can see the successful result. Sometimes if the patient is resistant and refusing amputation, we have to deal with the situation, unfortunately. We come up with a complete healing, but nowadays patients develop dry necrotic toes, and her toes would spontaneously fall down. This patient also, after amputation of the big toe, you can see how dry is the wound and how necrotic, a lot of debris. We use the silver silbadiazine for this patient twice a day until the wound bed come to complete superficial or 100% clean. We switch to the silver alginate, and this patient come up with the complete healing. Same patient, after 1 step on the pavement in July, after he finished his dialysis session, this is the result, big blister in his palantir. He advised by one of the colleagues to use the wet to dry povidone solution for 1 month, and this is the result. You can see all the blister outer layer, it was completely necrotic and dry and adherent.
2 minutes
Once
more.
One more case, then I'm finished. Once we received this patient, we started silbadiazine cream twice a day, and you can see how soft becomes the dry and necrotic tissue, how it becomes soft, and it's slowly taken down, and complete healing achieved within 4 months. Another case, transmetatarsal amputation. This patient, after we have assessed, you can see from the greenish necrotic tissue, confirming the Pseudomonas infection. We started with acetic acid with dry for 2 weeks. Then we continue with the negative pressure wound therapy until the wound bed become ready for successful skin graft. Plastic have done it. Sometimes you didn't need to think about it too much, but you have to do a little bit of action and it makes difference. The time between these pictures and that pictures, it was only less than 2 minutes. So you have to be very careful. If you are skillful enough doing the sharp debridement or conservative sharp debridement, go ahead. It makes difference for the patient and prevent the further damage. So you can see proper wound management follows vigilant and very careful wound assessment. And the dressing is very important part for the local care, but a clinician must first consider, assess the wound, the patient, then assess the wound and set up the treatment goal before jump to the selection dressing. And periodically, every 2 weeks, you have to reevaluate and set a new plan for the patient, either to continue or to change your dressing protocol. So you have to put in your mind, there is no miracle dressing that can heal the wound if underlying etiology are not addressed. Control blood sugar level, treat the infection. Revascularization is very important as needed, and offloading. And thank you so much for listening.
Thank you for all speakers for today and for very good talk and great talk with very good time management. And just now we'll go for Dr. Hani.
Okay. Thank you so much. We'll just take a few minutes تكريم المتحدثين to save time because some of the speakers they're leaving now. So can you guys start with Saad? Can we start? Where is Nusayba? We can give you later on time for the discussions, but we have to finish this part because some of the speakers are leaving.
عرفانا من اللجنة العلمية واللجنة المنظمة نود تكريم رؤساء الجلسات والمتحدثين. دكتور محمود صلاح، دكتورة مرام الخطيب، دكتور ثامر الناصر، دكتور يوسف التويجري، الدكتورة نور جناحي، دكتور عبد العزيز الطعسان، دكتورة حياة الصالح، دكتور نشأة غندورة، دكتور سامر بندكجي، يعطيك العافية دكتور. دكتور عبد الحليم نور والي، دكتور نزار باهبري. دكتورة سارة العمري. دكتور أحمد الطوب. دكتور محمد لكلوك. دكتور سامر بندكجي. دكتور عبد العزيز كيماوي. دكتور عصام خضر. دكتور إسلام فهمي. دكتور بدر العمري. دكتور ركان الحارث. دكتور وائل السيران. دكتور هيثم البشري. دكتور عبد العزيز الغراس. دكتور باسم المالكي. دكتور سامي طبيب. دكتور محمد الدرويش. دكتور عبد العزيز الكنعان. دكتور عبد الرحمن الصقعبي. شكرا، يعطيكم العافية.
يعطيكم العافية جميعا. شكله بعض السبيكر لسه نايمين. We'll start with the second session إن شاء الله. Saad, where is Saad? Saad, can you introduce the second session? And then after the second session, we'll go for break and pray time. Okay, good luck for the rest of the day.
So the second session for today will talk about diabetic foot infection and stomatitis. And the modulator for this session will be Dr. Nashat Ghandoura and Dr. Muhammad Hatem. Please welcome them.
السلام عليكم ورحمة الله وبركاته. واضح الصوت؟ Not working? Assalamu alaikum wa rahmatullahi wa barakatuh. Good morning, everyone. Our first speaker will be Dr. Samir Bundakji. He will speak about diabetic food infection, osteomyelitis, diagnosis and management for diabetic food emergency gas and wet gangrene. Okay, please, Dr. Samir.
Good morning. I've been given the task of presenting on diabetic foot infection and osteomyelitis. هذا البوينتر كليك من هون. اوكي علي الصوت شوي. طيب. Okay, good morning again. My name is Samir Bundokji. I'm for an ankle podiatrist over at Johns Hopkins, and I will be giving you a lecture today on diabetic foot infection and osteomyelitis. Just a little preview. We know that diabetic foot infections are always challenging. They require involvement of multitude of specialties, which make it always difficult for surgeons because they don't like to work with anybody. Dedication of the health provider to the patient, because these patients usually require a long follow-up. And most surgeons like just to do the surgery and then see the patients 6 weeks later. But if you're doing diabetic foot infection, then basically you're seeing the patient a few times a week, sometimes for a very long time. It also takes adherence of the patient to the treatment, which really makes or breaks the treatment, and also patience on both sides, and some luck always helps. Sorry. How do you, can you bring it back one slide, please? All right, just some guiding principles. A blood supply is paramount to anything we do with the diabetic foot. I'm sure you all know that. The second thing we look at is the infection status, how severe or moderate or mild it is. We look at the ulcer bed status. We look at the general health of the patient. And then we think how we're going to offload whatever surgery that we do and how reliable the patient is if we are to do that surgery. The treatment is really very simple when you break it down to just its basic properties. We're going to do a debridement, an incision and drainage of the abscess. We're going to use antibiotics that are appropriate for that infection. We're going to use the proper dressing. Ms. Hayat talked about that. We're going to do proper offloading, and also Dr. I think Tuwajri or somebody talked about that. When we do the surgery, we follow sound surgical principles. We remove all the devitalized tissue. We go down to bleeding bone. We don't leave any dead space. We always take x-rays before, make sure that we know what we're dealing with, and we take x-rays after to look at what we have done. We manage the whole patient. Multidisciplinary team is paramount in these cases, and also the speakers earlier spoke about the importance of that. Okay, so basically just what I said, the patient comes in, has an abscess and an ulcer. You know, as you can see, you know, if you squeeze a little bit, there's a drip of pus coming out, we debride it, we clean it, we manage the dead space with the vac, and then it starts to improve and get better. The size of the wound assessment, I'm sorry the slide didn't come out really well, but basically we just assess the wound just like some of the speakers earlier spoke about, as far as width, depth, length, the shape of the wound and why, the quality of the tissue. We talk about the wound margins and the surrounding skin. And we always ask, why is the ulcer where the ulcer is? So we always, say location, 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 because that will help you with your treatment if you can figure out why it's there. Is it the contracture? Is it a joint immobility? Is it a deformity? Instability of a joint? That will always help you in determining exactly how to get the best outcome. When it comes to the infection, the way we look at it is we look at the how bad is the cellulitis is there an abscess or there isn't an abscess? Is there an exudate like pus or so, or just serous fluid? We look at the odor and the biofilm. We look at the whole patient, like I said, systemic signs, fevers, loss of appetite, malaise, uncontrollable blood glucose. And we look at the healing rate. Is it slow? Is it friable tissue? Is the granulation tissue friable, or is it healthy? Because a lot of times, these patients look okay, but the underlying infection is really going on, especially with osteomyelitis, as we will see. And if the patient is not getting better, or your granulation tissue does not look healthy, you really have to think an underlying infection and just not go on with just dressings. Okay? I'm sorry, I think the slides must have gotten mixed up when they were transferred, but this is really the classification of diabetic foot ulcer infection when we have a clean one. It is just that, there's nothing, there's no surrounding erythema or edema. You don't need antibiotics for these. A lot of doctors do prescribe antibiotics. You don't need antibiotics for these usually, and you don't need very advanced dressing. Okay, for mild infections, you'll have a little bit of erythema around it, and then usually it is about 2 centimeters around. For this one, you need an antibiotic such as Augmentin, something that will cover most gram-positive and negatives. You don't need to worry about MRSA so much, or anaerobic. When you have a severe one, then this is when we come in and we start doing all kinds of work, such as incision and drainage, taking it to the OR, debridement, sometimes partial amputation, and so on. So infection and drainage is really detrimental for the outcome of these patients unless we do aggressive debridement and we do aggressive antibiotic therapy. Sometimes we double or triple cover these patients, then they don't do so well. Okay, I'm sorry, something happened with the slides. They are not coming out like I had presented them. But basically this slide would have showed this foot and then the surgical intervention and amputation. That's not the same foot on the right side. But basically when we do these amputations, what we need to do is to make sure that we go down to clean tissue and that the patient is revascularized before we do anything. And I think vascular surgery was talked about, or will be. The patient, before revascularization, after revascularization, makes a huge difference when it comes to surgery as far as the level that we can amputate at. And this is an example where revascularization really makes a difference. You can see this patient came in, would have had a 4-foot amputation at the least, but with revascularization, patient only lost 1 toe, and we were able to save the foot because of that. So I'm sorry, this is, I'm gonna have to stop, Hani. something went wrong because all the slides are mixed up. Is it possible to go to the next speaker and I sit down with IT and figure out, because it's
Definitely,
all
no,
jumbled.
no
and
problem,
it's
Doctor.
not coming out.
Yeah, go ahead.
All right.
We can.
I want to apologize to the
Yeah, we can go with the.
to you,
second
but
speaker. Please, Dr.
unfortunately, the slides are not coming out at all. and
It's okay,
They're all
Dr.
jumbled up.
It's okay.
This should have been like 20 slides from now.
It's okay.
Okay, so I apologize. In order to give you a proper
No worries, Dr.
presentation, I will go just deal with IT now. I'll be right back.
Okay, Dr. Samer. Okay. Our next speaker will be Dr. Abdul Halim Nurwali, Consultant General Surgery and Diabetic Food in King Abdul Aziz University, Jeddah. He will speak about the diabetic foot emergency, gas with gangrene, necrotizing fasciitis, puncture wounds, early identification, and fast action. Welcome, Dr. Abdul Halim.
Welcome. Thank you. I would like, first of all, I would like to thank the organizing committee for inviting me to this conference room and to give a lecture to this subject. موية هذه
Sorry for the technical error. We can continue. I will continue. Not to present for Dr. Abdul Halim. So you can see the curriculum. We started yesterday with the Gulf experience in diabetic foot. So we just take you on a journey in the Gulf area, Egypt and Iraq. And then we went from the beginning of diabetic foot, how you work up the diabetic foot. We start with the vascular evaluation, when you refer the patient to the vascular surgeon, when you order the vascular studies, and then how you do the endovascular. And then we start with the most important, controlling diabetes, how you control the hemoglobin A1C, and what's the effect of hemoglobin A1C and diabetes control on diabetic foot complications. And then we advance more. We start to talk about complication of diabetic foot, diabetic neuropathy, and then Dr. Sami went over diabetic foot syndrome. And then after that, we start with ABC of diabetic foot. As you can see in the morning today, we spoke about history, examination. History is very important in diabetic foot, is the spot diagnosis. We don't have to order like advanced imaging for diabetic foot. Just by looking to the patient, examining the patient, you can identify at least 95% of the diagnosis, and then you can add the labs and imaging to help you with the reaching to the final diagnosis. I think Dr. Abdulaziz Al-Tassan, he did a wonderful job and show you how to work up and how you order imaging for diabetic foot patient. And then Dr. Noor and Saad Al-Faiz, they spoke about the importance of biomechanics is really important in diabetic patient. I think the key in treatment of diabetic foot, when you are ready, I'm ready, okay? I will talk till the end, I don't have any problem. So we'll continue with Dr. Abdul Halim Nurwali just to cover the technical error. Please welcome Dr. Abdul Halim again.
Let's speak about diabetic foot emergency for identification and fast action. Diabetic foot. Diabetics can lead to peripheral neuropathy and impaired blood supply and compromised immune function. This condition increases the risk of ulcer, foot ulcer, infection, and subsequent complication. Diabetic foot emergencies can critical situation that demand immediately attention to prevent the further mobility and potential amputation. Diabetic foot emergency such as gas gangrene, necrotizing fasciitis, and puncture wound are serious complications that require early identification and fast action. This presentation will discuss the importance of the recognized diabetic foot emergencies and their clinical feature and necessary steps immediate to intervention. What the difference between gas gangrene and the necrotizing fasciitis? They both destroy tissue and can be fatal. Necrotizing fasciitis is a subset of aggressive skin and soft tissue infection that can cause necrosis of the muscles, fascia, and subcutaneous tissue. Also, gas gangrene, also known as myonecrosis, is characterized by rapid progressive gangrene of injured tissue, along with the production of foul-smelling gas. The same bacteria can cause both of them, but gas gangrene is usually caused by Clostridium perfringens, and necrotizing fasciitis is usually caused by group A Streptococcus or Staphylococcus aureus. The risk factor. There is gas gangrene and necrotizing fasciitis are more frequently in diabetics, alcoholics, immunosuppressed drugs, IV drugs users, peripheral vascular disease, may occur in young, healthy, and individual. Sign and symptom. The bacteria reproduce. The fast change might be seen in the skin over just minutes or hours. Some of the symptoms are skin discoloration. It might be pale, dark red, or purplish in color. Large bubbles, blister that are red, brown, or dark red, or dark green, or blackish. Air pocket under the skin or in the fluid inside the blister. Foul smelling fluid draining from the blister. A crackling feeling sound when touching the blister called cryptus. Fluid draining from the gas gangrene blister are often described as foul or botrytis. Sign and symptom, early sign and symptom and late. For skin puncture or injury, lead to erythema around it, and warmthness around it, and tenderness, and myalgia, and pain out of proportion, fever and swelling. Later on, can lead to hematic gas bully, and necrosis, and purple or bluish color, skin color, and cryptus, and sensory motor deficit. Later on, can lead to hypotension and mental confusion and multi-organ failure. Diagnosis is a history and physical examination and imaging, X-ray, CT scan, or MRI can show the gas bubbles change in the muscle tissue. Bacterial staining or culture are important. Imaging, subcutaneous air or gas is a hallmark on the X-ray, on CT scan, and on MRI, which give rise to cryptus on examination. This is radiological imaging, or shows gas here. This is CT scan, shows gas here and here, the leg. MRI shows gas here in the CT in MRI. Classification by location of lower limb extremity, based on the etiology. Type 1, polymicrobial infection. Type 2, monomicrobial infection, Lancefield. Group A, Streptococcus, Staphylococcus aureus. Type 3, monomicrobial, Clostridium species. Type 4, fungal infection, most often with Candida. What does necrotizing fasciitis look like? Here, the puncture of the tattoo, first of all, here the tattoo. And then this is lead to erythema around it, and redness around it, and myalgia, and fever and pain. Later on, can lead to bully formation and can lead to cryptus formation. Second one, post-traumatic patient. This one can multiple injuries and lead to erythema around it and cryptus formation, and bully and cryptus formation. Third one, post-cellulitis, which is strange. Cellulitis can lead to erythema around it and bully and myalgia, and then swelling to the lower limb, and then bully formation, and then cryptus formation. What is complication? Complication, gas gangrene can lead to life-threatening complication. Include renal failure, sepsis, and septic shock, and multi-organ failure. Management, fluid resuscitation, immediately surgical debridement, and early fasciotomy. Start on IV antibiotic with aerobic and anaerobic coverage. Infectious disease consultation. Don't delay for lab result. Surgical management. Surgical debridement required excision to the healthy margin, which often extended proximal to knee, below knee, and above knee. Healthy margin were noted surgically by bleeding skin and skin adherent to underlying fascia. Obtain multiple fluid and tissue samples for culturing. The indication and technical aspect of negative pressure wound therapy have been studied for necrotizing fasciitis after debridement, which is often circumferential. Surgical must be prepared for urgent debridement, extend into the lower limb region. Limb disarticulation is a surgical decision based upon limb salvage, potential life over limb. Treatment of adjunct and wound closure. Wound coverage, when not possible by direct suture, can achieve by either split thickness skin grafting and tissue transfers.
1 minute more, Dr. Halim.
Okay. Hyperbaric oxygen therapy is beneficial, and this increase getting into the tissue and then kill bacteria. Negative pressure may be used to promote the healing and wound culture. Antibiotic for Neisseria for antibacteria can cause polymicrobial and can cause for Streptococcus and Clostridium perfringens. Antibiotic regime is often penicillin, clindamycin, subrubate, and vancomycin and aminoglycoside. For this study was done in 2018 in Europe, discuss about necrotizing fasciitis, treatment concept and clinical result. This study, 15 patients over 21 months, and 2 patients underwent limb amputation. Diabetic was assigned with a significant high risk of amputation. The mean of hospitalization was 32 days, including 8 days in the intensive care unit. The author conclude surgical therapy is indicated if necrotizing fasciitis is suspected. Negative diabetes mellitus was a clinical predictor of the limb amputation for necrotizing fasciitis. Ampicillin, salbutamol, and clindamycin and metronidazole are recommended. In summary, the main high level of suspicion for severely painful traumatized area is in critical ill patient. Aggressive debridement of affected tissue and early fasciotomy is crucial. The laboratory investigation is not a definitive, but it can be assessed in diagnosis. Administer IV antibiotic immediately. Give priority to saving the life over the preserving the affected limb. With soft tissue reconstruction, consider at later stage. Thank you.
Thank you very much, Dr. Abdul Halim, for a nice presentation. Discussion will be there. We'll call again Dr. Samir Bundakji. He's consultant pediatrist in Aramco. He will talk about diabetic food infection, osteomyelitis, diagnosis, and management. Welcome, Dr. Samir, back. Thank you.
Thank you. Sorry about the mishap. We'll start over. Are we good? Okay. Okay, we'll just try and start exactly where we ended, so I don't bore you. So, for clinical evaluation, we take a thorough history and physical of the patient, including vital signs. The vascular exam is probably the most important thing in this patient because it determines how much we can debride and how much tissue we can resect. Observe for fever and chills, tachycardia, tachypnea, just the normal stuff. Of course, there's going to be cutaneous compromise with these patients. There's going to be a draining sinus. It's not going to smell good. Look for underlying disease and immunosuppression. A lot of these patients are on steroids. Locally, when you look at the foot, there's going to be a local induration, some fluctuance when you put your hands and try to palpate. 33% of this type in the feet of the hands. In the foot, just like the hand also, has fever leukocytosis, so only 33%. So these patients will really come with a really bad infection, but they don't look typically like a sick patient that you would see that is not diabetic due to the immunocompromised status of the patient, and also the neuropathy plays a role here. So with infection, we look for cellulitis, abscess, exudate, odor, and biofilm. Systemic signs, we look for fever and loss of appetite, malaise, and uncontrollable blood glucose. And sometimes in some of my patients, this is the only thing that looks weird, which is, they tell me, even though I'm taking my insulin, I cannot control my blood glucose. Also, you have to look at your healing rate. Sometimes these patients, you see them, you do a little debridement, they come back, the granulation tissue does not look healthy, something does not look right, and usually there's an underlying infection. The treatment, like I stated, is really straightforward. Starts with debridement, incision and drainage of the abscess. We take proper cultures. We start them usually on a big gun when it comes to antibiotics. and then taper down according to the culture that we take in the OR. But usually we start big and we taper down rather than the opposite. We do proper offloading post-op because that's also helps with the healing. We follow sound surgical principles, like I said, with debridement of unhealthy tissue, going down to bleeding bone, not leaving any dead space. We take x-rays before and take x-rays after, and usually internal medicine, infectious disease, and everybody else is on that team. And, we talked about this before, so I won't bore you with it. This is a classic clean ulcer that does not need antibiotics, just needs wound care. So that would be a no infection. A mild infection would have about 2 centimeters of localized erythema and cellulitis. The white blood count will be elevated, and these patients will need coverage with antibiotics. The ones that we are really concerned about is the moderate to severe, which require a trip to the OR as soon as possible, because really the incision and drainage of these feet is detrimental to the outcome and usually determines how much tissue you lose. The sooner you go into the OR, the less tissue that you'll be able to use. And this is when we double and triple cover with these patients. So aggressive antibiotics, incision and drainage, coverage with triple or double, like I said. And you don't have to worry so much about MRSA or Pseudomonas with these patients. Just basically gram-positive for the most part and gram-negative sometimes. But before amputation, and usually this is the second or third trip to the OR, just make sure that the vascular status of that patient had been optimized, because without optimizing that vascular status, you're not going to be able to get good bleeding tissue like the one you see in the middle picture here, which is, like I said, I think is the second or the third trip to the OR, and then you would get a functional amputation. I spoke about this where the patient only lost one toe. And also when you take these patients to the OR, if you know that you're staging yourself, just be careful of what you take and what you keep. Stay cognizant of the next thing that you are going to do. So basically just plan your surgery so you end up with a favorable outcome rather than burning your bridges at the very beginning. Sometimes HBO helps with these patients, like, in patients with severe infection and necrotizing fasciitis. But really we want to talk about today is osteomyelitis, which is what the talk is about. And osteomyelitis is basically just an inflammation of the bone and the bone marrow, which is caused by a bacteria. The classification is straightforward, and this is the one that we use. Basically, you get medullary osteomyelitis, which is mostly in hematogenous osteomyelitis. We see that in kids and in older people. And then you have superficial osteomyelitis, which is basically an inflammation of the cortex or infection of the cortex. We usually don't see those two in the diabetic foot. The two that we concentrate on or that we see often is type 3 and type 4, which is localized osteomyelitis in the marrow or a diffused osteomyelitis. And we'll see examples of that. I just want to touch on one thing. There is something called osteomyelitis associated with vascular insufficiency. This is what it would look like. This is the MRI, this is the X-ray, and this is the patient. 35% of cases fall into these. Usually those are elderly people that have areas that have necrosed and the bone got infected. Usually it's a low-grade infection. It's not really a fulminant infection of the bone. We will not talk about this much, but I wanted to just touch on it and say that there is such a thing as osteomyelitis associated with vascular insufficiency. The diagnosis of osteomyelitis, usually we do it by, we see it by X-ray, radiographs. You see a periosteal elevation, you see destruction of bone, and you see irregular bone margins. Pathology-wise, we rely on the bone biopsy that we send. And usually it comes back as either bone necrosis, fragmentation of bone, or inflammatory infiltration, leukocytosis into the bone graft. Clinically, we go by the signs and symptoms that we had talked about, because the osteomyelitis is usually what is underneath the infected tissue that we had debrided and looked at earlier. So we go by the signs and symptoms, a probe to bone, and I'll talk about this a little bit longer on the next slide. Excuse me. We go by laboratory parameters, and we follow usually white blood count, sedimentation rate, and C-reactive protein. This is what I use to follow my patients clinically. So the diagnosis of diabetic, and also I want to talk about sausage toe. A sausage toe is exactly what it looks like. It looks like a really fat toe, and usually there's always osteomyelitis underneath. You don't need an X-ray even to confirm. If you look at it, it's gonna have osteomyelitis. So sausage toe is osteomyelitis in toes. And always take X-rays, because you will be surprised with some of these patients. You take an X-ray, and I'll show an example a little bit later of an ulcer. People don't take X-ray, and when you take an X-ray, you look at complete destruction of the bone. So the probing to bone, it looks really simple, but it's really important. It's important because if it probes to bone, the likelihood of osteomyelitis is extremely high. It's about 95%. And the reason I put this slide is because this looks like a very simple ulcer. It's a small ulcer. This patient comes and goes to the clinic. But if you take a Q-tip or a cotton tip applicator and you put it in and you can touch the bone, you can bet your bottom dollar that this is osteomyelitis. And it works almost every time. Okay, and Dr. Gourini out of Beth Israel in Boston did this study. He presented it in 1998 at the American College of Foot and Ankle Surgeons meeting, and it was published in the American Journal of Foot and Ankle Surgeon. In the American Journal of Foot Surgery, where 211 patients were taken, and all their ulcers were probed. A small metal probe was used, and this was the distribution of digits, metatarsal heads, midfoot, and flatfoot, and rear foot rather. And of the 95 patients that were probed to bone, 88 had osteomyelitis and only 7 didn't. And the ones that were negative for probing to bone, only 3 out of the 60 had osteomyelitis. So the likelihood of it probing to bone having osteomyelitis is very high, and if it does not probe to bone, then osteomyelitis is probably not there. So what does it look like on X-ray? Well, you look at bone destruction, fragmentation, joint erosion, and periosteal reaction or elevation. And actually this foot, which is one of my patients, had all of them. And you can easily see that, there's, whoops, sorry. You can easily see that, there's bone destruction and loss of the joint. You have bone fragmentation. You have periosteal elevation and reaction over here. So this is what it would look like on X-rays. And look at this toe. The ulcer looks really simple, but when you take an X-ray and you look at the amount of destruction of the bone, you know this is not going to heal unless you do something to the bone also. But remember that these X-rays can be 14 days behind, and I'll show an example of what happens in 14 days. The bone is really, if you suspect osteomyelitis, treat osteomyelitis, and just don't rely on X-ray. An MRI today is almost mandatory. It's a standard of the care. Before, it used to be, when I was a resident, an MRI was reserved only to really difficult cases. But now, nobody would forgive you, basically, if you don't do an MRI and discover osteomyelitis early. And this is one of my patients, and the picture on the left, or the X-ray on the left, is exactly 14 days before this X-ray here. And you can see the amount of destruction that happens in 14 days. This was infected, of course. The patient had an ulcer. It was a probing ulcer. The patient was lost to follow-up, and then when he showed up exactly 2 weeks, which is when the ER had made him an appointment in my clinic, this is what it looked like. Of course, we took him to the OR. We had to resect some of the bone, put antibiotic beads, and the patient did well. And I'll show an example of another patient that we did the same thing. MRI imaging, like I said, is part of the standard of care now. Nobody will forgive you for not taking an MRI. Now it is available in almost every hospital and not that expensive. It does have false positives and false negatives that you need to be aware of. The false positives is the ones that we really concentrate on, which is mechanical stress, post-op. Sometimes if you had operated on the bone marrow will give a high signal. Inflammatory arthritis and Charcot, of course, always will confuse osteomyelitis with itself. So on MRI, you're gonna see a low T1 signal and a high T2 signal, and I'll show an example of that. And usually osteomyelitis is fluid sensitive. And this is what it would look like. And I think the radiologist spoke at length about this, but for my purposes, and I'll show this patient in a little bit, this is an infection in the first metatarsal. You can see the uptake compared to the other bones. And this is what it looks like on coronal. And this is a fifth metatarsal head infection here.
Left,
you can see the other metatarsals are dark or black, and this one lights up. Nuclear medicine is used when we cannot, when the MRI is indefinitive and can differentiate bone from soft tissue infection, and radiologists also talk about that. Technetium is not enough. You'll need gallium or indium or a leukocyte tagged in order to differentiate osteomyelitis from something that is false positive. And this is what it would like. This is the uptake here. You can see it. So how about antimicrobial treatment? Like I said, for type 1, which is the hematogenous, usually antibiotics alone are enough. For type 2, and you get very, very good results. For superficial osteomyelitis, which is type 2, 2 weeks of antibiotics following superficial debridement is usually enough. Type 3 and 4, which is the ones that we use, that we usually deal with, you need 6 to 8 weeks, and the arrest rate is about 90%. Although there are studies now that show that only 3 weeks of antibiotics is enough, IV antibiotics is enough. The reason we used to use the 6 to 8 weeks, because originally those studies were done on the heart valves, not even bone. So there are a lot of updates when it comes to the length of IV antibiotics. Now, 3 weeks of IV antibiotics following your last debridement is usually satisfactory, but it also depends on the patient. When it comes to surgical management, our goal is to leave healthy, viable tissue. And you can see, where you go down to bleeding bone, that is, and bleeding tissue, and no necrotic tissue or devitalized or non-viable tissue should be left. So that is really important. Okay, so surgical management, if you look at this ulcer, it doesn't look really that bad. It's been there forever. Patient comes and goes from the clinic. The X-ray clearly shows chronic osteomyelitis, and that will not heal without dealing with that. Antibiotics alone is not going to do it. So we resect the head, we move it, we put antibiotic
Can you
beads.
conclude your presentation,
The use
please?
of an external fixator is usually really helps with stability. Okay. If there is a deformity, correct the deformity. A lot of these toes will have a deformity at the tip of the toe, either a flexion or a contracture or a dislocation at the joint. And if you remove just the distal aspect of that toe, you get rid of the deformity and the ulcer at the same time. So if you have a toe like this that has an ulceration, without dealing with that deformity, that ulcer is not going to go anywhere. So here's a recent example. Patient has a flexion contracture. You can see the ulceration on the plantar aspect of the toe. And, you remove it. There's no bone inside at all. You can see from the resection, and then it is closed, and the patient gets rid of the deformity and the infected bone, and healing is really gets faster. With the fifth metatarsal head, this is one of the easiest ones that we do. You can remove it. Okay, I'll go fast. We can remove it. We always use a dorsal incision with these, and it heals really. By the time you remove your sutures, usually the ulcer is healed. This is the metatarsal head. Go through a plantar approach. This is the one that we showed the MRI earlier. You put antibiotic beads, and it heals really, really well. Also, on the heel, we debride, clean it, and after antibiotics, we go back and we close it. What to send to the OR? This is what you really want to send to the OR is the most proximal margin for pathology and for culture, because this is what you rely on as far as the follow-up of the patient. Okay, so what you want to find when you leave the patient is a strong cortex, no residual necrosis, no discoloration, and bleeding bone. And what you want to take out is soft bone, anything that is gray in color, non-bleeding surfaces, necrotic, and non-viable tissues. Okay, and I'll skip this one just for the sake of the time. And in summary, really, early diagnosis and aggressive therapy is essential for these patients. Always take x-rays. The minute that patient steps into your clinic, the first thing we do is take an x-ray. Nuclear medicine lab studies and MRI should be used when appropriate to help you with the diagnosis. Specific antibiotics therapy and surgical intervention should be always used when indicated. And thank you very much for your attention. Sorry.
Thank you so much, Dr. Bundugji. I think you have to give 5 minutes to Dr. Nizar Bahabri because you stole it from him. And please welcome Dr. Nizar. Nothing to say about Dr. Nizar. Thank you for his time. He's very busy and he's well known in infectious disease. He's always with us. He's supporting us. We hope we can finish in time, Dr. Nizar.
I hope. Assalamu alaikum wa rahmatullahi wa barakatuh. بسم الله الرحمن الرحيم والصلاة والسلام على رسول الله. رب اشرح لي صدري ويسر أمري واحلل عقدة من لساني يفقهوا قولي. Good morning, everyone. I would like to thank the organizing committee and thank Dr. Hani for inviting me to see everyone again for diabetic foot. You are about to hear the most important lecture in the conference. As you all know, Dr. Tuwaijri described to you the importance of radiology to know how long you are going to give antibiotics. And you monitor your diabetes for antibiotics to work. And you do vascularization for antibiotics to reach. And and Dr. Maram will take him to OR to clean the dead tissue for antibiotics to work. And Dr. Saleh will do dressing to clean for antibiotics to work. So it is the most important lecture. The whole conference is for my beloved antibiotics. They should work. خلاص? Now you know how important it is. So it's a challenge to take care of diabetic foot. There is a lot of things. Duration, length of hospital stay, weekly wound debridement, mobilization, IV versus PO. You need to know home health care. They should be your friend. Chronic renal failure, antibiotics needs to be adjusted. And all of this will take cost. So let's do appropriate antibiotics. This is according to the new guidelines of IDSA in 2023. The most important change in the guidelines is how much they emphasize about picking antibiotic based on culture. The previous guidelines used to say, let's do culture, it's polymicrobial, let's do that. The new guidelines emphasize about the importance of having culture, because we are dealing with a lot of multi-drug resistant. And if we look to our society, to our country, then the needs becomes worse. We have a very high multi-drug resistant organisms, so getting a culture is very, very important to pick the antibiotic. So biopsy. Please, always remember, I love when you ask me about antibiotics, but please do a good biopsy for me. Okay? You do superficial thing, this is not appropriate. When you do culture, I love the people who love pus. They love to send pus. Anyone who loves to send pus, please take it home with you. You can keep it for yourself. I do not treat pus. I treat tissue. Tissue. So when you are taking a swab, take it from an appropriate thing. I love when I tell people, please put normal saline over the wound. Get rid of the pus. He will tell me, the pus will go away. I say, drink it. I do not treat it. So take from the periphery, please take from the periphery. I need good swab. If you can take a good swab, it's okay, but if you can take with a needle clean thing, it's good. If you can take me the tissue, this is the real issue. This is what you need to do, because you do not send me a dead tissue and tell me to survive. Antibiotics are not gonna bring things alive. Remember, please do not treat the shoe of the patient. When you send me a very bad swab, you want me to treat the shoes. So whenever I see 10 things in the swab, I know I am treating the shoes of the patient. So I need one bacteria to treat appropriately. So give me the tissue. So antibiotics. What can we use? So I will just tell you the process of picking any antibiotic. Please just remember those 4 steps. First, you need the stability of the patient. Everything will depend on the stability. If the patient is stable, then you have to think about the organism. If the patient is stable, you treat the most common organism. If the patient is unstable, you use multiple antibiotics to cover every single organism that can cause the disease. Then you will need to make sure that your antibiotic is going to reach the place, because it is very important for antibiotics to reach there. You need to know, are you treating a soft tissue? Are you treating a bone? Is it good to reach there or not? So the treatment plan, whenever it's severe infection, debridement, surgery, IV antibiotic, you use everything in your hand, vac, hyperbaric, whatever you can use because the patient is unstable. Then if the patient is stable, you have to think about 2 things: duration of treatment, IV versus PO, and the cost. So IV versus PO, I decided to go for education about PO antibiotics, because there is a very good data based on, since 2019, based on the OVIVA study, that oral antibiotics will work very well for the bone and will work for diabetic foot. So let's learn more about oral antibiotics. Which one can be used? I will tell you about the drug of choice as an outpatient. Please remember, we have gram-positive, we have gram-negatives. I know people hate micro. Gram-positive, you have Augmentin, Bactrim, linezolid, and clindamycin. Those ones will work great for your gram-positive. Your gram-negative, you have 2 choices as an outpatient. Cipro, which is Cipro means levo, and ertapenem, which is IV or intramuscular. So ertapenem given once a day. Ertapenem will cover your ESBL. Ertapenem can be given intramuscular and IV. It will cover your gram-positive and your gram-negatives. So just remember, in micro, you have gram-positive and you have gram-negatives. Always in the skin, always in your soft tissue, you have gram-positive. Gram-positive are 3: staph, strep, and enterococcus. 3 big ones. Staph is like al-uzzab, single people. They are always together, powerful, all around. They have very tricky ones, like MRSA. You can't, it's MRSA, it's singles. Just remember, whenever people get engaged, they become strep, diplococci. They should be found inside the tissue. And when you want to remember, how can you remember the strep? Where are they? You just remember engaged people. The lying period, وقت الكذب. Okay? So, what does they do, the engaged people? They talk. صح, they talk. So, otitis media and pharyngitis. Why do they talk? To take care of her brain. يبقى يقنعها إنه مرة كويس. So meningitis. How does he lie to her? He will tell her, I breathe your smell. Pneumonia. خلاص? And what do he dream always? Going back and forth. So osteomyelitis, septic arthritis, and cellulitis. So it's not difficult to remember strep. Enterococcus is when they become married. They are in chains and brain. They are in the stomach, in the abdomen. Whenever you see it in the wound, you have to worry about the patient cleanness. So you should never see enterococcus. When there is enterococcus, this guy is not taking care of his wound. This is stool inside the wound. So always remember there are 3. Gram-negatives are the biggest, E. coli, Klebsiella, and then everyone loves in diabetic foot Pseudomonas. So I'll take you over. This is oral antibiotics for MRSA. So those are very important oral antibiotics. It will reach the bone. Bactrim, clindamycin, linezolid, doxycycline, and rifampicin. But please do not use rifampicin as alone. The one next to MRSA is coagulase negative staph, and always surgeons forget coagulase negative staph. Although when there is a wound like diabetic foot, it should be there. It is the one اللي دائما always the surgeons will say, we see pus, we do culture, it's negative. It's your coagulase negative staph. It is coagulase negative staph that will work after your wound becomes infected in diabetic foot after 2 weeks, 1 month, 3 months, and then you will have cellulitis in the same wound. It's coagulase negative staph. So coagulase negative staph, those are the oral ones. Bactrim, you cannot use Clinda for them. Moxi, Cipro, or Levo, linezolid, rifampicin. So always remember, a lot of them, they need IV vancomycin. So, clindamycin, gram-positive, staph and strep, and this is why whenever you have a cellulitis, clindamycin have anaerobic coverage, does not have gram-negative, great reaching bone, reaching very good, but the only one, you do not give BID clindamycin. BID clindamycin is for the vagina, and diabetic foot is not a vagina. If you ever see a doctor prescribing clindamycin, BID, this is vagina doctor. This is not diabetic foot doctor. Okay? It should be Q8 or Q6. Unless you want to give him clindamycin to amputate him later on, this will be another choice. Clinda, not BID. Q8. خلاص? Q6. Bactrim. Does not have strep, but it have great gram-negative. It reaches the bone very well. It deals with ESBL. So if you see a gram-negative, that is ESBL, sensitive to trimethoprim sulfa, then trimethoprim sulfa. It's a great one. It do a very good coverage for MRSA, but no strep. It does not have a very good anaerobes, no Pseudomonas. Then a lot of people, they forget about doxycycline. Doxycycline covers everything under the sun. Gram-positive staph, strep, enterococcus, MRSA, coagulase negative staph, gram-negative, except Pseudomonas, very long gram-negative, anaerobes, atypical. It covers even malaria. It have antifungal activity. But people say we do not use doxy because we worry about under the sun. Although you have to understand, we do not see the sun that much in our community. So you don't worry about doxycycline. And do not forget that you can have an infected bone, osteomyelitis, in our community because of brucella. Do not forget brucella. Whenever you are seeing a bad bone, do brucella titer. You will be amazed how many times you will have brucella related. Okay, linezolid. Remember, it's gram-positive. It's like your Vanco oral. It covers all the gram-positive, have no gram-negative. Okay? It doesn't have anaerobes. Vancomycin. Please, if you still see a doctor in your place who is prescribing vancomycin, 1 gram BID, this doctor is just 25, no, let's say 15 years behind. Not so much, only 15 years behind. So Vanco is milligram per kilogram. Whoever prescribe vancomycin, 1 gram BID, he is only in changing antibiotic science since 15 years. Vanco is milligram per kilogram, and you will need to reach a trough level of 15 to 20. You will need a trough level before the half an hour before the 4th dose. Vancomycin cannot be given 1 gram BID for everyone. Gram-negative, Pseudomonas. Always remember, Pseudomonas, Cipro, and Levo. Whenever you see Cipro-resistant, it means most likely Levo-resistant. So no oral. Minium Cipro-resistant, no oral. You need IV. Those are the common IV one. Piperacillin, tazobactam. Please remember, for Pseudomonas, piperacillin, tazobactam should be high dose, 4.5 Q6. Ceftazidime, cefepime, meropenem, and imipenem. Those are your ones. So, just to remind you all, Levo have a certain standard. It have gram-positive strep compared to Cipro. I just want to show you. If you are using for diabetic foot, if you are want to use Cipro or Levo, remember, Cipro, no strep. Staph, yes, no strep. So Levo have strep, staph, and Pseudomonas with your gram-negative. So if you are picking a single agent, it should be Levo, not Cipro, because you are going to lose strep. And you can reach up to 750 once daily. Cipro, please, no strep, no anaerobes in Cipro. And also, please, very important, remember, if people are using warfarin, there is a huge interaction between warfarin and Cipro, warfarin and Levo. Whenever you give Cipro, it will make the warfarin works very high. So unfortunately, I have seen diabetic foot with people coming with INR after Cipro 3 days, INR of 11. I have had 2 patients dying in the past 3 years because of misusing Cipro with a doctor did not ask about warfarin, did not adjust warfarin dose. Wallahi, I have seen him bleeding everywhere, brain, eye, dead. INR of unmeasurable whenever you are using Cipro, keeping the warfarin the same dose. Very dangerous. You need to adjust it. Just remember, then we go for the last session. about our multi-drug resistant, the CRE, ESBL, and multi-drug resistant. I am sure a lot of you see gram-negative ESBL. You can see E. coli ESBL. You can see Klebsiella ESBL. Proteus ESBL. Whenever you are seeing ESBL, those are the oral for ESBL. Bactrim, Cipro, Levo, and Moxie even, the whole fluoroquinolones with Bactrim. But start with Bactrim. Keep your Cipro next. If you see trimethoprim sulfa is sensitive, use trimethoprim sulfa first because you will need it later on. You will need the Cipro and Levo. Remember, Cipro and Levo, now there is a lot of studies which will show it is the most important agent for your patient to develop multi-drug resistant. It's an inducer for multi-drug resistant. So keep it behind, use Bactrim, then use Cipro and Levo. Other IV is your meropenem and imipenem. Do not forget ertapenem because it's once a day. When it becomes as multi-drug resistant, then you all have to be away from colistin. Colistin is not an antibiotic, it's a detergent. It is for you to kill the patient. You use it whenever you cannot use anything anymore. He's already dead, so you are going to use it for him. Maybe it can save him. Colistin should not be a choice of yours in the beginning. It's only gram-negative and it's only for multi-drug resistant. Tigacycline, a lot of people, they love tigacycline. Tigacycline have gram-positive, gram-negative, MRSA, ESBL. It have multi-drug resistant coverage. It have a lot of things, but remember it's bacteriostatic. It is not approved for osteomyelitis. Tigacycline should be used whenever you cannot use other agents. It should not be your first choice, especially in emergency or if the patient is sick. Tigacycline, remember, have 2 black warning FDA that it will increase mortality since 2010, then 2013. If you are using tigacycline, tigacycline is associated with mortality. So remember. Our new kid in the block is ceftazidime avibactam. This is the one that we go to now whenever we are out of choices. It's a very good antibiotic. We are using it only in different. When it compared to colistin, it showed a significant increase in survival compared to colistin.
Dr. Nizar, 1 more minute, please.
I am, last slide. And the last one for multi-drug resistant Pseudomonas is Zerbaxa, which is ceftalozone tazobactam, which have a great opportunity for whenever you have a very multi-drug resistant Pseudomonas. So by this how, now I run through all the antibiotics. Remember, antibiotics are your friends. Oral is as good as IV if you know which to use, but we need the culture. And this is why I just put in summary, this is what you should do. Those are the antibiotics. Those are the duration. And I thank the previous speaker, doctor, who spoke about the importance of 3 to 6 weeks on osteomyelitis. It is a big change. Chronic osteomyelitis, you might use up to 6 months to 3 months antibiotics. It's okay. And by this, I will finish. Remember, antibiotics is the most important. This is why we have Dr. Maram now to take us through surgery to clean the dead so antibiotics can work. Thank you very much.
Thank you very much, Dr. Nizar. Okay, our next speaker, Dr. Maram Al-Khatib. She is a general surgery consultant and diabetic food in King Abdulaziz University Hospital. She will talk about the surgical management of diabetic food infection and osteomyelitis. Welcome, Dr. Maram.
أنا ماني عارف كيف الدكتورة مرام حتقدم بعد نزار.
مو لسه بدي أقول السلام عليكم.
نقفل الكونفرنس ونمشي أحسن.
أول شيء السلام عليكم جميعاً. Thank you, organizing committee, for your kind invitation. And another thank you, but in a sarcastic way, for putting my lecture after Dr. Nizar Bahabri. It's actually a big challenge بس ساعدوني إن شاء الله وإحنا نكون قدها. Thank you, دكتور نزار.
بالعكس صح الناس يا دكتورة ترى.
Okay, so I'm gonna start regarding surgical management of diabetic foot infection and osteomyelitis. The part medical, Dr. Nizar, mashallah, tabarakallah, he covered it very well. Let's talk about surgical now. When you are telling about or talking about surgical and diabetic foot infection, we mean exactly incision and drainage, debridement, conservative surgery, minor or major amputation. What does it mean, debridement? You have to clean the wound bed by removing all the debris and necrotic tissues, stimulating the edge of wound, release growth factors, and reduce the inflammation. There is a lot of modalities, a lot of types. We have autolytic, biological, enzymatic, mechanical, and the surgical with the multiple modalities. Ms. Hayat Al-Saleh, she did a good part in this, so I'm gonna jump to the next step. My important part, we're gonna focus on the surgical. For the best outcome, always remember the surgeon must understand microbiology, pathophysiology, and behavior of the infection, and this is what Dr. Nizar covered. Wound management principles, shukran Ms. Hayat Al-Saleh. Food biomechanics, thank you Dr. Noor for that. It's not what you put on, but what you take off. This is the most important thing by Professor Armstrong, and it means the techniques of debridement and offloading as we had in the previous lectures. The surgical goals, usually you have to put in your mind, what's your aim in each surgery? Our aim is to control the deep infection. The second will be hoping to saving the limbs. Keeping in mind, any residual food, it may have some abnormal pressure points and risk of re-ulceration. So, when you think about it, always pus drainage, removing all necrotic tissues, we have to have a good functional results, keeping in mind at the start, we have a good vascularity and for sure, a viable tissues to cover all the defects. This is some examples of pus drainage. You can see how huge the amount of pus is coming from the leg. This is the end. In this stage, the surgeon will be happy. Nice, clean base. All the necrotic tissues are out, and you have still skin coverage and no more necrosis. If you do any operation, you have always to think, if you have any toe infection, any infection in the plantar of the foot, keep in mind the anatomical extension that you have to expect when you have any ulcers on the lateral side. The fifth toe, think about the extension on the lateral compartment. And again, for the second, third, and fourth toes, think about the extension at number 2 central compartment or the medial compartment in the hallux. And don't forget, usually, the interosseous compartment, as it's shown there. The pointer is not functioning well. Anyway, this is some examples for that. So when you see any wound at the big toe side, at the hallux, when you did debridement, you may reach till this level of opening and cleaning all the tissues. This is the results that we want. All the necrotic tissues, all the tendons, any part of infected plantar fascia, all has to go away. So your wound gonna heal in a proper way. Again, when you think about another wound at the second or third, you think about the central compartment and for the lateral compartment, as you can see. Putting in mind vascularity. This is what we mean by keeping in mind vascularity. If you have any problem with the vascularity, you have to do angioplasty first, revascularization, and the target will be getting rid of all the necrotic tissues and to reach a good healthy area with good vascularity so you can stop at that time. When we decide, can we continue on our conservative approach or we have to go for higher level of amputation? If I don't have enough tissues, this is why I'm putting this picture, to just show you that if I have a good tissues to cover any exposed bones, covering the limb, this is gonna help me to continue in our conservative approaches. I kept these two pictures here intentionally to see you. At some points, not always the wound will go in a very nice, smooth, clean, granulating, because most of the doctors are putting the start and then the final results, and it's amazing. But you have to keep in mind, all the surgeons gonna face these points when the tissue is gonna have some necrosis, some on and off infection, and this is we can deal with it by multiple debridement bedside, multiple debridements on and off with other local wound care dressing materials. When we see, always we heard about, heal doesn't heal, and we want to break this. Not anymore. We have a lot of successful stories in the heal. Not all the patients, but at least most of them. If we think that we may survive, we may success to survive the foot. This patient, diabetic hypertensive, ischemic heart, end-stage renal disease, she had all the comorbidities with this ulcer and osteomyelitis at the heel. After revascularization, good debridement to the bone, to the calcaneal bone. After that, we reached to healthy and good wound closure after 6 months. A young patient, neglected, uncontrolled diabetes, he just like left a wound without good care. And this patient was offered an amputation of the hallux. With good debridement, we reached to have a good healing within 3 months. Another patient with wet gangrene to the 4th toe, and debridement was done again. This picture was put in here intentionally to show you for how far we can go with the debridement. We have to remove all the necrotic tissues, all the fascia, to the level that you're gonna think that this wound will never close. And you can see here even the depth going down till the insertion of the plantar fascia. And we succeed, bifadlillah, and the wound was closed after 17 weeks. Every surgical procedure on the foot has the potential to alter the mechanics, and it affects the function. The careful and experienced surgeon will consider the bony alignment, weight-bearing surfaces, and soft tissue coverage during the planning of any diabetic foot infection procedures. Keep in mind, re-ulceration is a frequent event following resection of metatarsal heads. The highest will be after the first metatarsal head resection, and the lowest will be after 5th metatarsal head. And this is gonna make the difference between the experienced surgeon and the rest of the surgeons. The idea, thinking about good offloading, thinking about the optimum custom-made insoles, and the best diabetic foot shoes for these patients. Reasons to consider major amputation. When we're gonna decide that, I believe that Dr. Nasser Al-Hamidi had a talk yesterday about this topic. Just to make it simple, if the patient is unstable, extensive tissue loss, non-functioning limb, medically unfit for multiple surgeries, or long duration of antibiotics therapy. And here you can see some of the minor and major amputation. When we say minor, we always telling about the area or the level below the ankle. Now we're going to talk about osteomyelitis. Diabetic foot osteo is the most frequent infection associated with diabetic foot ulcers. It occurs in more than 20% of moderate infection, 50 to 60% of severe infection. As Dr. Bundugji said, you have to keep it in mind. When you have any ulcer, any wounds with the probe bone positive or it's deep, you have to keep it in mind. This patient may have osteomyelitis. Don't wait till you find all the X-ray imaging pictures to full picture so you can say it's osteomyelitis. You have to keep it in mind to start treating it, so after 2 weeks you may see the changes. It's challenging in diagnosis and therapy. Most of the complications are related to late diagnosis and delayed referrals. How the diabetic foot osteo can start it? This is like what was already described before, but you have to keep in mind, either by direct extension from the soft tissue or by the blood. Most serious consequences of diabetic foot ulcers is major and minor amputations. It makes the life expectancy so short, and it has a very high mortality rate, and you can imagine that. Minor and major amputation has a mortality rate higher than the most common cancer, known cancer in our country and in the world, like prostate, colon, and breast cancers. Management. So first, proper and early diagnosis, appropriate culture either for the bone or wound culture, and this is what was already explained by Dr. Bahabri. Surgical intervention if needed, wound care. I'm just gonna comment on one side. If you wanna take a bone culture, please don't take the bone in front of you. As mentioned before, cleaning by isotonic saline, don't use antiseptic, don't take the bone or the fragmented bone in front of you directly because this will be colonized with different organisms, as Dr. Bahabri said. And there is a lot of studies supporting more to go through another wound, not from the same ulcer, to take a good bone biopsy with the infected organism that you want to treat. Recent literature corroborates antibiotic as the first-line treatment for diabetic foot osteomyelitis. With this study, we have to close all the discussion, and Dr. Bahabri will do all the work. But this only for small forefoot lesions that easy to offload, and if the surgery can do more harm than helping the patient. So when to use the medical treatment, if the patient is stable and the patient prefers to avoid surgery or he's very high risk to go for surgery, he can tolerate appropriate antibiotics. You don't have to go for surgery for another infection, or it's not in acute on top of chronic with a lot of debris and infection or pus discharge. If there is a financial burden and the patient cannot afford to go for surgeries, unavailability of skilled surgeon, operating room, or other facilities. If the infection is confined to small forefoot lesion and easy to offload and a benign organism, you can go with the medical treatment. Pros and cons with the medical treatment. The advantages by the absence of biomechanical changes and cost effectiveness. Regarding the cons, risk of recurrence and ulceration, toxicity, and the adverse effect of the antibiotics. So there is a good systematic review in comparing the medical versus surgical treatment. They concluded that management of diabetic foot osteomyelitis remains challenging and no available evidence is sufficient to identify the best option. يعني في الأخير, we don't have any guidelines properly fixed that when to go for medical or when to go to surgical alone. Still, there is a lot of things has to be changed according to the availability of the surgeons and the facility and all the experience of the working team on these cases. Conservative surgery, this is the most common types of conservative surgery that used for diabetic foot ulcers or osteomyelitis. First, partial or total distal phalangostomy. So if we are talking about biomechanics, if you have a distal phalanx, like of the hallux here in this picture, you can see we can do a small incision, cleaning up, debriding the bone as you see in the post X-ray, and the wound closed within 7 weeks. So arthroplasty of the proximal or distal interphalangeal joint. It means when there is a wound at the joint side and osteomyelitis in the interphalangeal area. And you can see here hallux interphalangeal joint arthroplasty as it's shown in the X-ray, and the wound closed after 9 weeks. If the wound is in the interdigital diabetic foot ulcer, in this way, again, arthroplasty gonna be the management of choice and the proper choice of surgical approaches to clean the area, removing this toe, and to have a very nice results with a good functioning foot, and we didn't play or alter the biomechanics of the foot. Distal cyme amputation, this articulation of the distal phalanx, mainly at the hallux, and you can see here it's shown clearly with a nice plantar flap, and the wound closed within 10 weeks. When you're talking about percutaneous flexor tenotomy, this especially for the patient with foot deformities, and this is one of the most important, our risk, hazards, and burden to have an ulcer as a risk factor. So when patient had already an ulcer at the tip of the toe, debridement, phalangostomy in the second toe with percutaneous flexor tenotomy, and you can see here, and this can be done also as a clinic setup. Sesamoidectomy and arthroplasty of metatarsophalangeal joint. Here is a case with a good debridement and removing of the proximal phalanx and combined with the killer arthroplasty. This kind of procedure always to be done for the hallux valgus deformity, or what we called it for bunion, if there is an extra bone and having high risk of developing infection on and off. Metatarsal head resection, as you can see, there is 2 approaches for this procedure. We can keep the toe in place, only removing the head of metatarsal, and can be done by the plantar approach or in the dorsal approach, and there is a lot of studies in between having the same wound closure rate and time. And you can see here, we removed here the 2 parts. Actually, this is a case, a systematic review of Professor Ladaro and his team from Spain. So they concluded at last that it's a safe and effective option of diabetic foot ulcer with chronic osteomyelitis. It increases the chances of healing with reducing the possibility of limb loss, and if it's compared by the radical amputation. Here is some of our cases, of my cases, if I can say, with my team. When you have a patient with third third toe with gangrene with osteomyelitis. You can see the wound. It's typical osteomyelitis. And we did conservative surgery for him. Alhamdulillah, we reached a good results with a good shape and wound closed within 4 to 5 weeks. Again, another osteomyelitis at the tip of the hallux. Debridement was done. And this articulation of distal phalanx, and you can see a good results and ended by healed wound within 4 to 6 weeks. This is another patient. Actually, it has the same thing with gangrene of the hallux, with osteomyelitis, but for this patient, I went only with medical treatment. He was an old, fragile, 70 plus, blind, has all the comorbidities of diabetic foot and the diabetes in general, of uncontrolled diabetes, good vascularity. So I was so encouraged to clean all the tissues, and I did not touch the bone, only good biopsies, and he continued in 6 weeks antibiotics, and finally, alhamdulillah, the wound closed. Another patient, just to emphasize in the importance of the vascular assessment and vascular intervention. So this patient came with peripheral vascular disease, the second and the third toes was already dry gangrene. I was trying to escape from this patient. He had very bad heart, very bad vascular status, and he's non-compliant as a diabetic control. And they told him, just wait till these toes to be sloughed out and it will be auto-amputated, until he got an infection, and I was stuck trying to save this 2 toes or the foot as possible with this very poor vascular status. Actually, debridement was done. At the same day of surgery, the 4th toe started to be congested. And I used all the wound management secrets and magics and all the things, the adjuncts that can help for having a good oxygenation, like hyperbaric, infrared, whatever can help me on enhancing and increasing the vascularity for this patient, I used it. Until we reached to this area. All the wounds are closed, but with longer time, as you can see, 18 weeks. 2 cases already left now. The thing that they have all common in 2 things. When you have a wound at the posterior part of the leg, of the foot, I mean in the calcaneus part, to think about the tendon Achilles. Is it related or not? This infection is involving them or not? So this patient had an osteomyelitis of the calcaneus simply after the MRI showing that at the attachment of tendon Achilles. So operation was done by the help of my colleague and my friend, Dr. Hani Badahdah, and we went for the first surgery, cleaning up the first, as you can see here, the wound, cleaning the bone up with Dr. Islam, also Islam Fahmi. And then we ended, alhamdulillah, by a good wound. After 2-3 weeks, the patient started to have good healing in some parts, and another wounds was draining pus, so another operation was done, underwent. The patient underwent for another debridement, and after that, by 2 weeks, the wound closed totally. Again and again, another tendon Achilles rupture and infection, osteomyelitis at the heel, at the calcaneus, and you can see we reached till the moment that all the people around me was telling for amputation, major amputation, go for amputation. How many times up and down? One day will be dry, the other day will be wet, and the bone started to be exposed more. Debridement, drilling, antibiotics, we tried all the things here until we took him again, a good debridement, negative pressure wound therapy, started to have a good healthy granulation bed. We were so encouraged to go for skin grafting, and you can see it failed, and only this small part that survived from the skin graft. And I left it, and this is the result. We ended up by good wound, healed, closed, bifadlillah, within 10-month treatment, 3 hospitalization, and 4 operation. I keep always putting these dates and time because this is most important. This is the most important points that gonna be always attacked by the other surgeons. The health of stay, how many surgeries, the cost effectiveness, the burden, and all of these things. So always we emphasize on the duration of treatment. And we succeeded to publish this case already. My last patient, this is one of the challenging, maybe some of you will not accept this, but this is what we do usually. This is what we face in our life. A patient 41, he's in early 40, he is young, diabetic, he had all the comorbidities, reached to have end-stage renal disease, hemodialysis, weak muscles, ischemic heart disease, weak cardiac muscle, and very poor circulation by vascular status. He
1
went
minute,
he-
دكتورة مرام.
هذه آخر slide. So big toe amputation was done, and then unfortunately you can see all the osteomyelitis started to expose to talk. An ideal way is for transmetatarsal amputation plus or minus major amputation if this is not success. So after that, he was telling me, I don't want to do that. I want to keep the toes. So I told him, okay, listen, whenever you go for any conservative surgery, I keep it clear with my patients. We're going to go for that. It will be a long journey of wound management. At any point, we can stop this fighting or challenging journey to go back if you have any infection, any patient, any instability, or if your case, if you're getting or being unstable, or if the vascularity is not going well, or if you don't have a good coverage, or which is the most important also, the malfunctioning. If it's going to be a malfunctioning limb, so better to go for higher amputation. And I took the patient, removing all the metatarsal heads, as you can see, and we reached a good part. And alhamdulillah, these toes, it's not so floppy with the fibrosis. It's like almost attached in a good way, and the patient is so satisfied and so happy for that. Thank you so much.
يعطيك العافية. ما أنت بعيد عن دكتور نزار، ما شاء الله عليك. The next session is going to be a company presentation as appreciation for their support and continuous support. The next speaker, Hazim Al-Dabbas, Medical Professional Affairs Manager. He will talk about essential component of diabetic foot treatment. Please welcome Mr. Hazim.
Thank you, Dr. Hani. Thanks very much, and I really appreciate it. It has been really fruitful and nourishing knowledge, after hearing from Dr. Bundokji, from Dr. Nizar, from Dr. Maram. It was really great. So shall we start, please? Thank you. Okay. It's not me, okay. Okay, so I'm just going to fly with the presentation because I've been told that it was 20 minutes, then 15 minutes, then 10 minutes, okay? I was afraid that the last message from Dr. Han will be, okay, thanks for the presentation, you can go home now, okay? Okay, so, okay, now, I'm going to speak about the facts of diabetic foot injuries. That the principle aim to treat diabetic foot as early as possible, because whatever we saw, during Dr. Maram's, presentation, it was really great, but, it was a late admission for the hospital. Patient actually tends to ignore sometimes, tends actually to be late, or sometimes will be afraid of the amputation that they won't, accept in their life. So, I was thinking about, just to have something really, close and direct on how to speak about the management of the diabetic foot. So, I would say that the diabetic foot treatment should be actually composed of two things, prevention and treatment. Prevention will speak about treating underlying factors, which we all know, ensuring adequate blood supply and oxygenation, and then pressure offloading, which is really important and essential, and I think we need it in our region. Then we speak about the wound management, that is infection, debridement, exudate management, pain management, and edema for the patient. As we know that 85 of amputations can be avoided, but in some studies, it says that 75% of people will die after the first amputation in 2 years. So we have to be very careful in these things. Treating the underlying disease, just to cut it short, it's really too long in there. I used to say in my lectures, if you don't treat the cause, the wound will not close. Do you agree with that? Typically, most of our patients, I've noticed that in my experience, if you do amputation for the patient, he thinks that you have removed the problem so that the patient tends to go back to his normal life. No, so treatment of the underlying cause is very, very important. Stabilizing the patient, treating the diabetes, also smoking, stop smoking, blood pressures, vascular disease, kidney disease, all of these things should be stopped. Then after that, ensuring adequate blood supply. I always say that keep your patient VIP. The patient with diabetic foot injuries and diabetes, keep them actually VIP. VIP means what? Vascularity, infection, pressure offloading. So vascularity is very, very important. Before, thinking about the dressing itself, think about adequate blood supply for that area before touching the patient. Then oxygenation of the wound. We know that oxygen is necessary for extracellular matrix during the granulation or proliferative phase is very, very important because we need it for energy. It's essential. Somebody will say that during granulation phase that, hypoxia can drive the extracellular matrix. No, this is actually just for 20 days or 24 days. But after that, it's a burden. So we need to supply the patient with some oxygenation, which is really important. And we have loads of methods available in the market to do so. But I think, it's better to have some vascularity, or it's better to have sometimes, local thing that, can encourage the revascularization, because the granulation phase, it's really essential to have two things, angiogenesis and collagen synthesis during the granulation phase. The pressure offloading, we were discussing that yesterday, and I was insisting on three things: offloading, 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 especially if your patient is having a neuropathy. It's really essential. Then be aware that in case of an acute spreading of infection, and we have seen loads of cases today, loads of osteomyelitis cases, in case of infection, critical limb ischemia with gangrene or unexplained hot rod, swollen foot, or without pain, okay? Remember that we have to involve everybody. I used to say something in a quick way, just we need to do something that can say, do a CPR for the patient. You know what CPR? Okay, it's not a cardiopulmonary resuscitation, okay, which is the most emergency thing in the hospital, but we have to check the patient, check the blood, check the eyes, the kidneys, the feet, the skin, and we have to do what? Protect if there is any problem, and then after that, refer the patient. For me, if I want to refer a patient to the hospital, I would refer the patient to the whole hospital, not only single specialty inside the hospital. Okay? Infection, everybody spoke about infection. I think Dr. Nizar, he did, he spoke about infection in a very, very great way. So I'm not going to focus on that, but really, infection for me, if I see, touch, or probe to bone for a patient with a diabetic foot, 90%, as Dr. Samir here said, 90% or 95%, I think, it's osteomyelitis. So we need to be very, very careful with that also. And we go at Charcot foot management. Everybody knows that, it's really essential. And for me, TCC, total contact cost, as early as possible, it can actually manage the things. Vascular status will always be determined prior to sharp debridement. Patient needing revascularization should undergo extensive sharp debridement. Sometimes I'm against this because, as I said, if I expose bone, that means there is osteomyelitis. I will be very careful in that. I will use different methods in debridement. So what is the benefit of debridement? We have lots of benefits for debridement: to remove necrotic tissues, reduce pressure, allow full inspection, help drainage, stimulate healing, optimize effectiveness of typical antimicrobials. Then, moist management. Now, the new approaches in the world is to keep the wound moist. Is that right? Okay, because extra moisture causes what? Maceration to the wound and damage. Okay, low moisture causes what? Dryness of the wound, so that, there is no granulation at all. So the moist management contains, lots of letters in there. Moist, M is moisture, O is oxygenation, I is infection control, S is support by all the means, and T is the tissue. So moist even, can be a management protocol for the patient with diabetes. So exudate management is very, very important. Use the, right dressing for exudate management is very, very essential. Okay, set up a criteria for selecting your dressing. Pain management, sometimes I think we need to focus on pain. When a patient, with diabetes complains of pain, many people say, no, it's not really a real pain. No, pain is a subjective issue. When a patient says that I'm in pain, he is in pain. But a patient with diabetic foot, if you agree with me, he feels the pain in a different concept, in a different way. So we need to be very careful with that, and we need to focus on that, because pain prolongs hospitalization if the patient stays in the hospital, which prolongs anxiety. If it prolongs anxiety, it causes what? Prolongs inflammatory phase in case of patients having any injuries. Limb edema. Edema can delay wound healability, so we need to be very careful in that. And if the patient is obese, intervention to aid less weight and to apply also any garments to reduce the edema for the patient. So it's really essential and approved. So in the summary, okay, it was really very quick. I think it took me less than 10 minutes, is that? Okay, in the summary, it's a holistic view. The last time I was counting how many people inside the hospital the patient should see, when he develops a wound. It was 29 specialties. 29 specialties inside the hospital. It's not only vascular, it's not only ortho, it's not only podiatrists. So everybody should see everybody. Also, holistic view, we should focus on the family, not only the patient. Okay? Clinical tools, we have loads of them available in the market. We have the Wi-Fi, Texas, we have the Simbad, we have the PEDIS. So we have loads of them. But, I think actually in Saudi we're just using a mix of them in some hospitals. Multidisciplinary foot team. We should guarantee that each hospital in here, contains a team for that, because it's a single specialty. Okay? Then reassessment. The evaluation needs to be done regularly. Okay? I've seen some patients, have been on antibiotic for 3 months or 4 months, or been on antimicrobial dressings, for about 6 months. Okay, what about that? There is a study says that, if the patient, if you are setting a plan, okay, you have to wait 2 to 4 weeks before thinking about changing the plan. If the plan is improved or improving the patient from 15 to 25%, you have to continue. If not, stop, revise your plan again. Okay, so it's really essential to think about reassessment of the patient with a multidisciplinary team, and if this result doesn't account for the wound depth, can be used as a management guide. So I think this is the last slide. I think I was flying. Okay.
I think Dr. Nizar make all the presenter or speaker to speak very nice and give a wonderful presentation. Good job, Hazim. Thank you so much. Thank you for Mulike for their support.
Thanks very much.
The next company will be Amico. They will talk about advanced wound care innovation. Mr. Hussam Bakri and Sandy Yaqub, they will talk about this. Let's see what they have. Please welcome them. Thank you.
Thank you. Actually, first of all, I need to appreciate the role of Dr. Hani and Dr. Abdullah Arab for this event. And thank you all for giving us this chance to be here. My name is Hussam Bakri. I'm the Operational Business Unit Manager in Amico, and my colleague Sandy Yaqub, she is the Product Manager in the Midline, Middle East and Africa. For today, we will, after what Dr. Hazim is present for all of us, we will try to give some translations for those with our products. Actually, in Amico, we have a vision called Surround the Specialist. With this vision, we always try to give all the end users the total solutions. Today, we will discuss 2 types of products. One of our very important products, like the Biologics, called Dermacell. This is one of the unique products. It's the human cellular dermal matrix. It's the real skin. Came from a company called LifeNet. It is the biggest tissue bank worldwide. This is a real human, and believe me, if you both in our booth here in the auditoriums beside, you will find amazing products, help you very good in the difficult to heal wounds. Actually, I will leave the floor for my colleague Sandy to introduce some information about midline and some unique products we will discuss today.
Good morning, everyone, and thank you, Hussam, for this brief introduction. Thank you, everyone, for being able to attend our presentation today, and thanks for giving us this opportunity to introduce today to you who is Midline and what are the solutions that we are providing to run the healthcare better and to facilitate your job. So I'm not going to take so long. It's going to be finished between 10 to 11 minutes. Okay. So, who is Midline? Midline is a multinational medical device company, was established since the 1966 in the US market, and it sells over 300,000 products plus in over 125 countries around the world. Actually, last year, we were very happy to be ranked as the fourth medical device company in the US and the global by the Forbes magazine. Of course, our mission is to entire the healthcare sector ranging from acute care, long-term acute care, physician office, lab, ambulatory, retail, and not only that, also we provide educational support to add value to our society. So Midline is a market leader in the major product categories around the world, and one of them is what I would like to highlight on is the advanced wound care that was ranked in the US market #1 in the previous years. So, advanced wound care. What Midline today would like to provide you with a new innovative and a new technology in the advanced wound care. As you all know, the wound care and the protocol of the wound care in the worldwide is to start with the debridement process, treating the infection, and of course to manage and assess the wound bed environment and support the product to enhance the outcome of the patient and the wound healing. So that's why we create a wound care navigator, as you can see, which was used as a systemic approach in the wound healing, and it's called DIMES. So DIMES stands for the D, the autolytic debridement, I is the infection/inflammation, M is the moisture balance, E, the edge, and S is the support. Today we would like to focus on two new innovative technology. That the first one is a silver hydrogel antimicrobial called SilvaSorb, and the other one is cyanoacrylate skin protectant called Marathon. I'm going to give it again to my colleague to have a review on the SilvaSorb, and then I will continue with you on the Marathon.
SilvaSorb is one of the unique products we have in Midline portfolio. SilvaSorb, actually created by Midline, it was the first company that bring ionic silver technology to the wound care market in a form of gel. It's a broad-spectrum antimicrobial activity. SilvaSorb also have a biocompatible with the intact and broken skin. Also, SilvaSorb indicated for all wound types with a light to moderate drainage. Actually, maybe SilvaSorb left in the place for 3 to 5 days. The very important, after Dr. Nizar sessions, that the SilvaSorb, it is a broad spectrum product. It's covered the gram-positive and gram-negative and the fungi. Actually, SilvaSorb, one of the products that has a powerful antimicrobial activity, starting with this study within 4 hours from applying the SilvaSorb. We try to share the experience of this case. They are using the SilvaSorb. Actually, it was a very hard cases. She came with the CFA, with the right. And actually, this case, if you see that we have a sacral wound and left heel wound, we start to dealing with the SilvaSorb in the same time. Actually, the left heel wound, it show progress rather faster than the sacral one. Actually, as you can see, the wound, it's totally closed within range between 2 months starting for the sacral wound and going for 2 to 3 months for the left heel. And it was by using this amazing product. Actually, the wounds show significant improvement with a complete cloth, with using also olivamine and repair cream beside the self-absorb. Actually, we would like also to invite you to try the self-absorb on our post. We have a sample there, so please don't hesitate to come and try this product. We will go now for the marathon one.
Thank you. So let's, now moving back to me, let's protect the skin with marathon. Okay. So what is marathon? Marathon is 100% cyanoacrylate formula that create a thick barrier on the skin to prevent any friction and irritation. This barrier, it's a non-sticky, so it won't it will prevent the dirt accumulation, and it will prevent the adhesion of any dressing or of any cloth. Not only that, it have a very nice and unique purple color, so it will give you an indicator about where did you already apply this skin protectant on the skin and when do you need to reapply it again. So it's a smart by itself, will tell you where did you apply it, when it's dry, and when please reapply me again. It will cover a huge area, so it will cover, we are talking about 8 or 10 by 10 inch, so it's like A4 paper size, and similar to those cases are, for example, the incontinence-associated dermatitis. Where we can use marathon can be used all over the body, head to toe. So it could be used, for example, on a plenty and variety on our body. It could be on the tracheostomy, it could be on the elbow, it could be on the heel, sacrum, could be combined with the negative pressure wound therapy, could be as well on the stoma and the skin tear, and too many applications. Let's talk about some of the clinical evidence that will show how much this product is effective and what is marathon or where we can apply it. I'm going here to show you that a patient who have a neuropathic foot ulcer, and that were being done on a different and multiple of the patient. So we were trying it with a negative pressure wound therapy. As you all know, main complication of negative pressure is the maceration. So we start to use the cyanoacrylate 3 times per week. And as you can see here, after 1 month of this usage, you can see how it becomes the granulating tissue healthy, and you can see it will protect and won't even leave the wound to be more larger. The second one also, it will show you here after the 2 weeks. So the result was very effective, and it will kick off the starting of the wound healing, and it will support to make it faster. Second one. Another application, incontinence-associated dermatitis. We have here a patient who were 73 years old, who have already diarrhea, weak anal sphincter, also having cervical cancer, hypertension, and pain rated 10 out of 10. We start to apply it here in the first second, as you can see it. On day 1, we try to even investigate. As you can see, it was a huge improvement in just the first day. And also after that, we asked the patient if they feel any pain, but thanks God, he didn't feel like any pain, and it was way more improved than the first day. We clean it again, and we start like to reapply it for the up to 7 days, which is 1 week. At the end, no pain was there, and as you can see here, we help the patient to improve their life and health. Lastly, we can use it under a medical device. Here we are trying to apply it on the skin around the tracheostomy. So as you can see, we try to use it and for multiple of patients, and here one of them. The result was to show that it found out the skin protector didn't cause any pain, no stinging, and it was dry in 1 minute, and no adverse event at all, and even it won't have any infection or side effect on the airway management. So by this, of course, we ensure and we help and support the nurse care with their time and significantly reduce that, and at the same time we are saving the patient health. Lastly, I would like to say thank you for everyone. شكرا جزيلا لحضوركم. شكرا. أنا وزميلي حسام استمتعنا جدا بمشاركة هذه المعلومات. أتمنى لو في أي سؤال موجودين نحن فيكم بأي time to pass to us and to have any more information. شكرا.
Thank you so much. Thank you so much. Now we have a 5 minutes discussions, please, and then we'll go for the break. I know it's a long session, morning session, and so we're running a little bit late, but we can compensate. So I think it was very beneficial session, and I think there is a lot of questions about surgical, medical treatment of osteomyelitis. Please, the speaker, come to the stage. Dr. Nizar, Dr. Bundukji, Dr. Maram, Dr. Abdel Halim. That's mine, I think.
For the audience, yes. Any questions from the audience? Yes, please.
Thank you so much for all the speakers. Actually, it was a wonderful session that I didn't want it to end. And Dr. Nazar, wonderful, wonderful session. I wish I had you in medical school. You would have saved me a lot of hours of studying with the boring professors and so forth. Amazing. So I have a dilemma. We have a very nice antibiotic stewardship at Cleveland Clinic, and we work very closely with them. And they're really up to date. They provide us guidelines. It's implemented in our EPIC, but sometimes the decision comes into the duration when it's not black and white. So, and this question for everyone, because, for example, every time I finish debridement, whether an osteotomy, a partial amputation, TMA, they always ask me, didn't you just finish all the dead tissue, the infected tissue? Then we don't need the 4 weeks, we don't need the 6 weeks, we only need 5 days soft tissue. And always, because of the foot structures always close to each other, and despite the fact I send proximal margin to rule out osteomyelitis, remnant osteomyelitis, and so forth, I still don't feel comfortable that I cleaned everything. The foot is such a close compartment with so many structures. So do you have an answer? What would you answer the infectious disease physician when he says, do you still think there is a remnant infection or not?
I believe that this is face us everywhere, not in your hospital only, in everywhere. I think it's the dilemma between surgeon, and there is, unfortunately, there is no good study to show that if you give 5 days, we all know that if you remove the margin, what people in infectious disease are thinking that if you are in 5 days post-op, your cultures are negative from your margin, that means that most likely you got it. Evidence did not show a huge number of relapse if you did not give more than 5 days. So if you have a clean margin. And in my simple experience, I will tell you it's a surgeon dependent. I have worked with surgeons who really know how to get a safe margin and to send a real good biopsy. And wallahi, I cannot emphasize enough about what Dr. Maram said about sending the appropriate bone that you want to make sure that it is clean. Wallahi, a lot of times, when even what I do is I ask the surgeons to always send for histopathology and for culture, just for me to make sure with the surgeon that what he sent is a liable bone, was alive. Because sometimes when you send to histopathology, you ask them, they will tell you, oh, that kind of dead bone. So you cannot judge this. But wallahi, if you have a good, clean bone, alive, and it was negative, 5 days will be good enough.
Okay. Please, when you ask a question, briefly, yeah, please, because we are short time.
Thank you very much. Actually, I will have long discussion with Dr. Nazar. The first question is, what about nephropathy, diabetic nephropathy with antibiotic?
So
what is the best selected drugs in nephropathy?
So I gave you all the choices. In reality, a lot of them, you have to watch. First, Bactrim will give you a false increase in creatinine. It's not true. You did not go into renal failure because trimethoprim sulfa will block creatinine from excretion. So don't worry about significant increase, even up to 30% increase in creatinine is normal with trimethoprim sulfa. Linezolid and doxy, no renal adjustment. You only need to adjust Cipro. Ertapenem, you don't need adjustment, 1 gram. So none of them will cause nephropathy or in reality, except vancomycin with a patient who is known with diabetic nephropathy. So vanco by itself in a normal kidney will not cause renal failure. Most likely there is a very good evidence about that. But if you have vanco with someone with nephropathy, you might get him worse. So this is why I will use linezolid instead.
I see. Well, the next one, can I continue or shall I? Only one. Okay. The next, about the topical antibiotic with beads, calcium sulfate beads, impregnated with vancomycin and garamycin. Your opinion about that? In this kind of very difficult cases, the one that my colleagues deal with, you all deal with as surgeons, wallahi, I will use everything. The evidence is not very strong about the effectiveness, but I always advise my surgeons to put it. Yeah.
I have seen good results, and you are dealing with a very difficult cases, do it. The most important I always emphasize is blood supply. Make sure that your blood supply is good.
Yeah. Well, thanks.
Yes, I agree with you, Dr. Nizar, regarding this piece. We are using it sometimes in difficult cases and it's giving a good result sometimes, yes. Any other questions, please? Yes.
Thank you very much. It's just a comment regarding the local infection and the systemic impact of this infection. I'm a reconstructive surgeon. Successful of the reconstructive procedure actually is a very good test for the completion of the debridement inside you. This is the best indicator.
One I always want to emphasize about coagulase negative staph whenever you are doing,
exactly.
So don't forget it. Some people with constructive surgery, they will come to you, successful surgery, 6 months later, he start to complain of pain that is unusual. This will be coagulase negative staph.
Yes, but that's don't relate it to the primary procedure.
Yeah.
Yes, exactly.
Please.
I have to let other people get involved. Dr. Abdul Halim, most of the time we see necrotizing fasciitis in emergency room. But sometimes we feel like, let's give the patient a chance. So would you run for major amputation, or you just give the patient, especially if the patient is young with a good blood supply, would you give him a chance for surgical debridement multiple times and then instead of go major amputation? Because most of the time, most of the surgeons, they just necrotizing fasciitis amputation. So would you, what's the criteria, or when you give the patient chance for limb salvage more than amputation?
First of all, examine the patient, okay, in ER, and then the decision taking from the surgeon. if he can see the bully and crypts formation inside, then he start to do fasciotomy, early fasciotomy. That all. And then admit it to the patient, and then we can see the progress. If progress more increase in the air inside the tissue, then we can go more aggressive. And then if it come more increase, then we can go for amputation.
So I understand from your answer that if the patient is like stable, and we can give the patient a chance. If the no progression and the patient responding well with intravenous antibiotic, then don't run for amputation. Thank you, Dr. Abdul Halim. And I like to involve all the speakers. Dr. Bundukji, most of the time we see sausage digit, but when you do the X-ray, X-ray is negative. Would you wait to intervene, or you just go for the surgery and do phalangostomy or resection part of the phalanx bone?
Excuse me. I don't just go by the X-ray. That's not the only parameter that I use to judge before I start the surgery or I make the surgical decision. Usually the blood count and the soft tissue envelope around the bone also tells me whether I need to intervene now or do I need to wait. So usually if there's an acute state, then I will go ahead with the surgery. If there's not an acute state, then I will wait and at least get an MRI just to see the extent of bone destruction or bone infection, so I know how much bone to take out before I do the surgery. In an acute situation, we always open, debride all fragmented bone, remove anything that is loose or non-viable. But in a chronic state, I would wait for an MRI at least, just to see the extent of infection before resection.
Okay, my question to Dr. Amaram. Regarding the cases of osteomyelitis, sometimes when you remove the bones, you have the remnants of the infection. Do you think this enough to give him more excision of the bone is enough, or you have to give him session of the antibiotics?
So again, Dr. Nashat, thank you for asking. If we have osteomyelitis and I did partial resection, I would make more, focusing more in the operation itself to get rid of all of the infected bone to reach to the safe margin, as we said, a clear, healthy bone. You can see the blood is coming from the bone, and take cultures from these bones and histopathology, as Dr. Nizar also said, with all the tissues around, making sure that you are leaving healthy tissues grossly, clinically. I'm not so sure about the microbiological, but I'm talking about grossly now, clinically in the OR, in the set. And then after that, good coverage. We have more tissues, or we think about whatever kind of coverage to do at the time, at the OR time. Keeping in mind, at least I'm gonna put my patients on 2 weeks antibiotics with the help of the ID team, because the usual that we do more than 5 days, I would like, if there is soft tissue infection, to treat the patient as soft tissue infection, not as osteo. If I removed more than 90% of the bone, supporting that whenever we get the results of the microbiology within 5 days, so I'll be sure if we have any growth or not, and here is the time that I'm gonna decide to continue or to stop the antibiotics.
I have a question, for all of the surgeons, especially Dr. Maram.
خلي بالك يا دكتور القاعة أغلبها سيرجن ده رح نهجم عليك.
I have a real question from my life story. I have a lot of patients. Dr. Maram, when she presented, she put a lot of cases and she said 10 weeks, 3 months, and this is after 10 months. I always have an issue, and he went for 3 surgeries, but at least we kept the foot. From an ID, maybe I see only the bad cases. I do not see a good articulation to the patient saying that we are gonna go for a couple of surgeries. It's gonna take us 3, 6, 10 months until it heals. When they come, a lot of anger in them. They believe antibiotic is not working and this thing. They do not know that it is usual in your specialty, that you will take them to OR a couple of times. It will take antibiotics sometimes to 6 months. They get panic. Nobody gave them the message. The surgeons do not give the full message about that it is a long care. We will most likely go to surgery a couple of times. You will need antibiotic for... I do not see this is articulated.
I think,
well.
Dr. Nizar, some of the surgeons, they don't have a good experience in diabetic foot surgery. So they're hesitant to make the decision. But when the patient go to specialized people, usually they give a clear plan. I think most of medical legal issues related to this point, because the patient is saying, oh, I have the surgery, I should be done. They think it's a tonsillitis or pharyngitis. So we tell them, the patient, it's going to be a long journey, a long time of non-weight bearing, a long time of non-immobilization, multiple surgery, or either you take shortcut, go for major amputation. But that's the issue. And what's the problem, especially in the training program, you know, consultant gives some idea, and then the specialist next day give the patient another option, and then the resident give them another option. The patient get frustrated, and then at the end they leave the hospital and they go for herbal medicine.
She already showed cases, and all of them is clear cut for her.
Because she's specialized and trained in diabetic foot surgery.
بس معلش عندي تعليق بس دكتور انه you cannot have an exact plan and you move the same pathway. ايش فيش فرق؟ Same pathway as all the patients. In diabetic foot usually 6 to 8 weeks for anyone to heal. Now you cannot give a plan for all the patients that it's going to be 8 cut edges. Expected, yeah, go for surgery one time or twice, but you cannot give it an exact plan that you'll go more than. Remember, there's a multi-factor, multi-comorbidities the patient will have. So let's say you do surgery and the patient heals. That doesn't mean that he will never have a recurrent ulceration. Same location, sometimes different location. So you cannot give an exact plan or how many surgeries you're going to do and what's the course of treatment. Yes, you're going to tell them that it's a long journey, and once you have an ulcer, you might have another ulcer.
And I just like that it is a long journey.
It's a long journey.
Yeah,
it's a long
this have to be stated clearly. لأنه أحيانا كثيرة they do not have this idea about it is a long journey. يقول لك والله سوينا وفشلت وسوينا
Okay. Just I have the last comments. Okay, Dr. Maram, you have comments? Okay, please. Yeah, we have to close this.
But this is an important thing, just for all the residents, for all the fellows. Okay. So this is right. And what I do usually with the patients, if I have any operations like this, especially for the last case, if you still remember it, the patient that has to go for TMA, but he was reinforcing every time and pushing me to keep the toes. I keep in every dressing and every time that I keep telling, again, anytime that you get infection, anytime your life will be at risk, anytime that you're gonna go for infections, more and more. If the kidneys function started to be tired, not tolerating antibiotics. If the wound is not going fine, if the vascularity started to be in a hazard, and every time I keep telling this, we may go back to the major amputation. You have to be clear with your patient, and what I think we can just summarize what Dr. Nizar said. It's a very poor communication way between the doctor and the patient. If you make it clear from the start, you will save yourself from a lot of complaints, a lot of going to courts, and a lot of problems if you are dealing with these kind of patients.
Okay, thank you, Dr. Maram. Yes, at the end, I have these comments. I agree with Dr. Hani regarding the limb salvage is important. Try to save the limbs as you can before the patient have major amputation with the high mortality rate. Thank you very much for all our speakers and our audience. I will close now the session. The session will come back at 12 o'clock. At 12 o'clock for the third session. Thank you.
Before you leave, we're gonna give just the certificate for the speaker who were not here in the morning. Thank you so much. 10 minutes for break, yes. دكتور إسلام فهمي. دكتور عبد العزيز كيماوي. دكتور عبد العزيز الغراس. خلاص ما هي مشكلة يجيبه. دكتور إسلام فهمي. عبد العزيز الغراس. دكتور عصام خضر. سارة العمري.
This. test.
we'll come back after the break, and we are going to start the fifth session of the conference. This session will talk about Charcot foot erythropathy, and the modulator for this session will be Dr. Kimawi.
Assalamu alaikum. We'll start with the Charcot arthropathy. Our first presenter, we're going to be talking about the Charcot foot pathophysiology and diagnosis. We have Sarah Al-Amri. She is a specialist podiatrist, and she has a good experience in this topic. Please come on.
Can I have a mic? I don't see people. You know what? It's okay. I'll take it from the doctors. Good afternoon, everyone. This is Sarah Al-Amri, a podiatrist at Dr. Jamal Habib Hospital. Okay. And today I'll be talking about Charcot foot pathology and diagnosis. First of all, I want to thank everyone for making, who were working on this conference and do their best to make it a success. First of all, our presentation, on our presentation, we will talk about definition, glimpse of history, etiology of Charcot, prevalence of Charcot neuropathy in diabetic population, clinical presentation, classification systems, assessments, and management. So what is Charcot foot or Charcot neuroarthropathy? Is limb-threatening condition that results in destructive joint disorder caused by trauma to a neuropathic limb. Why does it call Charcot? This is Charcot. He's handsome, isn't he? Joking. It was first introduced by, like Charcot, or this disease was first introduced by Musgers as an arthrology secondary to renal diseases in 1703. And more than 150 years later, Charcot came in. And it wasn't after Charcot because he was the first one to link it to, or to describe the neuropathic aspect of the disease, which was linked to syphilis at that period of time. And then in 1936, William Rayleigh Jordan was the first to link this disorder to diabetes. So what causes it? The etiology of this condition includes any disorder that results in spinal nervous system dysfunction, including infections such as syphilis, traumatic injuries to the spinal cord or peripheral nervous system, neurological disorders, neurodegenerative diseases, and rheumatoid arthritis, for example, surgeries to a neuropathic limb, and so on. However, the most common cause of this issue nowadays is diabetes. In order to understand why is it a big deal, we need to know what's going on now. With diabetes, we know it's very prevalent. And in Saudi Arabia, it's known that diabetes ranks the second highest in the prevalence of diabetes within the Gulf, and it's the seventh worldwide, the highest worldwide, and around 7 million of the population are diabetic, and almost 3 million are pre-diabetic. These are crazy numbers to be in one country. And the fact that we have Charcot too as a complication, the study says that Charcot neuropathy, or the prevalence of Charcot neuropathy within diabetic populations, range between 0.1 up to 30%. Not every study said 30%. The 12% and the 30% of the prevalence of Charcot neuropathy was actually mentioned by a couple of studies, which were conducted in a clinical setting where they check feet, basically, foot clinics. But the rest of the articles, they were general within the diabetic population. Let's say we have 6% of diabetic population who are going to develop Charcot, or they're at risk of developing Charcot. We're talking about, in Saudi Arabia only, about 420,000 people might be suffering of Charcot. And that is crazy. That is 500,000. And those people who are suffering of such a disease that actually misdiagnosed quite a lot, would suffer also from amputation of 50% of those people they are at high risk of an amputation. And guess what? 9%, so it's 15, and 9% of these 15 is major amputations. So this can come with a great morbidity, great mortality rates. It's crazy how dangerous this is. And in order to understand how can we, or in order to think of a way to tackle this issue, we can't tackle Charcot itself, but we can tackle amputation. So in order to understand this, we need to know what is the pathophysiology of the disease. Going into theories of Charcot, there is no well-known, let's say, a pathophysiology like exact one of the way that Charcot develops. However, there are many, many theories which were discussed in the literature, and these are the most common theories, which is the French theory, which was developed by Charcot and Mitchell, which states that damage to the trophic nerves or autonomic nerves can result in increased blood flow to the bones, hence an increased bone resorption and weakening and fractures. What we say is it affects the vascular, the neurovascular, it works on even cellular level, at cellular level, and that's what happens. And also, in addition to that, Volkmann and Virchow said the repetitive microtrauma to neuropathic foot leads to fractures that induces deformity during healing. So what happened is a combination of both. So there is a problem, there is a nervous problem, and that's for sure. And then what happened is there is also a vascular issue, and that's for sure. And the patient doesn't feel, so there is also outer let's say factors where the patient will keep walking in their foot like if they're fine, but they're not. And guess what happened? Further fractures. So this is how the Charcot would present in the clinic. It could present as an acute, and it could present as a chronic presentation. Looking at the acute, it's tricky because patients will come to your clinic and say, guys, I don't know why my foot is like that. Did you trip? No. Did you fall? No. Did you hit something? They would say no, but you're not sure because do they really know? No one knows. So they will come with usually unilateral edema, arrhythmia, warmth to touch. It could be painless, most likely painless because there is neuropathy. No signs of skin breakdown, most likely. Some cases it might be, but mostly no signs of skin breakdown. And there is bone deformity. Not always there is bone deformity. This is why we have the question mark. At early stage, the earliest stage, there is no bone deformity. It looks fine. It's just a little bit swollen, hot. But then later on, because of the no action taken upon this, the patient might start developing changes to the foot. There are classification systems that can be used to classify Charcot arthropathy. One of them is anatomical classification system. It's based on the pattern. Where does this condition occurs? As you can see here, there's patterns from 1 to 5, and it starts distally, proximal until distally until proximal areas or joints of the foot. We're starting with the MTPJ and the IPJ joints, where 15% of Charcot arthropathy starts there. The major, it's most frequently occurs at the Lisfranc joint, which is 40% of the cases presents there, and it's not less common, but let's say less common than the Lisfranc. It's the navicular cuneiform, telenavicular, and calcaneal cuboid joint, where 30% of Charcot cases starts there too. Moving into the fourth pattern, which is at the ankle subtalar joint, only 10%, and then at the calcaneum, which is really rare, 5% of cases occurs there. There is also the modified Eichenholz classification system. Basically, it's made of 4 main stages. And each stage has clinical findings and radiological findings to make it easier for you to categorize it and help others to understand at what stage this patient is. So the first stage, or stage 0, is an inflammatory stage. There would be localized warmth, edema, swelling, and arrhythmia. And looking at the radiographic findings like the imaging, you wouldn't see changes really. What you will see is normal foot. In some cases, if you do an MRI, you might see some, let's say, bone marrow edema. However, you wouldn't always see something at first. And then we have this stage 1, which is the developmental stage. There will be more swelling, more hot. The foot will be more hotter. The redness, there will be minor foot deformity, as I said earlier. There might be changes starting happening to the foot, and then you can find joint instability, ligament laxity, and so on, due to ligament laxity and so on. And looking at the imaging, you might find some focal bone demonization, bony debris. You might start seeing dislocations. You can also see subluxations and so on. Stage 2, where the healing starts, it starts but it doesn't really, because the patient is healing, but he's keeping doing the damage. There will be continued but decreased warmth, edema, arrhythmia, and more bone deformity. And you can see absorption of osseous debris at the imaging. You might see fusion to the fragmentations. You might see sclerosis of bone and so on. Then the third and last, stage number 3, which is the last stage, is remodeling. There will be no warmth anymore. The foot is not warmer than the other foot. There will be no swelling. There is no redness. The foot is fixed. It's changed. It's become the chronic type of Charcot. So as you can see here at the imaging, A represents a normal foot. Then moving on, you can see the changes happening at the less frank joint, moving on into dislocations, moving on into fractures and like dislocations of the bones. And this is then the stage where you can see a rocker bottom foot. There is a collapse of the arch. The foot is totally damaged because of the neuropathy, because of the Charcot. What are the differential diagnoses of the disease? You could say gout, trauma, inflammatory arthritis, cellulitis, osteomyelitis, and venous thrombosis. However, unfortunately, there is no one way to get to know, like, is this Charcot or not? Like, there is no one test that you can do and it tells you, oh, it's Charcot. But what we do is, it's a game, not a game, sorry. It's an excluding methodology. So what we do is, first we look at the patient's history. If the patient has a history of diabetes mellitus for more than 10 years, he's most likely to develop Charcot foot. We look at the other limb. If the patient had a history of the Charcot in the other limb, which could be another suggestion that the patient might have Charcot too. If he has peripheral neuropathy or trauma, that's another suggestion. We look, again, when we do laboratory testing or any blood test, what we're trying to do with the workout is just to exclude, let's say, infections. Let's exclude gout. Let's see if the patient has high HbA1c, because studies said that if the patient has high HbA1c, that's mean he's more likely to have Charcot. And then we do physical examination. There's a test called Brodsky test, where what you do is you lay your patient supine and then you elevate the patient's foot. If the patient, for 5 to 10 minutes, if the swelling reduces, that suggests the presence of Charcot. But if the edema persists, that is the suggestion of the presence of cellulitis. And there is also temperature checking. We can check using the infrared critical temperature monitor. We check for the foot temperature and we check between both feet. So if the foot that is red, that is swollen, is hotter, so it's with a temperature difference of 2 Celsius degrees or more, that's a suggestion of the presence of Charcot foot. So what is the most accepted criteria? Every guideline says if the patient come in with a warm, swollen, erythematous foot, with or without any surgeries or trauma, a temperature difference, and in some cases you might be seeing some slight changes within the imaging, then you need to consider Charcot straight away. Sorry. So if CN was not confirmed yet, the presented case should be treated as CN until a definitive diagnosis is made, so that the risk of foot deformity or other associated complication can be avoided. We can't wait until the damage happens. You may do the x-ray and then you wait for 3 weeks and the patient does the damage. Can you fix it later on? No, we can't, because the damage has started. Then what we should do is to start treating, because this is how it should be. So what do we do when it comes to the management? For managing the acute phase, there is immobilization, and with that we use total contact cast. We protect the contralateral limb. We can't, he's diabetic. If he has peripheral neuropathy, he has it in both limbs. We can't think of one limb and leave the other one. If we try to offload the right foot, let's say he had it in the right foot, we try to offload the right foot, we need to think about the left foot, because he could put more pressure into that one, causing further damage to the other one, causing whatever ulcerations and so on. And then we need also, some studies recommended biophosphate as might help with these symptoms. Some recommended bone stimulations. It's reported with offloading, reported an improved or a reduction in time of healing for like from 23 weeks up to like from 23 to 11 weeks, which is good basically. But there is a lot of evidence. However, the most important management is offloading, 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 offloading. The patient will cause trauma, because he doesn't feel, he will cause trauma. And if I know the patient will cause trauma to his foot, then let me offload it for him. We would use the total contact cast. We make sure that it's a rocker bottom so the patient can walk. We make sure that we use it until the patient his foot is basically, I wouldn't say the time 2 to 4 months exact, because the patient might still suffer of something. But like, we need to make sure that there is a resolution of the fragmentation and the patient has obtained normal skin, temperature, and things.
1 minute, yes, sir.
Almost done. And then the patient can use also orthotics and braces, and footwear should be personalized based on the patient's need. Sorry. So our surgical intervention useful for those people. A lot of doctors, they avoid even using a scalpel to debride the callus on the patient's foot. Despite others, they don't want to go into open surgeries with diabetics because they are not sure will they heal because of their complications. What we say is, or not me, them, they said that after 12-year observation period, after they did corrections to shortcut foot, they found that around 77% had favorable outcomes. Yes, there might some with negative outcomes of dislocations and etc., but surgeries can be a solution to prevent what I said earlier, amputations. So we're looking toward prevention, 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 which is the key of the whole shortcut foot management. Thank you for listening. And if you have any questions, please feel free to ask.
Thank you, Sarah, for the great presentation. Our next subject is presented by my colleague, Dr. Ahmed Al-Toub. Dr. Ahmed Al-Toub is a consultant podiatric foot and ankle surgeon. He's an American board certified in foot and ankle surgery. And he's going to be speaking about the medical treatment of shortcut foot. Please proceed, Doctor.
Assalamu alaikum. First of all, thanks to everybody for being here, and special thanks to the organizer for giving me the chance to give a lecture to you, and hopefully you get benefit out of it. It's going to be short. I promise you won't get bored, because we don't have that much, even though it's a vital role to do the conservative treatment for shortcut foot, but there is not much to say here. But I will show, and we'll see. My colleague Sarah, she covered it very well, so I'm not gonna spend that much time on defining what's Charcot and the classifications, but it's just a destructive process. It takes, and that process takes from 1 year to a year and a half, and sometimes up to 2 years. So it's a long process. What it leads to increased patient morbidity and mortality also, increase in gross instability, and also the recurrent ulceration, because once the patient get deformed foot, they will have a higher chance to get ulcers where the bony prominence are. And that also lead to high risk of amputation. You will see it mostly with diabetic patients, even though there is, you will see some with leprosy and polio and rheumatoid arthritis, other diseases. On studies, it's diagnosed associated with diabetes ranges from 0.08% to 7.5%. The etiology, the most common etiologies that we know is the not the first one, that's the first one that's earlier in 1883, but the most common ones are the neurovascular theory and the neurotraumatic theory. Basically, it's just in the neurovascular theory, it's a hypervascular reflux toward the foot that leads to overactive bone resorption and osteoclast activity, and that leads to mechanical weakening of the foot. And once the patient walking with the mechanical weakening foot, it starts to deform and damaged. The other theory, the neurotraumatic theory, once you have a patient with a neuropathy, that patient will keep doing the repetitive trauma multiple times.
Doctor, can you get closer to the mic?
Without feeling that they are doing the damage to their foot. And they keep doing that over time, and that leads to the subluxation, and which end up with reduce the bone mineral density and end up with deformed foot and reducing bone strength. What our goals in treating the patients with Charcot neuropathy? Once you start seeing these patients, the most important thing that you need to do is early diagnosis, early recognition of the disease. That's the key for a successful treatment. If you miss it, then you may cause the damage that's irreversible sometimes. The second thing is you have to improve the symptoms and reduce all the sequelae and improve the quality of life of patients, because that will affect their quality of life for a long time and sometimes for the rest of their life. Optimize glucose control with our colleague in diabetology. You will find all the patients with Charcot neuropathy, they will have a high glycemia, HbA1c that's like 10, 11, 12, 13. So you have to pay attention to that part, not just treating the foot and forget about the tight hyperglycemic control. Of course, education, you have to be thorough with the patient because they need to know what they're having and what's the consequences of not being a compliant patient. They may end up losing their leg with major amputation. Of course, the immobilization is your key to success in the conservative treatment and even after doing the surgery. And custom orthosis and shoes that going to be later in the stages. Here is the stage. I'm not going to also spend time, but it starts with the inflammatory one. In that part, you won't see in the airplane X-ray something, probably. Most of them, it's just normal. Maybe in the MRI it shows. But in that stage, this is the best time to catch it. Once you start to see local warm and swelling and redness and painless, and that's the key, it's painless. Cellulitis, most of them, they will feel pain. But with Charcot, it's painless. So once you see all these symptoms, and you have to start thinking about Charcot. And at that point, the best thing to do is just immobilize your patient until otherwise proven. It's not going to harm to put the patient in a cast and wait for 2 or 3 weeks, and if it's not Charcot, then that's good. If it's Charcot, that's good, you catch it earlier. The phase 1 is called development. That's where you start the increase in warmth and swelling and redness, and here in this stage you start seeing these debris around the joints, the affected part. It's like start to see. It's like a fogging around the joints. On the second stage, the coalescence stage, that's where sometimes the swelling starts to decrease and even the warmth, and you will start to see in the plain X-ray, you will start these debris that you saw in the first stage start to decrease, and the fusion of these joints and bones and new formation of bone, you will start to see that. In the last stage, in the remodeling, That's where you see the huge foot. It's like 2 sizes bigger than the other foot. That's where the remodeling happened and new bone formation, and that's the last shape of the foot. And each stage, 1, 2, 3, it takes from 3 to 6 months. These are the classification, and also Sarah covered it well. It's just most of the cases you will see, it's just most of them in the less frank joints, and the second common anatomical location is the naviculo-cuneiform and TN joints. Rarely in the calcaneum. I've never seen it myself. Also, this is another classification based on the anatomy. And again, the type 1 and 2 is the most common ones. When you start treat the patients, as I said, diagnosis, early diagnosis is your key to success. And you have to look at what stage you are treating right now. Is it 1 or 2 or 3? Because each one has a different modality. What are the joints that are involved? Does the patient have ulcer or not? And if yes, is it infected or not? Because that also make a difference in your treatment. How is the patient's general health? How is his A1C? Is it high? Is it controlled? How is the vascular status? And in that part, I'm not really sure, because most of them, they have a good vascularity. I've never seen a Charcot patient with peripheral vascular disease or occlusions. The BMI, you have to tell the patient if they are obese, start working on losing weight, because they will be casted for more than a year and they will have a difficulty in ambulation. Plus that if they are obese, they will put a lot of weight on the affected part, and as we know that offloading and not putting pressure on the affected part, that's the key to success. And also the compliance, and this is your big challenge with the patients. Most of them are non-compliant. And you can show your patient this simple diagram. If you want to be compliant and let us offload your foot, you will end up with a normal foot at the end. If not, that's the shape you're going to get. You're going to get what we call it the rocker bottom foot. What's the goal with the conservative? Is just maintain the structure of the stability, prevent ulcers, and end up with a plantigrade functional foot. Even if you get some deformity, but at the end, is it plantigrade, is it functional foot? That's your goal. This is a simple algorithm of the treatment. If you diagnose a patient with acute Charcot neuropathy, the first thing you look for, does he have any ulcers? If yes, is it infected? Then the first thing you wanna treat is the infection, and we treat it with surgical debridement and antibiotics. If no, or if we treat the infection, then we go to the step of the total contact cast, and this is the gold standard for the ulcers and the Charcot neuropathy, especially on stage 1. When we're done with the stage 1, we go to the brace or walking cast. Then gradually we start putting patient in other modalities that are more convenient for them. If we catch the Charcot in a chronic stage, in the post-acute stage, most likely you will see deformities. And your question would be, is the deformity can be accommodated? Then you just go to the permanent accommodative footwears. If that deformity is not accommodated, then you jump to surgery. And we have different type of surgery to reconstruct the foot, from simple exostomy to exfixation and all that. And Dr. Hani will cover that part. And after surgery, you will come back to accommodative footwear. So it's going to be his shoes for the rest of the life. So what is total contact cast? It's just basically it relieves the pressure of the foot. It offloads the forefoot and the midfoot by 80%. It's non-removable. That's one of the disadvantage that the patient, that's why patients hates it. Just this study proves how effective the total contact cast is. The average time for diabetic foot ulcer healing is 43 days in 88 of the patients.
1 minute, Doctor.
1 minute. So this is your treatment in the phase 1 of Charcot neuropathy until you see reduction of erythema and edema and all the signs of consolidation, which means the fusion of bone. You start to see that, then you jump to the next step. That's just to explain how it works. Basically, it transfers the weight to the tibia. Once we put it contacts the entire foot and ankle and the leg, it transfers the weight to the tibia, so we offload the foot and allows the patient to ambulate during the process of the treatment. What are the disadvantages? Just you cannot use it with infection. If he has ulcer that is infected, you cannot use it. It's hard to take a bath or drive a car. You need a compensatory footwear on the other side to compensate the leg length discrepancy after putting the total contact cast. The other disadvantage, that's for us, not for the patient, it takes up to 30 minutes to apply it. There is a new way that some clinicians start to use it's called instant total contact cast. It's better tolerated by the patient. They liked it more than the classic total contact cast. You don't have to be well trained to do it, and it's reusable and less expensive in the material, and even it doesn't take time to apply it. Basically, it's just an air cast or cam walker. You apply it on a patient. You may put some padding inside. You apply it on a patient and then use co-band or adhesive band around the cast, and that's it. Sometimes you can even use a plaster of Paris, and that way you make sure the patient doesn't remove it, and it's easier to apply and cost effective. Crow boot, that's the classic, that used to be a classic stage 1 treatment. It stands for Charcot restrained orthotic walker. It reduced the pressure ranging from 64 to 92%. Basically, it just reduced the patient activity and distribute the weight in the foot, in the plantar of the foot. It's just it has a soft lining inside, and the rocker bottom rubber on the outside of the foot. It progresses the body weight from the heel area to the forefoot without having a lot of pressure on the points that we know for the foot. So that distribute all the pressure on the foot. And nowadays it's used with stage 2, not stage 1, and even stage 3 for the rest of the life. What are the disadvantages? As you can see, it's ugly, an expensive material, and it needs an expert to do it. It's not easy to make. Again, in stage 0 to 1, immobilization is your key, total contact cast. In stage 2, you can start switching to crow boot and limited partial weight bearing. In stage 3, again, crow boot, or you can use the double upright AFO or diabetic Miletus shoes with custom-made orthoses. Here is a study that answering if the conservative treatment is it effective or no. They follow patients for 6 years, for over 6 years of period. They treated 201 feet with Charcot, and just for the sake of the time, so the conclusion is they were success with 59.2% of the patients, they end up without surgical intervention, just by doing proper conservative treatment, and only 40% needed surgery. So that means if we immobilize it well and diagnose it as early as possible, we can avoid surgery and we can be successful.
You have less than 10 seconds. Less than 10 seconds.
Okay, this is the last one. Medication part, there is no hard evidence on that one, and it's a kind of promising studies. We have what they call it anti-resorptive therapy, the bisphosphonates, the IV, and intracranial calcitonin. Basically, what they do is just they reduce the osteoclastic bone resorption that happens with patients, especially in stage 1. And some studies, they show kind of it reduce that and improve the quality of bone during the inflammatory phase. Thank you.
Thank you, Dr. Ahmed, for this valuable presentation. The next speaker will be Dr. Mohammed Laklouk, Professor of Orthopedic Surgery, Mina University, with extensive experience in lower extremity deformity correction.
Bismillah ar-Rahman ar-Rahim. Dr. Mohammed Laklouk from Egypt. Our talk today about surgical treatment of diabetic foot and ankle, internal fixation and external fixation versus external fixation, or both. You have either external fixation or internal fixation or both. Classification, Dr. Ahmed talked a lot about the classification, so we not need to talk about the classification. Surgery might be needed when the deformity is present, because the deformity interferes with normal ambulation of the patient, and also the deformity may lead to formation of ulcer, like this photo and X-ray. Diabetic foot ulcer, every 30 seconds, a patient with diabetic requires an amputation. 70% of this amputation have diabetic foot ulcer. About 60% these ulcers get infected. 70% of amputated diabetic foot ulcer patients will die within 5 years. Treatment algorithm, also Dr. Ahmed talked about this algorithm, so we not need to talk about it. Surgical treatment of diabetic foot or Charcot foot, Dr. Maram talked also about the surgical treatment, but we will mention the lengthening of tendon Achilles, which is important step in treatment of ulcer or diabetic foot ulcer. Because contracture of tendon Achilles may lead to equinus deformity, increase the stress in the metatarsal joint, we will distract the metatarsal joint, and finally there is a fracture of bone, and this bone may lead to pressure ulcer in the plantar aspect of the foot, and disturb normal foot of the ankle, and finally lead to the ulcer. Also, equinus deformity increase the pressure in the forefoot and may lead to ulcer in the forefoot and the big toe. Overreduction and internal fixation are rarely used in the treatment of Charcot foot. Arthrodesis, fusion of the joint, is important in treatment of diabetic foot, Charcot foot, because it enhances stability and treat deformity. Also amputation, talk about it. So our talk today is surgical treatment of Charcot foot, internal fixation versus external fixation. The goal of Charcot foot treatment to achieve a stable plantigrade foot. This stable plantigrade foot lead to normal use of the proper footwear, reduce the risk of re-ulceration, prevent amputation, and improve quality of life. Indication of arthrodesis, mainly use arthrodesis in the stage 3, but there is only few papers we can use the arthrodesis in stage 1. Classification. Surgical reconstruction should be considered in the presence of the following: severe instability, varus or valgus deformity, acute dislocation of foot or ankle, infected long-standing and recalcitrant ulcer, failure of previous treatment. Untreated deformity may cause ulcer, increase the risk of deep infection, and subsequent amputation. Amputation increases the mortality rate after amputation. Decision making for diabetic Charcot foot fixation. We need a thorough history and physical examination to know the progression of the deformity, clinical and radiographic finding, to know the staging of the deformity and the presence of instability and reducibility. Also, we need 3D CT to know more idea about the bone stock and the fracture pattern and the joint malalignment, and we know a lot of previous management. Decision making depends on severity of the deformity, presence of ulcer, infection, instability, unsuccessful conservative treatment, and the ambulatory status of the patient. First, we talk about internal fixation. There is many guidelines talk about surgical treatment of Charcot foot and diabetic foot ulcer, but only one guidelines in 2006 talk about the surgical treatment of Charcot foot. Firstly, we examine the patient. If there is critical limb ischemia, we can treat it or refer to the vascular surgeon. If there is no wound, if there is intact protective sensation, we can do elective surgery to correct the deformity. But if there is loss of the protective sensation, we need to do prophylactic surgery to prevent performation of the ulcer. Like this patient, we have a deformity and a prominent bone in the plantar aspect of the foot. We correct the deformity and fix it by plate screws. If there is a wound and ulcer, we need a curative surgery for the deformity, but if there is a presence of acute infection, we need emergent treatment for this infection. Internal fixation may be by intermedullary beam, like this X-ray, or plate and screws, or both plate and screws and intermedullary beam is combined fixation. Internal fixation methods include plating and axial beaming and retrograde hindfoot intermedullary nail. A standard internal fixation technique by using leg screw, it is not enough for fixation of Charcot joint. So nowadays, evolving technique have focused on fixation placement and a stronger fixation system. We need to use a bridging plate. Normally, if there is a deformity like this diagram, after correction and deformity, we can fix it by plate. But this plate, it is not enough for a good fixation. So we need a bridging plate. The concept of this bridging plate to extend the fixation, both proximal and distally, like this plate, using less affected osseous segment to achieve better screw fixation. The disadvantage of this plate, it will affect the normal joint and near proximal and the distal joint are sacrificed. Or use plating. The plating may be locked plate. It gives good purchase. Or use plantar plating in the plantar aspect of the first tray. It is a very good position because it is put in the tension side. It is sufficient soft tissue envelope suitable for midfoot sagittal deformity. Or use medial plating like this photo. Also it is put in the tension side and the plate fixation manner in the tension side allows the placement of screw to cross multiple cortices and give good purchase and more stability for construct. Or axial beaming. Advantage of this technique is limited open approach. The screw are entirely intraosseous and more robust than plantar plating. Possible complication, lack of compression of this multiple arthrodesis site, loss of purchase, hardware failure, and may need a revision. Or we can use retrograde hindfoot intermedullary nailing for arthrodesis of the ankle joint. We can use both intermedullary nail and plate for arthrodesis of ankle and mid-tarsal joint. Traditional surgical reconstruction of Charcot foot is often done through large open medial approach, require more extensive soft tissue dissection, bone resection, and the plate on the screw to maintain deformity correction. So you have a very big incision. The disadvantage of intermedullary nailing as occur in the proximally in the femur, Z effect. Also we can show this loosening and Z effect in the ankle. Non-union also most complication of using intermedullary nail because of the bone quality is poor, difficulty obtaining compression by using this intermedullary nail. So we have multiple other have reported many complication rate reach to about 70% for internal fixation, like delayed wound healing, because of, the hyperglycemia affect inflammatory process and growth factors and has a negative impact on wound healing. Second complication is hardware failure and requiring removal, recurrent ulceration, fractures, subsequent surgical procedure, and recurrence of the deformity, and non-union. In addition, post-operative amputation rates reported range from about 15% after internal fixation. We now talk about external fixation. In recent years, external fixation has become more popular. Alone, we can find more than 96 incidents of limb salvage in case of diabetic Charcot reconstruction. It adds increased fixation stiffness. It offers immediate post-operative weight bearing, but also it has complications like bent tract infection, which range from 31 serious infection complication to maybe superficial infection in 100% in some cases. External fixation may be uniplanar or computer-based construct or hybrid or circular external fixation. External fixation are used in presence of active infection, ulceration, or patient cannot tolerate the morbidity of extensive dissection. So Elizarov is an alternative treatment strategy, but also it has many complications. For patients who have severe bone loss, osteoporotic, post-operative, post-septic deformity, non-union, ongoing osteomyelitis or peripheral vascular disease, poor soft tissue envelope, so external fixation is more suitable. The benefits of this circular external fixation correct deformity and provide stability and compression at fracture site. General external fixation is described in categories include static or dynamic or stabilizing of loading. Static, after correction, the deformity, acute correction of the deformity, we can put the external fixation to preserve this reduction and give stability to the fracture site. But dynamic external fixation, if the deformity is so severe, we cannot treat this deformity acutely, or maybe there is in danger for neurovascular injury, so we can use gradual correction by dynamic external fixation. The dynamic external fixation allows continuous post-operative adjustment and fine-tuning of the deformity. Another benefit, it facilitates delayed wound closure, and also it have a post-operative complication. Stabilizing of loading external fixation used when there is severe ulcer in the foot. We cannot use normal method of loading, so we can use external fixation like this case. We do arthrodesis for ankle joint, and the patient have ulcer in the plantar aspect of the foot, which is treated completely without any surgical interference rather than debridement. So the external fixation may be static or stabilizing of loading or dynamic external fixation. Some of my cases is a severe destruction of ankle joint after trauma in case of diabetic patient. Then the wound become infected. There is severe infection as you see in this photo. After debridement, we remove a big amount of necrotic bone tissue and fix it by Elizarov. We can see severe infection and pus drops from this wound. After removal of Elizarov, complete resolution of the wound, only just debridement of this wound. But the complication, there is non-union at fracture site, so we put intermedullary nailing, and the patient now, this X-ray is this week. Preoperatively, we can found severe pus formation. The patient can walk now, but there is a shortening. Sorry. And after walker, the patient can walk without support. And she is satisfied by this result. Another case is failure of reduction by fixation of ankle fractures and infected. We do debridement of the wound and removal of implant and do ankle arthrodesis, and the patient can walk after removal of the fixator.
1 minute, Dr.
Okay. This also a simple case, but we do lengthening of the tibia to correct the shortening. And external fixation has a very nice use in case of diabetic foot ulcer by doing tibial transverse transport, by do artificial fracture proximally away from the ulcer site and do transverse transport of this fragment, increase the blood perfusion through the limb, and they can correct diabetic foot ulcer, and we can see a marvelous effect. The principle of the treatment is case of diabetic foot ulcer and gangrene on the foot, just only do a fracture proximally in the tibia and do gradual transverse lengthening of this fragment, we can correct this deformity. We can see the perfusion through the bone pre-operative and during application of the fixator and after removal of the fixator. It is not my cases, but the case is in the paper. We found that the diabetic foot ulcer and there is amputation of the second two, and the chronic ulcer not treatment, not affected by treatment. After do transverse, cortical transverse treatment, lengthening, we can show the improvement of the condition of the wound. Another case with plantar ulcer, improved completely, just debridement of the ulcer and do transverse distraction in the proximal tibia. Another case of amputation of the big toe, and there is gangrene at site of the wound. After debridement and do debridement more and more, and finally this photo of the patient is completely recovered. Combine the internal and external fixation, we can see in this case, we can use external fixation as Elizarov and the intramedullary beaming of the first ray of the foot, or combination between Elizarov and the plate and the screws to give better result. Thank you. It's a sample of some models done by me, by Elizarov rings, like a camel clock, it is working clock, and the report. Thank you.
Thank you, Dr. Mohammed Laklouk. Now our next speaker is the boss, Dr. Hani Badahdah, consultant podiatric foot and ankle surgery.
So you can see the schedule. We start from the pathophysiology and diagnosis, and please make sure before you leave this conference, you know how to detect Charcot at earlier stages, because the key, you guys, you are the primary or the first defensive. Most of the cases, they come to us very late. So, and then Dr. Ahmed Al-Toub spoke about medical treatment and conservative treatment. I think most of Charcot, if we catch it at earlier stages, we can treat it very conservative. We don't have to do any surgical intervention 25% of the cases need surgical intervention. I believe most of the midfoot Charcot arthropathy can be treated conservative, but ankle and rear foot Charcot arthropathy, they need a fixation. So then Professor Leclerc spoke about Charcot reconstruction with external, internal fixation, or both, and show you the advantage and disadvantage. Still, there is no clear guidelines regarding what is the best. It depends on the surgeon preference. For me, I use purely external fixator as a powerful tools because most of my cases get infected Charcot with osteomyelitis. So usually when you start with the Charcot, Charcot by itself increases risk of amputation. How about if you have Charcot with osteomyelitis, will complicate the process of limb salvage and increase risk of major amputation. But always we are fighting for major amputation. We try to save our patient, but we have goals. Dr. Leclerc mentioned that we need to look for the plantigrade foot, functional limb, and braceable foot. So you need specialized training in order to do this type of surgery. Not any surgeon can deal with this type of complicated pathology. Decision regarding surgery not depend on the surgeon, it depends on the patients. Usually I sit with the patient family, I spoke with them, I tell them about the surgical in details, I explain to them about the post-operative course and the long period of immobilization, and also tell them about the complication, or either you can go for major amputation. Most of the patients, they declined major amputation, but some of them, they want to go for one surgery and they use prosthesis. As you know, our diabetic patient usually come as a package: obese, diabetes, chronic kidney disease, ischemic heart disease. I never seen diabetic patient without any comorbidities. Usually our colleague in anesthesia, they told us, why you bring this type of patient? Because they're very high risk to have anesthesia. But most of our cases done under spinal anesthesia, regional anesthesia, to reduce the risk of complications. As I mentioned, before we plan for surgical treatment, we have to look for three things. If the patient has wound, non-healing with the conservative treatment, or if there is instability, if the patient unstable, he cannot walk, or we cannot make a braceable shoes for this patient, then we have to consider surgical treatment for this patient. But if there is no wound and the foot is stable and you can put the patient in custom-made insole with the diabetic shoes, do not do surgery for this type of patients. I always support my presentations with evidence-based medicine. So there is either to do Charcot reconstruction or go for major amputation. There is a 91% of the patient who undergone for Charcot reconstruction, they back to their life and they ambulate with medical type of shoes. In comparison about the cost, initially Charcot reconstruction is costly, but eventually major amputation is more costly if we consider the disability of the patient, and also he will be a burden on the community and healthcare system because they need to replace their prosthesis every 2 years or 1 year. So things to consider before Charcot reconstruction or amputation. We're not doing surgery for every Charcot patient. If the foot is non-functional, I'm not going to consider the surgery. If the patient is bedridden, do you think I will take him for surgery and do Charcot and external fixate? Definitely no. Vascularity of the patient, if the patient have pure vascularity and non-reconstructible, definitely we're not considering surgery. If the patient clear from the vascular and they have endovascular procedure, and then we can consider surgical reconstruction. Glycemic control, we spoke about this yesterday. We have to have control blood sugar. My cut point, hemoglobin A1C 8. If it's 8 and below, I will consider surgery. Above 8, I won't proceed with the surgery. presence of wound and osteomyelitis, we still work on this type of cases, but you have to look for the bone quality in Charcot reconstruction with osteomyelitis. Obesity, I think obesity one of the common cause of failure of Charcot reconstruction, but still, you know, as I told you, most of our patients, they're obese. If we're not gonna work on them, then we're not gonna do any kind of reconstruction surgery. But you have to keep in consideration, you tell the patient, you send them for the dietitian, and also you have to consider sleeve surgery or bariatric surgeon. Our colleague can help us after the surgery. Medical comorbidities, most of our patients, they have multiple comorbidities. That's why MDT, multidisciplinary team approach, is really important before you proceed with the surgical treatment. Younger patients, they usually have good outcome. Lifestyle, you don't want to consider this type of surgery if the patient is very active and he's working in an active job duty. But the goal of the surgery is to keep the patient independent. He can walk at home and he can drive his car, but we're not looking for him to do a marathon or go for soccer or playing basketball. You know, we're just keeping the patient independent. Economic status, as I told you, is very costly. So if the patient is poor and he's is taking care of his family, and he wants to have one surgery, I wouldn't think to consider Charcot in this type of patient. I will recommend him to go for major amputation and have a prosthesis to take care of his family. So I will go over some of the cases. I'm not saying I'm a hero. I'm not saving all the limbs, but at least we can save 85% of the cases, which is good. وَمَنْ أَحْيَاهَا فَكَأَنَّمَا أَحْيَا النَّاسَ جَمِيعًا. This patient, as I told you, is coming as a package, 65 years, smoking, DM, chronic kidney disease, ischemic heart disease, with the right ankle Charcot arthropathy, complicated with open wound and osteomyelitis. So, multidisciplinary team here is very important. We send the patient for cardiology clearance, and also we spoke with the patient about quitting smoking because it affects the bone healing. You can see the bone quality here is really bad. See, the talus is completely out. And imagine if you put intramedullary nail in this type and quality of bone, definitely intramedullary nail will be fail 100%. So that's why Professor Leclerc mentioned about the bone quality is really important before you consider your fixation type. So this is the patient before the surgery. I usually document my patients before, after the surgery. I don't think the video is working. No, it's working. See how the foot is completely dislocated. And then my friend, circular external fixator. I like to use it because you can do it in one stage. You remove the infection. And also I use topical antibiotic, Dr. Nizar. I think you guys, you don't like topical antibiotic. I use something it's called calcium sulfate, absorbable antibiotic bone cement to enhance the eradication of the infection locally. And then we put circular external fixation to offload, correct the deformity. Most of the time I do static external fixator. I don't use dynamic circular external fixator. This is the patient. Usually I keep my circular external fixator for 4 months up to 6 months, depend on the bone healing. And you can see the patient is completely have wound healing on the lateral side of the ankle joint. And this is the patient, it's completely bone healing. By the way, this patient was recommended major amputation before visit our service. And this is the patient after 4 months, as you can see. Sometimes you don't want to have a rigid ankle arthrodesis. You want some kind of range of motion to help the patient to ambulate with the medical shoes. And this is the patient. Consent was taken from the patients to let his face appear in this presentation. This is just to prove that I'm not lying to you. I'm just showing you cases. There is a successful cases because a lot of people, they say you have if you put a circular external fixation, that there is a chance of pin tract infection. One time I was sitting with a surgeon, he told me, by default, you don't talk about this. You have pin tract. If you take care of your patient and you do right technique, you will not have any kind of pen tract. Even if you have a superficial pen tract infection, you can't treat it as an outpatient. This is a young patient. He's 39-year-old, DM with ankle arthropathy, with a chronic non-healing wound for 3 years. This patient with the 3 years. He gave up. Everybody told him major amputation. By the chance, my friend told me, I have my friend, he has wound and they offer him amputation. I tell him, let him come to our clinic. So I saw this guy. I told him, why are you waiting? He said, I'm waiting just to get infected wound and then I will go for emergency major amputation. So we give him some hope, especially his young patient. So this is the X-ray. Sorry for poor quality because the patient did the X-ray and I don't know what kind of clinic, but it's a poor quality. You can see there is no talus, there is osteomyelitis, and you can see the tibia is coming out medially. That's why the reason of the wound. If you do wound care here in this type of wound, it will never heal because there is a deformity. So you have to correct the deformity in order to fix the wound. So again, we put the cervical external fixator. This is not the bone. This is where the fibrosis tissue, because he was walking in this leg with the media deviating medially, so he was putting all the pressure on the medial side. And you can see the wound is completely offloaded. So we use the cervical external fixator for multiple reasons. So this is intra-op, 3 months post-surgery, and this is the patient 4 months later. And this is, you can see the X-ray. This is a younger patient. That's why you see a good, excellent bone consolidation. And this is our patient, completely walking on his leg, and he's back to his life, and we saved his limb. Imagine this patient live without leg, with the prosthesis. Amputation is a morbidity. The patient will develop ulceration in other leg. So do not force the patient to go for amputation. Dr. Nashat mentioned that. So amputation is a disaster, guys. Dr. Khalid say, I love disaster word. So you can see young patient is walking back to his life. Again, this is a 70-year-old female patient with an ankle fracture. It's just simple ankle fracture, get neglected, develop this wound. If you put the most expensive wound care product, all the exhibition there on the next side, if you put all the products here, you cannot close this wound. So you have to correct the deformity in order to close this wound. And I will show you the X-ray, Dr. Nizar, and see how aggressive the osteomyelitis in this patient. So definitely we involve our infectious disease colleague here to help us in this case, because this patient, she has MRSA. So this patient was kept on antibiotic for about 6 weeks, according to our colleague in ID recommendation. So after discussion with the patient, so we decide to take her for surgery. We give her a chance before go for major amputation. And then again, external fixator give me the chance to do single stage of surgery instead of doing multiple stages to reduce the cost on the patients. And this is the patient 4 months later, complete wound healing with deformity reduction. And we don't want to achieve like 100% deformity reduction. We're looking just for braceable, stable foot and plantigrade foot. And this is the patient. You can see we eradicate the infection. You guys will ask me, how do you know that the infection is completely gone? We track this infection with the CRP and ESR, and also the clinical picture of the patient and the wound healing, and also the images, the X-ray. I do frequent X-ray to monitor the bone progression.
1 minute, Dr. Hani.
I have 57 minutes. Take home message. MDT approach is really important to improve your surgical outcome. Early recognition. My colleagues, they already talk about this. If you catch the patient at earlier stage, you reduce the chance of amputation. You need to involve the patient and the patient's family and discuss with them about the surgical plan. You need an experience and training in this type of kind of surgery. Patient selection is very important. Patient selection is very important. And thank you so much. And still I have 22 seconds. Thank you.
Thank you, Dr. Hani, for this valuable talk. I think we are open for discussion.
5 minutes discussion and then lunchtime.
Okay. Okay, so may our speakers come here, stand in the front. We need chairs, guys. Anyone? Yeah.
Thank you very much for this surgical approach for the Charcot joint. But I would like to ask about the post-operative follow-up. How long this fixation are stable? What's the maximum you are following the patient? Any of your patients? How many years?
You talk about time of application of reserve or
Fixation.
post-removal follow-up?
Stable fixation of this ankle joint.
Till the condition is very good and no recurrence of infection, and the diabetes is controlled, we can for life.
Actually, the movements of the extensor and flexor muscles around the ankle are stopped completely, and the patient is allowed to even sometimes run. Sometimes these fixed arthrodesis are dislocated again, or vulnerable to dislocation again. How frequent this happen?
In some cases, but other cases it's very good for XCSE.
Stable arthrodesis
Yes,
for good.
Doctor, you have to think different. Charcot is completely different. It's not trauma patient. It's not a normal patient.
I see.
Charcot, I have goals I need to achieve. I need the patient to become independent, ulcer-free, infection-free, and braceable foot. Even if the ankle is not completely solid fused and the patient can walk with the medical shoes, I'm very happy. Because most of the time, the risk of surgery complication in Charcot is 50 to 60% the risk of complication. If you could reach to the second end without complication, you achieve excellent results. So bone healing in diabetic patient is not perfect, but we can bolster that healing with using biphosphonate, calcium, vitamin D, and we encourage to control blood sugar and optimize the vascular status of the patient. Yes, we have some cases with a pseudoarthrosis, but I'm happy because I clear the infection, I save the limb. Even the patient, if go for amputation, his limb with the braceable shoes is better than prosthesis, because prosthesis will increase the pressure on the other foot, and the patient in the next 5 years, he will end up with the amputation in the other leg.
I appreciated so much the results, but you are using external support or fixation or something like that as post-operative care?
Yes. After we remove the circular external fixator, we put the patient in a crop boot, or we use a medical shoes, high neck shoes up to the mid leg to prevent the recurrence and dislocation later. Because I have to discuss with the patient from the beginning about the medical shoes for life.
Thank you so much.
Any other question?
Question for Dr. Ahmed. Thanks for a nice talk about the Charcot foot management. My question, when you treat the acute Charcot, you apply TCC. Do you allow the patient to walk with the TCC or like 100% offload by wheelchair?
Well, that's the goal, or that's the reason we use TCC, because that will allow patient to ambulate. And if you notice the pictures, the patients will have like a surgical shoe on top of the TCC, so they can ambulate. At least it will be limited ambulation, but with TCC, it's going to be all the plantar aspect of the foot will be totally contacted with the rest of the foot and the ankle, and that will keep the joints and even the soft tissue immobilized, and that's and all the pressure will convert it to the tibia, and that's going to prevent the complication of it.
But now when you do that, you take care of the diseased one, but what about the healthy one? You're going to harm the other one.
Well, the other one, that's why I said that you have to put you think of the compensatory footwear to the other side in terms of having a balanced standing. I mean, no leg length discrepancy. Plus that having a good custom molded shoes to prevent any harm to the other side.
In my experience, if you put the TCC in the affected one and you have the patient in a wheelchair for 3 months, you're going to save both. This is, I tried that and it worked good.
Yeah, you have a point, because if you put a lot of weight on the other side, you might not develop charcot, but maybe develop ulcers on the other side. And that's why we need to continue seeing the patient and reapply the TCC almost every 10 days, just to make sure there is no problem on the affected side that we covered, such as cellulitis or any other issue, and checking the other side, not getting any problem for being dependent on it.
Thanks a lot.
My question to both Dr. Lakluk and Dr. Badahdah about if I didn't get a solid union in cases of charcot when I fix it, does this matter? Does it? Sometimes we didn't get solid bony union, and it ends with fibrous union. Does this matter, or I have to fixate this bone again to get a solid union?
If the patient is satisfied by this fibrous union, it's okay. You cannot judge for another operation and the result of the second operation. Most of our patients become satisfied because following period of the application of Elizarov, so we become satisfied and stop and refuse to do another application of Elizarov for solid union. What's about your opinion, Dr.?
I agree with you, Dr. Lakluk. Yeah, you're right. If you have ulcer-free, infection-free, braceable limb, you're fine.
My question for Dr. Lakluk and Dr. Hani. About the Elizarov during charcot patient. Dr. Lakluk, you said that patient can with bear during Elizarov. And as far as I know, I am working with Dr. Hani, it's totally prohibited for the patient to bear any weight during the Elizarov period. So about your experience, do you allow your patient to full weight bearing while Elizarov?
Yes, if he can walk, I prefer, because it is accelerate healing, improve the condition of the limb.
No, Dr. Hani.
I'm opposite to you this time, Dr. Lakluk, but because you have to run for lunchtime. So in my patient, diabetic is completely different from trauma and deformity patient. Diabetic patient, if you let them walk, they will come with the loose screws, loose wires, and loose pin and pin tract infection. I keep my patient, I always teach them how I have to say that occupational therapy and physical therapy, they will help us for the patient how to remain non-weight bearing for 6 months or 4 months without putting any weight. Because I've seen this before, let the patient walk, develop pin tract infection, osteomyelitis of the tibia, and eventually end up with a major amputation. Diabetic patient is completely different from trauma, deformity, and other patients. That's my opinion.
Thank you, everyone. Now this concludes our session for the charcot foot. Now it's lunchtime. I think all of you are hungry and ready to dance.
We'll be back at 2, huh?
Yeah.
And at 2, we have a workshop. We have 2 workshops, basic application of circular external fixator and also a negative pressure wound therapy.
حل لك استعمل في بغداد في ني كراتشز ووكر شايفه؟ انا عارف حلو هذا لا سؤال لك سؤال نستعمل بون مورفوجينيك بروتين تو انهانس هيلينج اوف
تيست. السلام عليكم. الصوت واضح؟
ايوه. طيب.
Welcome back again for the last session today. The last session will talk about diabetic foot surgery, and the modulator for today, Dr. Badr Al-Amri, he's general surgeon in Al-Qasim, and Dr. Isa Al-Amri, he's general surgery board certified from Kuwait. They will be the modulator for this session.
I will repeat my introduction. Dr. Abdulaziz Kimawi, he's our first speaker for this session, professor and consultant foot and ankle and diabetic foot in Dr. Suleiman Fakih Hospital.
Assalamu alaikum. I don't see a lot of people here. MashaAllah, people are still eating. Anyway, whoever is here and awake, we're going to start with my lecture. I'm going to be talking quickly because I got an airplane to catch. So today I'm talking about the elective, prophylactic, and curative diabetic foot surgeries. Well, until 1949, the very first published large series about transmetatarsal amputation, at that time as a solution for below-knee amputation, as a solution to save the leg. So before that time, people would lose their feet or legs because of simple gangrene. At that time, if you have an ingrown toenail, you might lose your leg. But for the past few years, alhamdulillah, there was an acceptance of diabetic foot surgeons around the world, and the training became so advanced until what we see today and the topics we've been talking about. The current guidelines about diabetic foot management is usually focusing on the diabetic management or the non-surgical treatment for diabetic foot ulcer. Not many papers are written, and we do not have a consensus on the surgeries for diabetic foot ulcer. Let's go quickly over the pathophysiology of diabetic foot ulcer. First, we have motor neuropathy that is going to cause muscle tendon imbalance. After that, you're going to be having a foot deformity. The foot deformity later on will cause increase in plantar pressure, and plantar pressure along with sensory neuropathy is going to cause an ulcer. So you always want to look for the foot deformity. Keep that in your mind, that a foot deformity might be the reason for you having an ulcer, especially if you have a recurrent ulceration. If you have a patient with an ulcer, you take your time, you spend the time, you treat the ulcer, but later on the ulcer comes back, you have to sit down and question yourself why the ulcer is coming back. Most probably because you missed a deformity that you did not correct at first place. Let's not forget peripheral vascular disease, which is there in about 50% of patients. And also you remember that the purely ischemic ulcers are not that often common. Most of the ulcers are whether neuroischemic combination or purely neuropathic ulcers. So here, that's why I'm looking for deformities. The deformities that we're looking after are here. For example, the very first common one, if you have a callus or an ulcer on the tip of the toe or on the top of the toe over here, this is because of hammer toe deformity. Then you might be having an ulcer over the metatarsal areas. You might be having an ulcer around the medial side of the first metatarsophalangeal joint. This is caused by a severe bunion deformity. A condition here called hallux rigidus, where you don't have enough motion at the range at the first metatarsophalangeal joint, and you're going to be having ulcers happening on the big toe. Equinus. Equinus is almost present in all patients with diabetes. With uncontrolled hyperglycemia, you have glycosylation that's causing shortening of the Achilles tendon. So many of your diabetic patients are going to be having ulcerations happening in the forefoot area because of equinus. If we're missing equinus, we're going to be missing a big reason for this ulcer to happen. Charcot foot deformity. We've been talking about the Charcot foot deformity in the previous lectures, that if you don't correct the deformity, the ulcer will never heal. And lastly, an amputation that happened in the past. The foot is missing many of its tendon, and the foot is deformed, and the ulcer is not going to heal if it happened at around the corner of the stump. So identifying and treating this deformity is the most important part of your treatment when you're looking for recurrent or difficult to heal ulceration. And there are many ways on performing these surgeries, the offloading techniques, many ways to do them, many literature about them. And most of the studies right now, they're supporting that we move from only accommodating treatment into actual surgical correction, especially that you want to prevent recurrence. We were looking at the total contact cast to close an ulcer, but what happened after you remove the total contact cast? What's going to happen? The deformity is still there. If you don't fix it, the ulcer is going to come back. So we have a classification system that was developed to stratify the different surgeries, and the schedule depends on the presence of neuropathy, how bad is the wound, and if there is a risk for amputation. First is the elective, class 1, prophylactic, curative, and emergent. Elective is where the patient has no neuropathy, only have a deformity. And here you want to entertain the idea with the patient that you might need a surgery in the future because you're having a deformity right now. You might get neuropathy, and at that time we will have to fix this deformity to prevent an ulcer from happening. The prophylactic or class 2 is where you have an ulcer that has healed, but you're looking at the patient, you're examining him, and you see that there is a deformity there, that if I don't fix it, the ulcer will sure come back. Curative is where you have an ulcer, where you have an infection, maybe in the bone also, so you want to treat all that altogether with curative procedures. Emergent, class 4, from its name, is when the patient has a limb-threatening infection or life-threatening infection, and here most of your surgery is going to be amputation. So let's talk about elective surgeries. As I said, few of my patients, they fall under this category. I do treat them if they have pain because of this deformity. I don't treat them because I want to do a surgery before neuropathy and before I see an evident risk for this patient. But many of my patients, they fall under prophylactic surgery when they come for screening, and I see that this patient is missing part of their foot, or they had a surgery in the past, or they recently healed from an ulcer. I would look for deformities, and if I find any of them, then I would push the patient to the OR and have this deformity corrected. One of the very common prophylactic surgery that I do perform in my office is fixing a hammer toe. Patients with hammer toe, they're going to be having a callus here at the tip of their toes, maybe on the dorsum aspect of the foot of the toe because it's rubbing against the shoe. You can perform this minimally invasive. You put a small blade or even an 18-gauge needle, and you cut the flexor digitorum longus tendon here, and that's going to be fixing your deformity, preventing this callus to become an ulcer. Another prophylactic surgery that we do, if the patient has a heavy callus over here, and these patients come visit me in the office, they have neuropathy, and they are building this callus. And I ask myself, why this patient is building the callus over here, not on the other side of the foot? Why this callus is happening here? We have a foot map that we look at, and if we find a callus happening here, I immediately check the range of motion of the joint, and if I see that the joint is not moving, then this callus is going to continue happening. If the patient developed an ulcer, it's not going to go away. If you look at our phases of walking, the gait cycle, you see that the toe off, it's really important to have good range of motion at the first metatarsophalangeal joint. If you don't have it, then this patient is going to be putting his entire pressure on his toe. So a simple procedure, you take the patient to the OR and you take this piece of bone here. This is killer arthroplasty, very benign surgery, where the toe is going to be floating. The toe is going to be floating and the pressure is going to go away. Another prophylactic surgery that I love to do is releasing the Achilles tendon. If a patient has an equinus and he has a small ulcer or a callus happening here, then I would take the patient, I'm going to use my hand instead of this marker. If the patient is having a callus over here in the forefoot area and his heel is smooth and nice and beautiful, I know that most of the pressure is happening here. We check the range of motion of the joint, and if I see that the patient has an ankle equinus, then I would entertain the idea of taking the patient for whether a minimally invasive triple hemisection of the Achilles tendon, or we can do an endoscopic gastrocnemius recession. This patient has chronic Charcot. He has a rocker bottom foot. If I leave this here, this patient definitely is going to be developing an ulcer here. So I'll take the patient when everything is cold. I don't wait for the ulcer to happen. I don't wait for infection. I don't wait when the patient is hyperglycemic. So when we have a good condition, we take the patient to the OR. This patient, we performed a medial incision. We did an osteotomy through and through, and then we fixed the joints, and we created a small arch. So the patient has an arch here, and we offloaded the rocker bottom, the deformity, and this patient is going to go safe without having a risk of having an ulcer. Curative surgery. Here, the ulcer has happened, maybe an infection happening, maybe osteomyelitis as well. So here you're going to be dealing with multiple stuff. You're going to be dealing with a deformity. You're going to be dealing with ulcer. You might be dealing with osteomyelitis as well. So most of these patients will have to go to the surgery, to the OR multiple times. So we fix one part of the problem at a time. For example, this patient is having these patients, both of them have the same deformity. They both have ankle equinus. Both of them have, let me show you here. Both of them have a short first ray. If the patient is having short first ray, then most of the pressure is going to be transferred under the second metatarsal. And if you see that the second metatarsal looks really longer than the rest of the metatarsal, and the patient is having equinus, when you're having equinus, let's make it easy here. If you look at the lateral view of the normal foot X-ray, you can see that the metatarsals, they're pointing downward. The pressure is going to go under the longest metatarsal. So if we have a long metatarsal here, this metatarsal is going to be taking most of the pressure. Add equinus to the game, then this patient entire pressure, entire weight is going to be under the second metatarsal head. So this is not going to go away unless we fix the deformity. If the patient is, if the patient is having a superficial ulcer like that, easy. Let's go inside, we can fix the deformity, and this ulcer is going to heal by itself. And this patient went into osteomyelitis. In this case, the treatment is going to be a little bit different. So this is a benign procedure we perform to restore the parabula, restore the length of the metatarsal heads, all aligned, to distribute the pressure well. And we need a fixation here. We need a small screw. So if we have osteomyelitis, if I have a deep ulcer, then I wouldn't do this procedure. I would just simply go and resect the entire metatarsal head, and we're done. And of course, I'm going to be coupling this with Achilles tendon lengthening. Sometimes when you have an ulcer that is difficult to heal, then you can use a skin graft. Skin graft is used for non-weight bearing areas. If you have a weight bearing area, then the ulcer, the simple skin graft is not going to be enough. You will have to go with a skin flap. So this patient is about the same deformity. So here we had to fix the deformity and then get the infected bone out, and we have an ulcer here, and then we fix it with a rhomboid flap, and the ulcer has healed with low chance of recurrence. Another patient here, our friend with Charcot deformity, he has a deformity, he has a thick ulcer, and maybe that piece of bone there got infected. So we have to resect all that, maybe perform a full Charcot reconstruction or just exostectomy. That depends on the stability of the midfoot joints. And then this area, it's very difficult to close it with just a skin flap. The patient's weight is going to come here. So you want to go a little bit more further and perform a muscle flap. Muscle flap of choice here for me was the flexor digitorum brevis.
2 minutes.
This is a good muscle. Sorry?
2 minutes.
All right. This is a good thick muscle with good blood circulation. I'm going to go really fast. So you make a long incision, you want to release the muscle from its insertion, bring it back, flip it backward, fill the gap, and then the reason why I'm putting external fixator here, because if I perform all that muscle flaps and the patient walks on the foot, putting minimal weight bearing on the foot, he's going to be destroying my flap. If the patient is moving his foot up and down, then there is going to be an excessive motion at the wound bed, and that ulcer is not going to heal. So this external fixator helped me doing both things. If I did a Charcot reconstruction, then also this is going to be helping me with the fixation option. Later on, the patient healed. The emergent surgery. These are the surgeries we don't like to perform, and this is what we are forced to take the patient to the OR. Patient typically presents with a life-threatening infection, and here your options are not much. Most of your options are going to be an amputation, but don't do a big amputation. We were talking about the gas gangrene. You can go minimally and remove only the infected part and infected bone out, put the patient on a wound vac, bring the patient back in the clinic, multiple debridement, multiple visit to the OR, and then later on when everything is nice, you can take the patient for another procedure where you put a skin graft on him. That's a non-weight bearing area, so a simple skin graft really helped. As you can see that we had to go between back and forth in the schedule, choosing different surgeries depending on the ulcer itself. If you have an infection, then the infection is way more important than fixing the deformity. Start with your infection first, get the infection out, bring the patient later for another stage procedure. And the line in the middle here, I wanted to stress on, don't perform non-functional foot amputation. Don't take part of the bones, leave the rest of it, because you want to have the foot having toes. Don't leave the patient with a foot looking like that, or a foot looking like this, or like this. If you have to go for surgery, then take as much as you can to have the patient walking and have a good prosthesis on. My reference is here. Thank you very much. If you let me take the questions now, because I'm going to go to the airport. What do you think?
Any question? Thank you, Dr. Abdulaziz. It's a really nice presentation. Any question? Because of Dr. Abdulaziz, he will leave now.
Good, mashallah.
Okay. Mashallah, you are lucky.
Thank you. Can you give him the mic, Doctor? I can't really hear you.
Thank you. Particularly in the diabetic foot, the problem is the vascularization, also atherosclerosis and all that. Do you think that it may lead to further necrosis of the boundaries if it is not applied properly?
What's not applied properly?
This vac system.
The wound vac?
Yeah, wound vac.
Well, the wound, of course, vascularity is an important part that I have to fix all the time.
Yeah.
So that's why staging surgery is really important. You bring the patient is not going to be always having a deformity without maybe some element of ischemia. So if I have my ischemia taken care of, then I'm happy to perform whatever surgeries I want to do. For the wound vac creates typically an area of like a cuff around the wound, where an area of less blood flow. So in that case, if the patient is ischemic, you want to go with less pressure.
Yes,
so you don't go with 125, you go with maybe 75. You don't go with full-time wound vac. You want to do it intermittent treatment. So you give some time for the tissue to have some perfusion, local perfusion, and then let the vac work again.
Intermittent.
Intermittent.
At a low.
Yes.
Thank you so much.
Sure, of course.
Thank you for everybody. Thank you, Dr. Abdulaziz.
Thank you.
The next speaker will be Dr. Issam Khidr. He's a consultant pediatrics surgery. He's on Dawali Clinic. Welcome, Dr. Abdulaziz. Dr. Issam Khidr.
ده الليزر اوكي ده التغيير okay. Good afternoon, everybody. Thanks for the organizer and thanks for inviting me. And many thanks for Dr. Hani, who put a great work to articulate this conference. Today, we'll talk about the amputation technique, diabetic foot amputation technique, which is amputation always a disaster for the patient and for the family. And it's a difficult message from the doctor to convey to the patient, but we have to sometimes. We should first do everything in our power to prevent or at least limit amputation. But if amputation is risk the patient's life, we have to do it. So we'll talk about that. Some backgrounds. Diabetic foot disease is a serious complication of diabetes mellitus. Patients with diabetes mellitus have a 25% lifetime risk of developing a foot ulcer. Between 14 to 24% of patients with foot ulcer require a minor or major lower limb amputation. The diabetic foot is described as a foot infection with an active wound formation and deep tissue destruction. This is due to diabetes mellitus-related neuropathy and peripheral arterial disease of the lower extremity. Diabetic patients are 17 times more likely to develop foot gangrene than non-diabetic. It is a tragic fact that 2/3 of major amputation in the United States are performed on a diabetic patient due to foot problems. Peripheral neuropathy, peripheral arterial disease, and altered host defense make the diabetic patient particularly prone to the development of the infected foot ulcer, which may lead to a foot amputation. Some risk factors may lead to foot amputation: high blood sugar level, smoking, peripheral neuropathy, peripheral arterial disease, calluses or corners of the foot, history of foot ulcer, past amputation. Now we talk about the classification of the diabetic foot amputation, which also we call it a distal amputation or a minor amputation. Anything below the knee, it's minor amputation, and we'll try to keep it this way. Sometimes we do those minor amputation to avoid major amputation, which our goal to have the patient back on his foot. There is three categories of the foot amputation. We divide it to a forefoot amputation, which is consists of distal simum amputation, which is partial toe amputation. Like if we do here. Excuse me, pointers. Green. I think the red one.
The laser, green.
Laser. Okay. Yeah, that's like a forefoot amputation. We're talking about a toe amputation, which is a part of the toe with affected bone, or ray amputation, which is we take the whole toe disarticulated at the tarso-metatarsal joint or the tarso-metatarsal joint, and also we'll go further to midfoot amputation, which is two things: the Les Franks amputation, disarticulation at the tarso-metatarsal joint, and Schobert amputation, which is disarticulation between the talonavicular and calcaneocuboid joint. The other one, the third one, hind foot, which is SIME amputation. Here we remove all the calcaneus, the talus, and both malleoli. We talked about that. Definition of the distal SIME amputation, the excision of the affected part of the toe. And we do that when we have like a gangrenous toe, like this, or ulcer on the tip of the toe. So we remove part of the toe, not the whole toe. So as you see here, the metatarsal bone is here, and here the toe, and you can just articulate at this point here. The ray amputation, as I said before, it's the whole toe. So the excision of the affected toe and part of the corresponding metatarsal bone. And this is usually the indication, dry or wet gangrene of the toe, the gross infection of the toe, including the whole toe, septic arthritis of the metatarsophalangeal joint. And here, this is wet gangrene. So we take the whole toe, and here the unhealing ulcer involved with the phalangeal and metatarsal bone. A transmetatarsal amputation, and the definition, excision of all toes with resection across all metatarsal bone, like what it shows here. This area. And the indication, dry or wet gangrene of 3 or more toes of the foot. So if patient comes to your office and you have like 3 toes, you don't do only 3 toes because you're going to expect the other 2 toes going to get gangrene also. You're going to do the whole 3 toes. Severe infection involving the forefoot, most of the forefoot, and dry or wet gangrene of the forefoot. And this procedure like save lots of limb. Most of the patient, when it goes to the hospital or anywhere, the clinic or office, the decision of the physician is, or the surgeon, is to do blue knee amputation. I rather start with the metatarsal, the transmetatarsal amputation, and then if it failed, we can go further. Midfoot amputation, as I said before, it's 2, Les Franks amputation and Schobert amputation. Les Franks amputation, this articulation through the tarso-metatarsal joint. All metatarsal with the cuneiforms and indication, dry wet gangrene up to the midfoot, severe infection of 2/3 of the foot. Schobert amputation definition, disarticulation through the talonavicular and calcaneocuboid joint. We only leave the calcaneus and the talus. We try to avoid this procedure because in diabetic foot infection due to a higher failure rate and the proximity of the infected tissue to the heel pad, because we need the heel pad to use it, and this is the part we can use it to cover the wound. Hind foot amputation, SIME amputation, excision of the calcaneus, talus, the lateral and medial malleoli with preservation of the heel pad. Indication, wet and dry gangrene for more than 2/3 of the foot, severe diabetic foot infection involving the whole foot, trauma cases of the foot. And this is the outcome of the SIME amputation. There is some, like Heda says, SIME amputation should be reserved for patient with at least a palpable posterior tibialis pulse with ABI. There is a type of mistake here. ABI, ankle brachial index, more than 0.5. Disadvantage of the SIM amputation, instability of the calcaneal flap, which we needed, due to a poor adherence of the soft tissue of the calcaneal flap to the tibial surface. The second one, the dissection of the calcaneus. When we remove the calcaneus or excise the calcaneus, it attached to the calcaneal flap. So when we remove it, we devascularize the flap, and this is gonna lead to poor healing. Excision of the calcaneum will lead to a shorter stump. So we're gonna suffer, the patient gonna suffer from limb length discrepancy. Conclusion, diabetes mellitus related minor and major amputation of the lower limb are known to significantly affect patient diagnosis and quality of life. Multidisciplinary approach should be recommended to form an optimal treatment in addition to a careful determination of the amputation type and plan. Diabetic foot amputation should be comprehensively evaluated according to the patient general health status, because we cannot operate on the patient with like comorbidity, with the, as Dr. Hani mentioned before, a bedridden patient with a vascular status is not good. We cannot operate on patient like that. So conservative is the best thing for him. The degree of injury, the severity of the lower limb vasculopathy, and the other relative indicators, this is like we have to evaluate the patient systemically and locally too. The Wagner grading system of the diabetic foot and the severity of the lower extremity artery disease are important bases for determining amputation of the diabetic foot. As I said before, like amputation is a disaster decision taken by the physician and conveyed to the patient and the family. So we have to do everything in our power to eliminate the rate of amputation. And this is our job, to save limbs, to save foot, not to cut limbs or foot. Thank you.
Thank you, Dr. Issam. The next speaker, the big boss, Dr. Hani Badahdah.
I'm here again. I don't want to give more lectures, but you know, for some reason, some of the speaker they have to leave for emergency reason. That's why I have to present it. I mean, Dr. Assam, he talked about very wonderful presentation about the amputation. It's very sad, you know, you don't see too many surgeons here to attend this type of conference, because we see type of amputation what they do in the hospital, and I think most of us, we see this type of cases, they do amputation, the bone is exposed, or they do like a mouth bite, you know, they just remove the toe and leave a big hole, and then the patient end up with the osteomyelitis and infection, go for the second toe amputation, transmetatarsal amputation. And I think all of us, we agree that the technique of amputation is really important. And Dr. Bundukji mentioned that, how to do the resection of osteomyelitis. It's very sad that we don't see a lot of surgeons here and to learn from the expertise about this type of surgery. But anyway, we will continue fighting for amputation, and we'll do great work as we do as usual. We invent something, it's called orthoplastic technique for diabetic foot wound closures. Ortho, it's mean orthopedic, to correct the deformity. Plastic, we combine orthopedic surgery with the plastic surgery in order to close this type of wounds. Traditionally, most straightforward treatment for complex wound, I think it's not traditional, it's still till now the primary intervention for the most of surgeon. I'm not saying that general surgeon, in general, surgeon, they prefer major amputation instead of taking the patient to multiple surgery. That could be maybe lack of experience, or because of their hectic schedule and busy schedule, and they don't have time to follow up the patient for 6 months or 7 months. I think that's why diabetic foot is considered as subspecialized and need dedicated service for this type of patients. Amputation is a straightforward and rapid solution to complex wound that can have patient back amputating in short period of time. I will consider amputation in type of patient with a low socioeconomic status and they want to go back to their life very soon. We can consider amputation. My colleague, they talk about the statistic of major amputation and the mortality rate after major amputation and the percentage of contralateral ulcer development in the next 2 years after the major amputation. Orthoplastic, as I mentioned earlier, is a combo between a plastic technique with osseous deformity correction. Wound closure for diabetic foot wound can be challenged because they have multi-comorbidities also, and they have uncontrolled diabetes, they have neuropathy, they have peripheral vascular disease. That's increased risk of complication in this type of patient. So that's why we have to involve multidisciplinary team in this type of patient. Wound care can work, but in this type of cases, sometimes we cannot do any kind of wound care. If you don't address the osseous deformity, the wound will never close. Also, we can consider surgical closure if the wound failed to close with a conservative treatment. Sometimes we have wounds, you try all kinds of wound product, but the wound failed to close, and then we have to consider surgical offloading, like Dr. Kimawi mentioned about how to do surgical offloading to close the wound surgically. Key to success, first, patient selection is very important. You cannot do this type of surgery to any diabetic patient because we see there is smoker patient, they're non-compliant patient, the patient they live by themselves, they have socioeconomic issues, they have psychiatric issues. You cannot do this type of surgery. Definitely, if you do surgery in this type of patient, your surgery will be failed 100%. Two, you have to optimize your patient medically. I mean, you have to make sure the blood sugar is controlled, vascularly optimized. You have to call your colleague for vascular optimization. If there is an infection, you have to address the infection. You call Dr. Nizar Bahabri, or remember Dr. Nizar Bahabri lecture to help your patients. The first inspection is really important. When you look to the patient and the wound type and the nature of the wound and the severity of the infection, all this is important, should be addressed. If there is osteomyelitis or there is no osteomyelitis, if there is pus, no pus, all this is make a difference in the plan of surgical treatment. Again, most of our patients, they have multi-comorbidities. We have to address all these comorbidities. Also, you have to discuss with our patient the surgical treatment plan, long period of immobilization, and also post-operative care. Also, the most important is smoking. Smoking is very high risk factor for delay wound healing and also for bone healing. Smoker people, they have double time of delay healing in comparison to non-smoker patient. So that's why we not just look to the wound, we have to examine the patient as a holistic approach from the head to the toe. You have to optimize his medically from the cardiovascular status, nephrology status. You have to correct the albumin, the nutritional status. All this help you to improve your surgical outcome. Vascular evaluation is really important. It's really sad that you see some of the surgeon or doctors, they start with the debridement without examining the patient. Please touch the patient, feel the pulse, feel dorsalis pedis, posterior. If you cannot feel the pulse, do not do debridement. Do Doppler arterial ultrasound or call your colleague for vascular clearance. We've seen patients, they've been doing debridement for 9 months. After 9 months, they woke up and they found the patient have ischemic disease. So where are you for the 9 months? You're keeping cleaning the patient wound until you expose the calcaneus. Oh, I'm scared now, the calcaneus exposed. You know, it's your fault, it's not the patient's fault. You know why? Because you did not examine the patient at the first visit. This is me and my colleague, Dr. Badr Amri. We're planning for the external fixator in Qasim. So, reconstructive ladder, usually we start with the basic. We start with the wound care or primary closure. or secondary intention, and then skin grafting. We have artificial skin grafting, and we have split thickness skin grafting, local flap, regional flap, and then eventually free flap. You know, in order to apply all this in our patient is very hard. That's why patient selection is really important. So we'll start with a local random flap. It's called random because it doesn't depend on a single blood supply. It depends on multiple blood supply, subcutaneous and superficial and fascial blood supplies to supply this type of flap. You resect the wound, the infected wound, and you transplant the normal skin to the defected area. The importance of this, you apply new skin with a good soft tissue and support to prevent the chance of recurrence in this type of patients. Okay, this is one of our case. This patient has, you can see, has a chronic wound here, probe to bone with a chronic osteomyelitis. So this patient has this wound, imagine, for how many years? Any guess? Can you guess how many years the patient has this wound? Or how many months? This patient has this wound for 10 years. Imagine the patient with a 10 years wound. It's a small wound, you know. But I made a statement. Diabetic foot wound is a volcano. You see a small opening, but you don't know what's going on inside. So this patient has a chronic osteomyelitis, failed to heal. So what we did aggressive debridement. We cured the bone. We cleaned the osteomyelitis. We took a bone culture, bone for histopathology, and we did something is called, I made this by myself, it's called happy face or mad face local random flap. Another example of local advancement flap. So this patient was referred from my colleague Saad Al-Faiz from Taif because this patient has this wound for almost 3 years and failed to close. And they recommend him what? What do you think? They told him, you should go for major amputation. So patient had good vascularity. Just because he has Charcot with a failure of wound closure, they advise for major amputation. And this patient has high chance of wound healing. So what we did, we discussed with the patient, medical optimization. We assessed his vascularity. We cleared the patient. We took the patient to the surgery. We did, our colleague talk about the tendo Achilles lengthening, and also we did very simple procedure, exostectomy. We resect the bone, and then we did a local advancement flap, and you can see the progression from August 8th, and the wound closed on December, I think, 6th. So in about a month, we achieved complete wound closure and the patient back to his life. Please remember, once you close these wounds, you have to put the patient in a custom-made insoles and diabetic shoes. Local rotation flap, all these cases was taken from my fellowship director, Dr. Thomas Zagonas. I trained under him, so we do all this type of cases. So here, a local rotational flap. So always I like triangle. When I remove the ulcer, we remove it in triangle, and then we pull the skin to cover the wound. We always use circular external fixator as a surgical offloading to prevent wound complication and flap failure. Local double advancement flap is called double because you're taking from both sides. Always remember, Hani was asking me, my colleague, my assistant, told me why you're using triangle because it's easier for you to achieve wound closure. So it's called local double advancement flap because from both sides and you advancement the flap and you close the wound and you put circular external fixator for surgical offloading. Local intrinsic muscle flaps, we use it if you have not enough skin or you have osteomyelitis. It's well vascularized. It can help you to eradicate the osteomyelitis. In the foot, we have abductor hallucis, abductor digiti minimi, and flexor digitorum muscle. We can use it. I rarely use this type of muscles because most of the time in diabetic patient atrophy, and I'm scared if I remove this muscle, dissect the patient, I will not see a good muscle bulk to cover the wounds. So the most common, abductor hallucis, flexor digitorum, and abductor digiti minimi. This is also from my fellowship director book. So the patient with abduction, Charcot arthropathy with osteomyelitis. So they resect the infected bone and they took the abductor hallucis from the insertion. So they cut from the tendon and they reflect the muscle all the way back to cover the wound. And then you can apply artificial skin graft or split thickness skin graft and negative pressure wound therapy in addition to the circular external fixators. So you correct the osseous deformity and also at the same time you achieve wound closure in one stage surgery. Abductor digit minimi will do the same thing. You can see extend the incision all the way to the insertion and then you cut it from the tendon and you reflect the muscle all the way back to cover any wounds over the lateral malleolus or the base of the fifth metatarsal. Local and distant pedicle flap. This is rarely we use it in our patients, especially in Saudi Arabia, because due to multiple comorbidities, I don't like to use it. Risk of failure is very high. But in some patient, young patient, in selected patient, it gives you a good result, especially when you have a calcaneal wound.
2 minutes.
Okay, I will be on time, inshallah. Okay, reverse flow, sural arterial neurofasciocutaneous flap. As you can see, we did it like 2 times, but most of the time they end up with a superficial necrosis, but eventually they have a good coverage. We see a lot of calcaneal wound. Calcaneal wound, they take long time to heal, and the patient will end up with the osteomyelitis, so that's why we try to close the wound as soon as possible to prevent infection and complications. Take-home message. Stepwise approach using reconstructive ladder in the surgical management of diabetic foot wound is essential for functional limb salvage. So do not jump for free flap without taking the ladder. Start from the wound care, primary closure, secondary intention, skin grafting, local flap, and then you go for the more advanced type of flap. Again, we have to learn from each other. We have to involve our colleague in a multidisciplinary team approach to optimize your surgical outcome. Wound care is good, but in this type of cases will not help you. So you have to consider surgical wound closure for this type of patient with osseous deformity. And this concludes my presentation. And thank you so much. And I hope you enjoy the conference.
Thank you, Dr. Hani. Next, we have Dr. Nishat Ghandura. He's a consultant general surgery and diabetic foot in Jeddah. Yes. Welcome.
السلام عليكم. بسم الله الرحمن الرحيم. الحمد لله رب العالمين والصلاة والسلام على أشرف الأنبياء والمرسلين سيدنا محمد. First, I would like to thank Dr. Hani Dahdah for and his the organizing committee to give me this opportunity to share with you my talk. I will talk about the negative pressure wound therapy application in diabetic foot. Okay, thank you. Enable pointer. Okay. Okay. My objectives will talk about the introduction, mechanism of action of negative pressure, and indication of negative pressure wound therapy, careful selection criteria and application of negative pressure wound therapy, factor contributing to a successful outcome, clinical evidence of the VAC and diabetic foot wounds, and I will share with you many cases I did it with the VAC system management. Negative pressure wound therapy, also called vacuum-assisted closure, refer to the wound dressing system that continuously or intermittent applied as a subatmospheric pressure to the system, which provide a positive pressure to the surface of the wounds. In the history, it was first described by Charker, an experimental technique for treating of subcutaneous fistula, which was in 1989. Then after decades, Argenta and Marikaus allow negative pressure to gain recognition and useful clinical tool for management of complex and difficult wounds like big surgical wounds, trauma, and also diabetic foods wounds. Mechanism of action, negative pressure have multiple actions in the treatment of the wounds. First is improve local blood flow through vasomotor mediators, and also the negative pressure up to the 125s, which is recommended, millimeter mercury is in generally accepted, but we can make it up to 150 in first 48 hours, and after that continuously, but we can use it for follow-up at 125 millimeter mercury with the intermittents, 5 on and 2 off, to achieve a good outcome. In the opposite, that a very high pressure, more than 400 millimeter mercury, this have been shown reduce the overall wound bed vascular flow. So it is not recommended to have high pressure. It's induced macro deformation. Direct macro deformation induced by negative pressure lead to the wound contraction and size reduction. And this is an important mechanism that reduces the large surface area and the large defects in diabetic foot wounds after radical debridements. Also, it induces the granulation and angiogenesis. Granulation is an important clinical sign that indicate a wound healing. Clinical trials in diabetic wounds have also demonstrate negative pressure wound therapy superiority to produce healthy granulation compared to the conventional dressing. Negative pressure wound therapy induce also angiogenesis, new vessels, and which is proliferation of the vessels. Also, it reduces the edema, especially in the infected wound, showing the high level of the exudate, and leads to local soakage and edema of the wounds, and this is prevent or delay the wound healing. By negative pressure wound therapy, this remove the excess of this fluid, and this reduce the edema and also enhance the local blood flow and also flow of the nutrition in the wounds. Continuous outflow also reduce the build-up of the anti-inflammatory mediator, which degrades the adhesion protein necessary for wound repair. It also reduces the bacterial colonization, while the mode of the bacterial clearance is unclear, but negative pressure wound therapy provide a safety barrier that shield the wound from the environmental contaminant. In diabetic wounds, there are a clinical report to suggest of negative pressure wound therapy. That means recent systemic review of bacteria-loaded and the vacuum therapy show equivocal result, which recommendation of the further researches. Where in the indication of the negative pressure wound therapy is indicates in most of the big wounds, but in diabetic foods we recommend it to be in post-debridement of wound with the necrotizing fasciitis. And if there is an foot abscess or with the space occupying lesions or space occupying cavity, I mean, this is a good recommendation for VAC. Infected heels ulcer and exposed bone sometimes is important to start negative pressure wound therapy. There is a careful selection criteria and application of the VAC. In ischemic wounds, it's in case of severe ischemia, it's not recommended to apply VAC, but in early ischemia, after evaluation or after revascularization, it should be used carefully with this kind of ischemia. The wound must be close monitored, and high negative pressure should be avoided in the ischemic cases. Wound must be also at least by, you have to check for his vascularity, as mentioned by Dr. Hani. You have to palpate for the vessels. If it's not palpable, you have to send him for duplex, for angio, until you do revascularization. At that time, you can apply VAC. In severe ischemia, it's not recommended to apply VAC therapy. In neuropathies, it's indicated, but must be assessed appropriately before you put the negative pressure wound therapy. And it is not a contraindication, as I mentioned, but neuropathy is important to predict for ulcer recurrence. Infection, as I said, deep infections such as osteomyelitis, septic arthritis, it's not a contraindicated. You have to do a proper debridements, incision and drainage for abscesses. Then after you clean the wounds, then you can apply the VAC system. Application of the device over the underlying infection are essential to creating an abscess. There is a source must be surgically removed prior to any negative pressure wound therapy. So debridement is important to be done, proper debridement before you apply the negative wound pressure. Okay, factor contributing to successful outcome. Radical debridement before application can be successful when the adequate and proper debridement has been performed to remove the devitalized tissue, necrotic tissue, and infected tissue. Regular monitoring of the wounds. During each change of the wound, a small slough must be removed with side debridements, and also remove the biofilm layers before application of a new dressing. If there is a resistant slough, definitive surgical debridement is needed. Optimizing glycemic control and healing marker. So hemoglobin A1C must be in the normal level to prevent delaying in the wound healing. Stop smoking, also one of the factors affecting the wound healings. And reduction of hemoglobin, it reflects poor tissue oxygenation. Healing will be very poor if the hemoglobin is below 10 gram per deciliter. Optimizing glycemic controls and healing markers like albumins, lymphocytes, creatinine level reflect normal renal function. Renal impairment suggests by raised creatinine level can negatively affecting all aspects of healing and affecting overall treatment outcome. Appropriate antibiotic, which already discussed in this morning, you have to choose the proper antibiotic with the VAC system to take a tissue culture for sensitive organism, and must be administered by help of achieve the reduction in the bacterial load. There is a multiple clinical evidence showing that negative pressure wound therapy is superior than conventional treatments, and all of them supporting this evidence. And in 2005, Armstrong conducted the landmark multi-centric controlled study comparing negative pressure wound therapy with the standard dressing. They demonstrate satisfactorily a significant reduction in the healing time, higher percentage of healed wounds, and reduce the number of the re-amputation in the VAC therapy treated groups. How to apply VAC? I think most of them know how to apply it. Just take clean, or after you clean the wounds, you apply the granular forms in the wounds. Then after that, we apply the blasters, create a small opening in the centers, connected to the canisters, and start, as I mentioned, in the first 48 hours, we start in high pressure, negative pressure, 150, continuous for 48 hours. And then after that, we can reduce it to 125 millimeter mercury, intermittent, 5 on and 2 off, 5 minutes on and 2 off. Now I will show some cases I was using this fact. This is a teacher about 50 years old. He presented with the necrotizing fasciitis in the plantar after debridements. I apply VAC. After 2 weeks, it started to have a good granulation tissue. And I did for him also after wound is clean and good granulation, skin graft after 6 weeks. Then after 10 weeks, patient have complete wound healing with the offloading, of course, in these cases. Number 2, this is a 60 years old male patient who is presented with chronic lower ischemia, intermittent claudication. He did a surgery outside the kingdom and came with necrotic tissue in between the first and second toe and fourth and fifth. After revascularization, femoropopliteal bypass, then the patient having a good vascularity, so we apply VAC in this case and start to have good granulation tissue. Within 6 weeks,
2 minutes.
Within 6 weeks is completely healed, as you can see in the line. This is a case also came from Yemen, female patient with necrotizing fasciitis. Also, she is diabetic ketoacidosis, admitted in ICU in King Fahd Hospital. And she came from Yemen because they said for her just for balloon amputation. And after that, with open book debridements, did in the OR, remove all necrotic tissue reaching to the bones, muscles. Then apply VAC, start to have a healthy granulation tissue. After that, as you can see, this is good granulation. Then I called my colleague, the plastic surgeon. We did for him rotation flap in the wounds, and alhamdulillah, she discharged and went back to the Yemen. Thank you very much.
Thank you, Dr. Nashat. The second speaker was Dr. Islam Fahmi. He is orthopedic and spinal surgeon.
Good afternoon, everyone. The whole day we are talking about Charcot, about diabetes, about ulcers, but my talk is totally different, about trauma patient and diabetic patient, specifically about fracture ankle in diabetic patient. Why we're talking about fracture ankle in diabetic patient? It's a very common, or one of the most common fractures in orthopedic. Usually we have a lot of presentations in fracture ankle, either unimalleolar fracture, bimalleolar fracture, maybe fracture dislocation of the ankle joint. As an orthopedic surgeon, we are directly take the patient to OR, fix the patient, achieve good alignment, like these cases, and after 6 to 8 weeks, end of the story. That's our routine as a trauma patient. But if all these kinds of fixation for fixation of fracture ankle in a trauma patient, this is our normal daily routine life. But here we start our talk. Fracture of the ankle or ankle fractures in diabetic patient is totally different story. Why? Literature showed that the complication rate in diabetic patient who had ankle fracture is much more risk than any other risk factors, like age, gender, BMI, osteoporosis, severity of the fracture, classification of the fracture. Even if the fracture are open or closed, all these risk factors had less complication rate than if the patient is only diabetic. So this is the most important thing to detect if this patient who had an ankle fracture is diabetic or no. why the complication rate associated with ankle fracture in diabetic patient, not only the routine complication of trauma patient like non-union, infection, failure of fixation. We are talking here about the most common complication is transtibial amputation. This patient may develop Charcot neuropathy, not only the routine complication of a usual trauma patient. So if any patient has an ankle fracture and he is diabetic, if this patient develop any kind of complication, the most common complication for this patient will end in transtibial amputation. That's why we need to consider this very much about if the patient who has an ankle fracture has diabetes. Risk factors with ankle fracture. Complication after ankle fracture in diabetic patient range from about 26 to 47 in diabetic patient, but in non-diabetic patient, it's only about 15%. The risk of complication in diabetic patient, he has transtibial amputation after ORIF or open adduction internal fixation of ankle fracture in diabetic patient. Most of diabetic patients who experience ankle fracture, open adduction, and internal fixation, they have higher rate of secondary operation, and the risk of infection and serious surgical complications are higher in these patients. So, as a conclusion of the previous slides, some surgeons found that why we operate them, leave this patient conservative. Do not operate in this patient, just splint them or cast them and avoid the risk of high complication. But literature found that there is higher complication rate if we use a conservative management and fracture ankle in diabetic patient. Why? They will develop Charcot neuropathy, joint destruction, bone loss, deformity, and eventually we will go for amputation again. So if we operate, there is high risk of complication. If we did not operate on this patient, there are higher risk of complication. What to do? Complicated diabetes mellitus. This is the most important thing that we need to diagnose before take this patient to OR. Is this patient diabetic? Second point, is this patient is complicated diabetes or no? That analysis showed that about 12.5% of patients who had a fractured ankle are diabetic, but only 14.6 from this diabetic patient are complicated diabetic patients. So not all diabetic patients have the same risk of complication if we took them for surgery. Why? Many studies showed that the complication rate of non-complicated diabetic patients are equal to non-diabetic patients. So the most important point, if one patient presents to ER and he has a fracture of his ankle, first question to ask him, are you diabetic? It's a very important point. Usually, as an orthopedic doctor, all of us in daily routine, we meet one patient, ER call us, we have a fractured ankle, they show us the X-ray, okay, prepare the patient for OR, fix the patient, then end of the story. But if we miss that this patient is diabetic, it will be the beginning of the story, not the end of the story. So, as we said, we need to be sure that this patient is diabetic or not. So, next step, if this patient is diabetic, is this patient a complicated diabetic patient or he is not complicated diabetic patient? What is the meaning of complicated diabetic patient? If this patient has peripheral neuropathy, has any macro or microvascular disease, reduced immunity response, diabetic nephropathy, diabetic retinopathy, then we should consider this patient complicated diabetes. So before we send the patient for the surgery, we need to take detailed history from the patient. Once the patient presented for us at ER, ask the patient first, are you diabetic? Yes. Do you have any signs or symptoms or any history? We need to take detailed history from the patient about his condition. How we can assess the diabetic patient at ER before we decide how to manage it? First of all, we need to do peripheral examination for the neuropathy. Okay, but this patient has a fracture and the patient is already in severe pain, so maybe it's impractical to try to examine the patient for any peripheral neuropathy. This is our routine in diabetic patient. The second one, to check the peripheral pulse, but still this patient has a fracture. How we can evaluate his dorsalis pedis or tibialis posterior artery pulses in a trauma patient. These two factors, which are the usual factors to detect if this patient is complicated or not, we cannot rely on these kinds of evaluation or assessment. What we can rely on is investigation, laboratory investigation, and the first one is measurement of glycosylated hemoglobin for this patient. If this patient has glycosylated hemoglobin more than 7, so we should consider this patient as complicated patient. The other factor that we can do at routine or at ER to measure transcutaneous percutaneous oxygen BO2. If this patient has BO2 less than 30, so we should consider that this patient is high risk of complication and if we send this patient for surgery. As we said, so all what we can rely on to detect if this patient is complicated, first of all, glycosylated hemoglobin more than 7, and second point is assessment of transcutaneous BO2, and the third point, detailed history from the patient. Before we decide how we will going to manage this patient, we need to multidisciplinary team approach. First of all, we need vascular clearance. Second, we need to be sure to control the glycemic control. Literature found that if this patient, if we could control the glycosylated hemoglobin 1%, there is a reduction in the complication rate by 30%. So the management of ankle fracture in diabetes. If the patient, once we have patient at ER presented with ankle fracture, as we said, we need to check if this patient is diabetic or not. If the patient is not diabetic, we usually take the patient directly for ER and do our job as an orthopedic doctor. If this patient is diabetic, we need to, first of all, diagnose if this patient is controlled or actually uncomplicated diabetic patient. If the patient is uncomplicated diabetic patient, we can manage the patient as the routine diabetic patient. Just fix the patient with rigid, stable, with rigid fixation, either lock the fracture, splint the patient, and prolonged immobilization for 8 weeks. After that, protective weight bearing if the patient is non-complicated. But if the patient is complicated and controlled, we mean complicated and controlled, he is vascular clear, his hemoglobin A1C less than 7%. So now we will prepare the patient for surgical intervention. We will discuss later on the presentation. But if the patient is complicated and uncontrolled diabetic patient, should we prepare the patient for surgery? Should we operate the patient? Please not. If we operate this patient while he is uncontrolled, you may fix the patient and you may achieve good reduction, but this patient will develop very high, have a high risk of complication, and it will end in major amputation. So we have to control his diabetic status before take this patient for OR. How we can control this patient? First of all, if we have a fracture or any ankle fracture and uncontrolled the patient, reduce the fracture. We have to reduce the fracture, then splint the patient, consult your colleague, vascular colleague, for management of peripheral ischemia, internal medicine for glycemic control. This is the first step. We can leave the patient on a splint for 1 week, 2 weeks. Once the patient condition is controlled, then we can take this patient for surgical intervention. But do not take the patient directly for OR and then re-evaluate it. He will develop major complication. How to fix ankle fracture in diabetic patient. Literature found that suboptimal stabilization of ankle fracture in diabetic patient can result in fixation failure and catastrophic complication and may start the process of Charcot neuropathy. The treating surgeon also should bear in mind that the demand of diabetic patient is only limb salvage and maintain this patient ambulatory.
2 minutes left.
Okay. This can be achieved by maximum rigidity to the fracture. Cast application is not rigid enough, it will develop Charcot neuropathy, so we should avoid conservative management. How to fix? Studies showed a higher complication of open reduction and internal fixation with higher revision surgeries. Primary ankle fusion had a lower rate of complication and revision surgery with a higher rate of limb salvage. Primary ankle fusion could be achieved by a retrograde nail or external fixator. Avoid using Billiton screws for ankle fusion as it's associated with higher soft tissue dissection and higher rate of complication. After we fix this patient, we will post-operative rehabilitation. It's better to prolong immobilization and restrict weight bearing for at least 8 weeks. Some literatures support that early mobilization and early weight bearing in a cast or boot may be accepted, but still it's a controversy. Our previous experience with some complicated cases done with Dr. Hani. The first case, this is an example for unrigid fixation failure. He is a male patient, 40 years old, have a fractured ankle. He was managed by ordinary fixations. The patient was diabetic. This patient has a failure. After 2 years, this patient developed failure. And as you see this X-ray, this patient presented with osteomyelitis and failure of the fixation. Patient presented to our clinic. We did removal of the implant, debridement, and we did ankle arthrodesis by Elizarov. Second case, this patient, 52 years old, he has a rigid fixation. They did rigid fixation, the previous surgeon did a rigid fixation with locked plate, but still this patient had experienced failure after 5 months and he has developed Charcot neuropathy. And again, this patient developed osteomyelitis, and we did debridement, implant removal, and back to ankle arthrodesis bar, external fixator, Elizarov. And we could achieve good debridement and good contact bone. Third case, this patient, an example for conservative management. She had a male patient. He has a fracture of ankle fracture dislocations. He was managed by closed reduction and air cast, but this patient developed after 5 months Charcot neuropathy, and again, he presented with us with this condition. So we again took the patient for OR. We did ankle arthrodesis by external fixator. One of this patient, I believe the video is not working. It's an example.
If we can go to the conclusion.
Okay. Conclusion. There is increased risk of surgical complication reported among the diabetic patient with ankle fracture. Non-operative management is inadequate or is not an option for diabetic patient. If we are going to operate on fracture ankle on diabetic patient, we have to go for ankle arthrodesis as a primary procedure or after a failure of initial management with a high successful rate with about 80% of the cases. Thank you.
Thank you. Now, please, the speakers. If any question for the speakers, Dr. Hani Badahdak, Dr. Isam, Dr. Islam, Dr. Abdulaziz, he left already to the airport, and Dr. Nashad.
Any questions?
Thank you. Thanks a lot for this nice orthopedic lecture. Actually, I am dissatisfied regarding the primary arthrodesis. Is it directly primary arthrodesis?
Yes, I know that it's a big debate, and we discussed this one with Dr. Hani, that a lot of orthopedic doctors will not accept the idea of primary arthrodesis in fracture ankle. But yes, we will go for primary ankle arthrodesis if the patient is complicated, whatever the fracture classification, because we know very well this patient has low demand. This is the first point. If any complication happened in this patient will end in transtibial amputation, and you cannot avoid this one. High risk of complication up to 50%. So he's an old patient, low demand, uncontrolled, poor vascular status. Why we want to achieve fixation in this patient? What is your goal? This patient has a high risk of all kind of complication, failure of the implant, infection, delayed union. But if we achieve better fixation or rigid fixation, you end the story from its beginning. We stop the process of Charcot neuropathy, any risk of infection, because usually we are doing this arthrodesis by external fixator. You could achieve good bony contact, you have a good bony stock. So from the beginning, make arthrodesis for this patient, achieve good healing from the beginning before he develop any kind of complication. As we show, and we have a lot of patients like this, after 5 months, 1 year, 2 years, even the first X-ray were perfect. All the X-rays about the reduction, about the usage of implant, looking implant, everything were perfect. But still, this patient developed Charcot neuropathy and failure of the implant. So why don't we, if the patient is high risk, complicated diabetic patient, to go directly from the beginning to do ankle arthrodesis with external fixator, avoid soft tissue dissection, you have a good bone stock, you don't want to go for any osteomyelitis, debridement, any risk, go directly for ankle arthrodesis, and it will be single surgery from the beginning.
What I mean, I want to do X-fix directly at the first time without arthrodesis. The main point we have here, the syndesmosis. Once you get fixation and perfect fixation for syndesmosis, an easy way, no need for arthrodesis, especially if you are controlling
Dr.
everything.
Ahmed, sorry to interrupt you. So as Dr. Islam mentioned, if the patient with control hemoglobin A1C below 7, you treat the patient as non-diabetic with supraconstruct and also long period of immobilization. You don't go for primary arthrodesis.
You mean ORF? Open reduction and internal fixation.
Yes.
The patient is controlled.
I see so many patients with ORF.
No.
They end with osteomyelitis.
But Dr. Islam mentioned a good point and good classification. If the patient with uncontrolled diabetes, with uncontrolled A1C, you go for primary arthrodesis, because if you go for RIF, there is a risk of failure, risk of osteomyelitis and complication, and eventually you will end up with the arthrodesis of the ankle joint. This is evidence-based and per literature. So if it's uncontrolled A1C, if the hemoglobin A1C 8 with a patient with a peripheral neuropathy, you don't go for open reduction internal fixation, you go primary arthrodesis. If the patient without peripheral neuropathy, uncontrolled diabetes, you treat the patient as non-diabetic, but you have to put supraconstruct, longer plate, okay, with more screws, and you keep the patient for long period of immobilization. And then after you remove the cast, you protect the patient in a air cast for another 2 or 3 months until you feel confident, and even that, there is a risk of failure. As we see, one of our patients, after 2 years of open reduction internal fixation, came up with failure and the plate coming out. I hope the idea is clear. And I have a question for Dr. Nashat Ondura. So I was reading literature about the negative pressure wound therapy. It states that after 3 weeks or 4 weeks, there is no benefit of negative pressure wound therapy. But in a practical life, we're using negative pressure wound therapy for 2 months, 3 months, and 4 months, and we see the results. But I don't know why this literature says after 3 weeks, you lose the benefits of negative pressure wound therapy. Any comment?
It's unclear, but I agree with them that if we keep the wound negative pressures wound therapy more than, the recommendation from 3 to 4 weeks. If it is, we keep it for 1 or more, 5 weeks, or for example, in some cases, you cannot see the progression is as when you apply it in the first week. Yeah, the progression is minimal or sometimes is static. There is no more progression. So I don't know about this. Maybe there is some, I don't know. But I agree with them for regarding not to use it more than 4 weeks.
If I can just add to that, from what I've had from experience is, as long as there is improvement from the wound in negative pressure, especially when we're dealing with large skin defects such as post-necrotizing fasciitis, as long as you're not stagnant, I think it's a clinical judgment to keep going. But if it does go into stagnation, as the doctor said, yeah, there's no benefit after that.
Okay, any questions? Can we close? Before we close, we have something for you guys, and then we need to take Surah Jama'iyya for everybody. And thank you for you guys. Your presence is a corner of our success in this conference. Thank you for our speaker. Thank you for the companies. And I hope this is beginning in a diabetic food service in our country and the Gulf region. Thank you so much. الصورة هنا بس أول شيء. Can you remove that? تفضل. بس نشغل.